Hello, everyone. Hello, everyone. I can't whistle. I can clap. Hi, everyone. Maria McGrath. Maria McGrath. Are you going to be mad at me later? Sorry. Everyone, welcome. Welcome to Canmore. This is the Three Sisters. They're well known in Canmore as the Three Sisters. And we chose this location actually because of Donald Houston, wherever he might be sitting. I don't see him around. Maybe he's around a pillar. Oh, there he is. And he said if we're going to get together after 2 years, it better be somewhere nice. So that's why we're here today, after his good advice. It is a little tricky getting here, so I'm really glad to see all your beautiful faces. We have a great day planned, I think. The real key around it, and we'll go over the objective, is really to look at trying to meet some equity for our patients and really get available resources to our patients and delivered properly for our patients. And I had a lot of help, I must say, from Dr. Simpson, because she is an EDI expert and has helped facilitate that piece of the conference and really bringing that together. So we'll bring in really some strong medical pieces with CBS's here in force, which thank you to our colleagues, and try to bring that in as well. But there's a lot of EDI things that come up with CBS in terms of donors, rare blood supplies, all of those things that really mean a lot to our patients and their survival and wellness. So welcome. So this is our objective. It's really to promote discussion around healthcare equity for hemoglobinopathy patients. So we're really trying to do that at this conference. That means everything from access to medications, access to safe blood supply for this particular patient population, access to social work resources, all of the things that people need to thrive that are often given to other medical patients and not necessarily our medical patients. So it's about really the equity in resource allocation that we see in Canada. Housekeeping, there's a lot of housekeeping here and I'll probably forget many points. Coffee will stay here, really importantly, but they'll leave the fruits and some of the snacks out at the table. So if you are needing a little pick-me-up or a refresher, you can always just go out. We're going to try to stay on time, might not happen. We have a hybrid format. We are trying very hard to have a hybrid format. And what that truly means is that there is a live audience right now and a virtual audience. We will have 2 moderators for every event. If you speak a question loud from the floor, the live audience moderator will repeat that question back or paraphrase it into the microphone so that then the virtual audience can hear. The questions coming in through the chat box through the virtual audience will be read aloud to the live audience so that we can hear. We have a real mix of presenters, some in person, some virtual, and we will try to hopefully make that flow as well as we can. We're up in beautiful Canmore and it's a small town. So we are working our best with these sorts of things. Bathrooms are out and to the right. What else do I need to talk to you guys about the event? I think that's really it. I'm really super happy that everybody was able to make it. And if you have any challenges, oh yes, other housekeeping. The gentleman in the back is named Rob. He has all your answers. There is another man out in the hallway by the name of Rob. So you can just randomly use the name Rob and you'll probably be right. And they are here to help and facilitate things. Stephen is our producer, and he's got his headphones on right now. So if there's tech glitches or issues that you come up with that you need help with, he's your man. And that's about it. Evaluations. We have our agenda, but in your packages are evaluations for the day. It's super important for us to bring together, form good conferences, form better conferences the next year, or improve upon things and keep things that you thought were really valuable. And that is really it. I am going to hand it over to Dr. Simpson and Dr. Verhosek. Really to, where did Dr. Simpson go? Oh, there she is. Like it's a bigger room today. To introduce Dr. Fasipe, our keynote speaker. I think that's the end of my slides for today. Yeah. Oh, they have it right here. Okay, perfect. Oh, okay, sure, okay. Well, good morning, everyone. Oh, no. That won't land well.
We can ask where everybody's from, where everybody traveled from.
Great.
So, good morning, everyone. You heard just as we did that we've got an extra minute here. So this is awesome. We were in this room last night. The nurses had a separate thing happening behind that wall there, so I didn't see how many were in there. Does anybody know how many nurses were gathered there last night?
We had 11 nurses and 1 social worker.
Okay, fantastic. And then I think many of you must have arrived later yesterday or even this morning, so it's fantastic to see a full room. I'm thinking just to do like a roll call of where everybody's traveled from. I'm imagining that there are a lot of folks who have come from Alberta. Amazing. And BC? Fantastic. I know we've also got folks from Saskatchewan. Excellent. And Manitoba, got representation across the board. Folks from Ontario, I guess I'll put up my hand too. Quebec, excellent. And I don't know, do we have anyone from New Brunswick or PEI? Maybe not. But no, I'm getting there. Nova Scotia, yeah, Nova Scotia. I'm going across, yeah. Nova Scotia, and anyone from Newfoundland? No, so you guys are really carrying a heavy, not a heavy, an important, a strong responsibility for all of the Maritimes. So that's fantastic. And anyone who's here not from Canada? Okay, folks at the back. Fantastic. So I won't put you on the spot, I don't think, beyond that, but really fantastic to have representation from coast to coast, and as we tackle some very important topics today.
Thank you, Noah, and it's really nice to see all your faces in person because it's really long overdue. So thank you to Aisha and everyone who made this possible for us all to be here gathered, because our fellowship and connection has been such an important part of CanHaem. So it's really nice that we could all be together. And so I have the privilege of introducing our keynote speaker. So Dr. Titilope Fasipe is co-director of the Texas Children's Sickle Cell and Thalassemia Program, and she's also assistant professor in pediatrics in hematology-oncology at Baylor College of Medicine in Houston, Texas. She's passionate about public health strategies to curb the psychosocial barriers and health complications of individuals with sickle cell disease. She's actively involved in various sickle cell-focused community and policy efforts aimed at understanding and addressing these challenges. Dr. Fasipe has been repeatedly appointed to sickle cell-related advisory committees of the Texas Department of State Health Services and currently serves on their Newborn Screening Advisory Committee and chairs the Sickle Cell Task Force. Her professional memberships include the American Academy of Pediatrics, the Heartland Southwest Sickle Cell Disease Network, the American Society of Hematology, where she serves on the Quality Measure Oversight Subcommittee, as well as the Technical Expert Panel for the Sickle Cell Disease Quality Measures, and the American Society of Pediatric Hematology Oncology, where she's the current chair of the Hemoglobinopathy Special Interest Group. Dr. Fasipe has a unique perspective of relating to and understanding the need for education, community awareness, support, and medical care, as she is a pediatric hematologist as well as an individual with sickle cell disease. So we're very honored to have had her present, and so her presentation's pre-recorded, but she'll be joining us live for a Q&A after the presentation.
still brushing off the cobwebs. You know what? I'm sitting here very guiltily realizing that I missed the entire north of Canada. So the territories. So is there anybody from Yukon, Northwest Territories, Nunavut? It's like, oh my goodness. Typical Southerner, right? Forgetting that there's a whole nother huge geography up there. So apologies if I missed anybody. Looks like we might be all set.
Okay, great. Okay.
For inviting me here today. This is such a great honor for me. The title of my talk is Sickle Cell Advocacy and Health Policy, Historical Perspectives and Current Opportunities. First, I'd like to get my disclosures out of the way. I have been involved in either educating or other types of review work for some industry partners, including getting grant funding. None of them are relevant, and they're all since completed. I don't make money off of any drugs, but I wanted to bring them up because I will mention the drugs in a slide very briefly, as well as mention some advocacy work. And then my most important disclosure to me is the fact that I'm a sickle cell warrior and I'm a physician advocate. And I feel like those two parts of myself, line, color, flavor, everything I say and do. I also want to acknowledge two individuals. I'm sure many of you, if not all of you, recognize them. Dr. Isaac Odame, as well as Mrs. Lamre Tunji Ajayi. They have been so kind to me. First, they serve as role models in the space of sickle cell advocacy, but then they've also taught me a lot about the Canadian experience in regards to advocacy with sickle cell. And I've learned that I basically don't know anything about the Canadian journey. And, but I am a beginning learner, and I hope all of you who are here will also continue on that learning journey. But I did want to say thank you to them, and I hope that I can continue to learn from them. So over here in the United States, we are celebrating Sickle Cell Awareness Month. And, whenever you have an awareness month, people try to find any celebrity you can find, right? That highlights the disease or the issue. And so some of you might be aware of these people, but if you're not, T-Boz from TLC, she's in the middle. She has sickle cell disease and has been vocal about her experience. And some of the greats of our musical world have also been impacted by sickle cell disease, including Paul Williams of the Temptations, Georgiana Tillman of the Marvelettes, the rapper Prodigy, he's part of a group called Mobb Deep, and then Miles Davis. Many people didn't realize that he also was impacted by sickle cell disease. I'm happy that I don't have to only show their faces all the time, as lovely as they are. It always just seems so distant, I should say, and far away. In today's world of celebrities, you have people like Dexter Darden, who acted in the movies, the Maze Runner series, as well as a professional basketball star, Billy Garrett Jr. But now everyday individuals are their own version of celebrity, sharing their stories and being advocates. I gave you a snapshot of 3 series that were done of individuals impacted or working in the sickle cell disease space. So the Centers for Disease Control and Prevention have a sickle cell stories, NIH has Faces of Sickle Cell, and the New York Times did a beautiful review as well called Patient Voices, featuring several individuals with sickle cell. And last, I'll share that I was excited to hear that Disney wants to get in the sickle cell space by way of Miss Marseille Martin. She's the lady on the left. She is actually one of the stars of Blackish, as well as other several movies. But she's a producer too, as young as she is. And her first television show will actually be a story on a girl with sickle cell disease who loves to skate. And I'm excited to see what this looks like. We're waiting anxiously for this pilot. So that's my sickle cell awareness month shout outs. Let's start with our actual talk today. The objectives are listed on the screen. We're going to summarize the negative effects of systemic racism on disease populations, specifically sickle cell disease, and describe the impact of health policy on patient outcomes, such as children with sickle cell disease, identify the advocacy role that healthcare providers can play, and then implement strategies to advance advocacy efforts that include involvement at the national and local levels. So let's start at the very, very beginning. Before we heard of maternal mortality in Black women being significantly higher, and also Native women, than Caucasian women, before we heard of COVID disparities, where Black and Native and other minorities were impacted disproportionately by COVID-19 and the mortality associated with it, sickle cell was there at the beginning. It was the first disparity and continues to be a long-standing disparity. I see it as the medical representation of the Black experience in America. And I think it's very important to let that sink in. When you think of any of the healthcare outcomes we describe in our country today, you'll notice that minorities are always disproportionately affected. And sickle cell just highlights that with such almost like an exclamation point multiple times. So how does one solve a problem like sickle cell disease? Well, we know it's a blood cell disorder. We know it impacts hemoglobin. But if you only focus on that component of the disorder, you miss the boat. If you don't focus on the historical neglect that has impacted the disease for centuries, if you don't focus on the fact that most of the individuals with the disease do not have access to high quality care, if you don't emphasize the fact that stigma and racism play a upfront and center role in the disease process, as well as the fact that there still remains decreased community awareness, then you are not really going to be able to solve a problem like sickle cell. And so by calling the problem what it is, or by redefining the problem, that is crucial. And I love this work by Hertz Nazaire. It's my favorite piece of his, and it's called 10 Redefined. Now, in the medical community, we describe the pain scale from 0 to 10, 10 being the worst severe pain anybody could imagine. Well, I like the fact that he called this 10 Redefined. This is more than thinking about pain on a pain scale, a biological disorder. This is about all of those other systemic injustices. And so that is the beginning of us solving the problem, is actually stating the problem as it is. So let's give some historical perspective. Now, here's a disclaimer. You can already see that this timeline is not to scale. So I apologize for any of the timeline experts or people with rulers in the audience today. So this is just for artistic representation, let's say. And I'm not going to be able to talk about everything that you'll see on these timelines, but I just wanted to give you a taste of some of the things I've learned about the history of sickle cell disease. And it actually starts as far back as King Tut. I won't be able to go into this today, but I would like all of you to look up later King Tut and sickle cell. And there is this very nice rebuttal talking about King Tut not having some bone disorder, but potentially having sickle cell disease, evidenced by the fact that he died prematurely compared to his parents, and he was found with a walking stick, as well as several bony complications on his body when they found his mummy. So look that up, you'll see. And I'm on the team that believes he probably had sickle cell disease. Well, we will touch on some of these other historical points, but let's move forward in our timeline, where we see where sickle cell got its name, named after a farming instrument. How quaint. And then you have your malaria hypothesis there, as well as the role of fetal hemoglobin. And then, of course, the importance of understanding what happens when there's deoxygenation. So these were all highlights through the time periods of scientists learning more about sickle cell disease. But what about the people that sickle cell impacted? Well, we didn't see much change into that regard until the 1970s, when you saw the first sickle cell legislation, as well as sickle cell organizations come to fruition. And then newborn screening started in the United States for the first time in 1975, New York being the first state. But I will tell you, it was not until 2006 that all 50 states had newborn screening. So America now has universal newborn screening. And I learned that Canada is still not there yet. And I hope that's something that changes soon. So we are now in the 2020s generation. This timeline is now the here and now, and where are we going to contribute to this story? That remains to be seen, but it's definitely up to us. So going to that initial phase, the origin story of sickle cell disease, I remember in 2018 reading an article by the New York Times called "How One Child's Sickle Cell Mutation Helped Protect the World from Malaria." And just as beautiful as that title sounds, the story went on to read almost like an action hero story. You have this child that was born in the Sahara, and back then the Sahara was not a desert. It was actually almost like a tropical paradise with water, greenery, and of course mosquitoes and malaria. And one child was born who was able to be protected from malaria because he had a superpower. That superpower was sickle cell trait, and it allowed this child and the future generations that followed, who inherited that same mutation, to be protected of sorts from malaria. Now, there was a twist to this story, a paradoxical component to it. The same protection that we were trying to impact the red blood cells, keeping them from dying from malaria, if you got 2 copies of this superpower, you ended up destroying your cells in another way with sickle cell disease. And so I know when we tell that story, it sounds almost romantic, like a story in a book, but it has enormous repercussions. And I will say that the New York Times was actually expressing the work of Drs. Charles Rotimi and Daniel Schreiner. They discovered, and they are postulating, that all the various haplotypes of sickle cell disease come from one single mutation, one single ancestor, the so-called lethal advantage. And now we know that those ancestors have, for now centuries, populated various parts of our globe, of course, predominantly in sub-Saharan Africa and India, but we now have sickle cell everywhere around the world. And I will say, I was born in Nigeria, and so that's why part of my perspective comes from there. And now I'm in the United States, and the total population of the United States actually equals the number of babies born every year in Nigeria with sickle cell disease. It's pretty powerful to think about that. And this work that was published in 2013 actually postulates that in 2050, all of these numbers will be much more. Now, this is the main discussion that I'll have on the global experience. Most of the rest of the talk will focus on the United States, but we must never forget where most of the individuals impacted by this disease live, and we must also work to make sure that the disparities there are also improved. So how did sickle cell arrive to the Americas? Well, initially through the transatlantic slave trade. So I was able to go to Ghana in 2014, and I took that picture at the top of the Cape Coast slave castle, and I was able to see the area where they kept the slaves in preparing to ship them off to the Americas. And when they were being shipped off, they brought their culture with them, and they also brought that genetic mutation of sickle cell disease. And in fact, though we credit 1910 being the first discovery of sickle cell disease, many people allude to this paper that was published in the Lancet in 1843, discussing a runaway slave who was caught and killed. And when they did his autopsy, they saw he was missing a spleen. They also saw he had multiple almost deformities that were representative of the sickle cell complications. And so many individuals in the healthcare world believe that this is actually the first evidence of sickle cell disease documented in the Americas. Now, the last thing I'll say about Africa is that we got the name of sickle cell correct. Sickle cell requires a name that emphasizes the pain and suffering that it brings. Unfortunately, it was named after a farming instrument, as I mentioned, which has nothing to do with what the disease does to the body. But you'll notice the terms for sickle cell in African countries either refer to the body chewing or the body biting, again, that excruciating pain, or it mimics the cries and moans of those affected. And in my country, there's actually myths and superstitions that highlight that inheritance pattern. The Obanje traditions, as well as Abiku, children who come and go, basically wondering why their children are dying, coming back and dying again, affected by the same thing. So I wish we had the power to change the name. You know, sickle cell is part of the history, but just keep in mind that when you think of sickle cell, you should think of that pain and suffering that the individuals feel. So the person who gets credited to discovering sickle cell, the people that get credited include Dr. James Herrick and Dr. Ernest Edward Irons. And at the time, and I'm not going to go into depth in this story, but they took care of a gentleman named Walter Clement Noel, who actually came from the West Indies. He was from not from the United States, and that's another disparity I want to highlight. The first description actually was not in a person who lived in the country, but a person who was visiting, coming to school. He was an educated gentleman. And in fact, they were surprised by this, and it's highlighted in their paper, the freakish poikilocytosis in a patient that was an intelligent Negro, as they called it. And it's because this gentleman likely spoke the Queen's English, and he was going to dental school. And so you see the pictures that they have of his cells, and so that's why that is the credit that we give. So one person's dream, the dream to study dentistry to go help his country, led to another's discovery. And it's interesting that he eventually was able to go back to his home country and serve. Unfortunately, he did die prematurely, but we all remember Walter Clement Noel and his contributions in this area, as well as the doctors who treated him. Another scientific highlight was that of Linus Pauling. He was the scientist that discovered that molecular component of sickle cell and helping us understand that area. But even him you saw the implication of his biases reflected in his work. In fact, there's a quote that many of you may know from him that said, "I have suggested that there should be tattooed on the forehead of every young person a symbol showing possession of the sickle cell gene. or whatever other similar gene. If this were done, 2 young people carrying the same seriously defective gene in a single dose would recognize the situation at first sight and would refrain from falling in love with one another. And he said that in 1968. And you know, it's just to show how sickle cell has this invisible component. The disease was exciting, it was in blood, easy to study, so many scientific advances, but the recognition of the individuals as humans was not really present in the society for several years. But then how did that change, or how was the beginning of that change? So in the 1970s, so right off during the boat of our Jim Crow era in America, you saw advocacy groups such as the Black Panther Party recognizing sickle cell as a problem. And they actually set up testing sites for sickle cell education, conferences to teach people in their communities about sickle cell disease and the genetic inheritance. You also saw doctors such as Dr. Charles Whitten, as well as Dr. Marilyn Gaston and others, start to tell the story of sickle cell and the humans affected by them. And so they represent this advocacy voice that was loud enough that it finally got to the president's ear. And in 1972, President Nixon, no less, signed the National Sickle Cell Anemia Control Act. And in his words, it was to reverse the record of neglect. Since that time, we've had 2 other sickle cell acts, and we're working on a few more right now. We have one from 2003 and then one from 2018. And we hope more will be passed. With every one passed, we have a little bit more success. Here is a version of an advocacy timeline, and I wanted to highlight it because even with the sickle cell acts, there were still key concerns in the community space of why are we not able to solve this problem of sickle cell? For goodness sake, why? And you would see various summits being held, various discussions, calls to action. And I saw each of these summits and calls to action as almost waves of change moments to move us forward to where we are today. And I feel like the current wave that we're in, and I would say, I give credit to 2015, some might go a little bit further back, but definitely was in the 2000s. That current wave of change moment has now been a wave that has not dissipated, and it is staying up, and I hope it continues to rise. I put the red star there to highlight Canada's journey as well, because I believe it was in the early 2000s that your advocacy journey really took flight as well. And so we can do this. We are having the right voice, and working together, we can make things better for sickle cell. Now, advocacy in medicine is not strange. You know, we pediatricians, we advocate for healthcare access for children, immigrant child health, gun violence prevention, to name a few. And so it's our role as physicians to place some version of advocacy for our families, the patients that we serve, and the community. And it looks different depending on who we are and our skill set. How can an individual physician or provider advocate? Well, the easy, lazy way, is not just lazy, excuse me, but easiest way is to just click the button on the email that you get from your specialty physician organization. So whether it's your pediatric group, your sickle cell group, your hematology group, there might be some legislation being passed, and they will help you by making the template of the letter. And of course, if you support what they are advocating for, you can add your name and it'll get electronically sent to the place that it needs to go. And I feel like, though that sounds very simple, it's important and a good way for busy healthcare providers. And so I see it as a very effective way. Some of you that are on social media can do the same thing by tweeting and or putting on Facebook the same thing. So sometimes it's very simple, and using technology can help you. Going a step further, you can also testify by telling your story. And that doesn't mean you have to be impacted by the disease, but you are an expert because you care for individuals with the disease. So whether that's a verbal or written testimony, you can do that at the legislative circles and in other spaces. Some people have gone as far as to write op-eds, policy briefs. So you can do this as a physician, and it can, and for me, I feel like it's now a crucial component of my job, but even if it's a small role, you can advocate at any step. I'm going to briefly tell you a little bit of my background and how I got into advocacy, because I have an MD PhD, as you saw. I was in the lab. I did not know anything about advocacy or public health or that kind of thing, but I did live it, if for will. First of all, my name, Titilokbe, means forever grateful. And I have to start there because I know that I've been blessed, and I know that I credit that to the individuals that have been placed in my life, my parents, the various physicians that have cared for me, and all the people who have mentored me along the way. So I was born in 1981, and around the time of my first birthday, I started having pain, and my own pain and suffering that my parents witnessed. They took me to the hospital, and this is in Nigeria, and they were told that their daughter had sickle cell disease. Now, Nigeria does not have newborn screening for sickle cell disease. They're working on it, but at that time, it wasn't something that was done. And so they were devastated. They were told to take me home and take good care of me. There wasn't much that was being done for sickle cell at that time. Fast forward, and about a year later, we migrated to the United States for my parents' education. And they took me to the first children's hospital, and that hospital told them the same thing that the Nigerian doctors told them. Take your daughter home and take good care of her. There's not really much that you can do for sickle cell disease. And so that, my 80s lifestyle, but I was almost behind some of these innovations that we now take for granted for things that we can do for children. So I was, in some ways, a regular, happy, normal child, but you saw the impact of the disease by my size. I was definitely a very small child. My stomach was impacted by splenic sequestration, so it would be bigger than most of the children. And I had the experience of being isolated because I did not know anybody else with the disease. I had 3 siblings that were born after me, and none of them had the disease. And so I had this situation where it was just my existence. I didn't know anything else. Fast forward to, I was 11 years old, and our parents take us back to Nigeria. And then the story was different. I met several people with sickle cell disease. They went to church with me, school with me. They were even in my own family. And so I will say that meeting my cousin with sickle cell was life-changing for me in 2 ways. One, I had a role model. She was older than me. And 2, she was also just full of life and vibrant. She gave me hope. So you can imagine how devastated I was when this young lady passed away at the age of 17. And it appeared to be because of acute chest syndrome. I don't think I'll ever know, but I was determined then that we have to do something to keep sickle cell from making people die prematurely. I kind of blamed it all on the fact that it was Nigeria. I didn't realize that America had a lot of struggles with also healthcare disparities with sickle cell disease. So I came back to the United States during the end of my secondary education, and got into college, medical school, and this is a picture of me and my parents in my medical school graduation. And I realized then that sickle cell was not something that was considered a good disease. It was an ugly disease, if you will. And coming from Nigeria during my formative years, I didn't have any shame associated with sickle cell, really. I had no problem telling people I had it. But that first year of medical school, I started to become silent because I realized people didn't like sickle cell. They said negative things about the people who had it, including the terms drug seekers, including saying that I would never be happy doing a career that involved sickle cell disease. Some of these people did not know I had it when they told me things like that. But I was very disheartened. And then in my clinical rotations, I met my first adult patient with sickle cell, and I was just mind-boggled by how she was treated and how she was not believed. And I just didn't understand this component of the medicine that we were practicing. Why was her health why wasn't she getting the best quality of care in her situation? Why couldn't people believe her? What was the disconnect there? I wanted to learn more, and I made that my mission. So after medical graduation, I was like, I learned the medical side, the biology of sickle cell. I wanted to learn that social side, that historical side. And that led me on this advocacy journey. I said that there's two sides of awareness, because the awareness that sickle cell was ugly brought a shame and silence to me. I stopped telling people I had sickle cell disease. I was very quiet about it. And it wasn't until I met other individuals with sickle cell disease, other advocates, they inspired me. They were brave, they shared their stories with passion. And I realized that there's another awareness that can happen from meeting others that are sharing the same journey. And that awareness brings strength. That awareness brings dignity. And that awareness brings beauty. And then I became brave again. And starting in 2018, 2019, I started looking for ways to discuss sickle cell disease and to share my story. I ended up getting more training about sickle cell disease. For those who recognize the Texas Capitol, that's me and some individuals there, as well as some other things I've been proud to be a part of. And so I now proudly consider myself a physician advocate, and I want sickle cell to be seen not as ugly, but as the true face of it. If you're interested, some of my educations, I have my medical books, but then the education that I felt really prepared me for understanding the historical component, many of them were books written by Professor Keith Wailu, but then also I have some other books here that may be of interest to you in learning about sickle cell. What is the impact of advocacy? Well, this was the other component of my education. I saw that in America, with all those winds of change moments, every aspect of the healthcare system suddenly had a part to play in improving outcomes for sickle cell. And I apologize for all the acronyms and the alphabet soup. You don't need to learn them, but just know that they represent various components of our healthcare system, grant funding mechanisms, and organizations dedicated to the health of individuals in this country, in America. And so I'll highlight a few of them in my next few slides. Because of this, we now have guidelines. So in 1910, you have your first patient documented with the disease, but it wasn't until 2014 that we have our first evidence-based guideline. And then you'll see that there's other things that started that helped with guidance. In regard, our HRSA group started the Sickle Cell Treatment Demonstration Program. We have a quality, and our insurance, National Insurance Service published a pediatric quality measure. The American Society of Hematology just recently published 5 guidelines for sickle cell disease to accompany the NIH guidelines from 2014. And then one of the documents that I consider very groundbreaking was the National Academies of Science, Engineering, and Medicine's Sickle Cell Disease Report and Blueprint. So this is moving us forward. Highlight what happened with the American Society of Hematology, and I'll end on this in a few slides forward. You see that they investigated every single area of what was wrong with sickle cell, and they started investing in those different components in various ways. The Centers for Disease Control and Prevention, they have been the light in regards to sickle cell surveillance. And though we only have a few states that are actively tracking sickle cell, we hope to eventually expand this to all 50 states one day. Texas is not yet part of that list, and I'm working hard with others to try to get it there. The Food and Drug Administration in the 1980s passed an Orphan Drug Act, and orphan drugs are drugs that are for diseases that impact less than 200,000 individuals in the country. And so sickle cell met that criteria. And so now if an industry wants to do a drug for sickle cell or another rare disease, they're able to have a fast track process, and they're incentivized to do so. So hydroxyurea, that was all by itself in 1990, since 1998. Now, some of you may know that we have 3 additional drugs. And here they are, again, just a brief slide to show you that there are 4 disease-modifying drugs for sickle cell currently. The Health Resources and Service Administration, or HRSA, they focus on access to care. And so their sickle cell treatment demonstration program has been a regional effort to try to improve outcomes in sickle cell care. And in the early days, this is what their group looked like. I put a star at the top one because now Texas is part of that Heartland group. They call it Heartland Southwest, and a few other states as well. So this is something that we're also trying to expand to impact all 50 states. And then NIH, who had long been involved in sickle cell research, has recently taken this Cure Sickle Cell initiative to the next level. And they've brought patient families and advocates to the table of the research components of curing sickle cell disease. And this represents a kind of change in the pattern of thinking for sickle cell. Whether, this is one example, whether you're an industry company making drugs for sickle cell disease, whether you're a government agency, whether you're a hospital doing your best for sickle cell, if you don't invite families and patients who are impacted to the table, again, you might miss the boat. You need to really redefine the problem by bringing the experts to the table. And so that's an example of that. One of our other funding, nonprofit funding agencies named PCORI had several grants related to sickle cell disease. And I just listed a few there. And then I have this slide called Monitoring the Monitors. And I have a picture from one of my favorite movies, Enemy of the State. So this concept of stewardship and economy and all of that is important when it comes to healthcare and cost. I think very much so in the United States, where our healthcare system is very, very expensive. And so there's a group that prides themselves in being the watchdog of those costs. They're named ICER. And they recently looked at several blood disorders, hemophilia A, beta thalassemia, and sickle cell disease, as well as other rare disorders. And they were doing an assessment of the current treatment drugs available and whether they were priced appropriately, whatever that means. And that is good. They're not, they're the only group that exists like themselves. It's important to do that economic review, but you have to understand the disease when you're doing that economic review. So on the other hand, you have this other group named PIPC, which was like, wait, some of your practices, though you're intending them for good, they end up being discriminatory because you don't understand the true impact of the disease. And so it's important that even when you think you have an accountable measure, that you don't inadvertently cause even more disparity with it. So how do you responsibly be accountable as well as balance the fact that you're dealing with a disparity? And then again, the only other slide on industry that I'll say is that you need to bring industry to task too. They need to join the advocacy space, and a few of them have. These are some examples. But the goal is, again, you're making a drug for sickle cell disease, you need to bring them to the table, and you need to support the community in any way that you can. And so here's some examples, either through grants or summits or councils to help. So recently, we've had a few more legislative wins for sickle cell that will continue to help that wave rise. And so NIH got more funding for COVID, as well as which we find would be helpful for sickle cell and all diseases. The CDC ended up getting more money to increase the number of states that are being part of their surveillance program, as well as making sure that they can distribute COVID vaccines. And then HRSA, their sickle cell treatment demonstration program, also got increased money. And there are a few more acts in the works right now that are waiting to be heard, and we are going to advocate for them because we can't stop. We have to continue moving forward. You don't have to be a law expert or a policy expert, trust me, because I barely know how a bill becomes a law. It's still something, I have to put that picture to remind me, still something I'm learning. But you can, again, be that voice that explains from your experience what is happening with the patients impacted by the disease. So I want to share a few things that are happening in my state. Consider Texas my American home state. And this is what's going on over here. So first, when you look at the United States of America, in 2010, the best numbers we have tell us that Texas has the third largest sickle cell population. And in that, the area where I serve and live right now has the most babies born with the disease based off of newborn screen. Now, you can see from the map that there's several rural areas in Texas, but everybody is impacted by sickle cell disease. Even the one that says 0 is just that they rounded, but there's still a tiny percentage. And so when we think of Texas, we think of the urban component as well as that rural component. And we also have a very diverse sickle cell population. I think normally people quote 90% Black, 10% other, or some version of that. But with us, our number is higher because we have people from all over the world, and anybody can be impacted by sickle cell disease. Anybody can be impacted by sickle cell disease. Other things that you'll see is that the utilization and the clinics that are serving sickle cell are, of course, typically based at either an academic center or a very busy urban center. And so you can see that based on these maps, as well as this utilization hospital map as well. Most of those big urban areas, including the Houston area and the Dallas area, have a lot of utilization for sickle cell. Now, I can't tell you the details of that utilization. I also can't tell you how people die, when they die. We just don't have good ways of tracking that data. This is another reason why I think we need to join the CDC initiative to help us be more accountable to the population that we're serving and look for the areas that are of high need, priority areas. So Texas's journey took a turn. So again, the waves of change, it finally hit us in 2016 with the development of a sickle cell advisory committee. And that was the first of its kind for Texas. And that committee was only supposed to last for 2 years. So the committee members were smart. They were like, how do we last longer than 2 years? They submitted a recommendation and a final report. And in the report, the first thing was, please start a sickle cell task force to continue to address the issues associated with sickle cell disease. Well, that led to 2 different initiatives. One, the Newborn Screening Advisory Committee, which was a long-standing committee, added 2 sickle cell related members. And I put 2021 there as an end date, but actually they are now official long-term members of the committee, so they will continue to serve. And then the Sickle Cell Task Force, which started in 2019, but also extends beyond the 2021 time span. And they have been working to continue the recommendations from the Sickle Cell Advisory Committee. And it's been, I'm privileged to have been part of all 3 of these. And it's been so wonderful to see actively how health policy can impact healthcare. And we're learning, we're trying to get ourselves to a space where we can, again, have that high level of stewardship to the families that are impacted by this disease. And so that work from the committee led to legislators creating various legislation. And on one particular year, this was 2019, there was the success of having 4 sickle cell bills make it all the way through and become laws. All of these are active. One of them was added to another bill, but we are so happy that the task force was created into law, as well as an opioid exemption act as well, which was very important. So locally, where I stay in the hospital that I work, we do several things for our families. We have a Sickle Cell Education and Research Day, as well as World Sickle Cell Day ceremonies. And so, you know, every bit counts. You want families to know that sickle cell matters. These are snapshots from our various events. And I mean, it's beautiful to see. And many individuals don't meet other people with sickle cell disease, like how I experienced as a child, until they come to events like this, go to camps and the like. So it's very important to make sure that individuals see others with sickle cell disease, as well as learn from them, and even meet people who are older. This lady is a very dear friend of mine who she is considered like, you know, a role model in the sickle cell community space. And I think it's healing for the parents and the children to see that, hey, wow, she is there, you know, living her life, doing her best thing. We also bring young adults and have transition panels to show them that there's life beyond that success that we talk about in pediatrics. but that in their adult years, though we do anticipate challenges, they will be able to make it, and that there's others working and doing the fight with them. And then allowing the individual patients to speak for themselves. There's a blog that we have, and these are a few of the stories that feature individuals with sickle cell, and they're able to share their stories and their journeys. And it's another version of advocacy for themselves. And then you're able to take these stories and allow it to be amplified. So we started discussing the question, how do you solve a problem like sickle cell? And we know we have to redefine the problem and continue to redefine the problem. And we need to count ourselves accountable. We need to give ourselves a grade. And I think that helps us see how far we have to go. So back in 2016, so after the 2015, one of those calls of action, there was a report card that was made, and it was called State of Sickle Cell Disease. So the 2016 report gave several ratings, and every 2 years they try to update those ratings. So what you're seeing is the 2020 ratings now. But 2016, if you look closely, those are some low scores. And I was happy. I was happy because people were calling the truth. They were, calling a spade a spade. It's okay if your score is low. It just shows you that you have a beginning point and where to go from there. You can see that the 2018 and the 2020 scores have since grown. And we should evaluate these in truth. I don't know if everybody would give us a 6.2, but the goal is bring everyone to the table, the stakeholders, be honest in the evaluation, and then see how far we can go. And various evaluations might look differently. This happens to be the one that was led by the American Society of Hematology. And in every area, it's important to have that outreach for sickle cell. So I just wanted to say thank you. Thank you, the Canadian Hemoglobinopathy Association. This has been a wonderful delight to be here with you. One day I'll come to see you guys in Canada. I've been there a couple of times, but I hope I can go again and meet you all in person. I look forward to that day, and I'm grateful, and I look forward to our discussion. Thank you.
On with us yet, but there's going to be a moment of AV time to get things switched around. Maybe if anybody needs to refill coffees and things, stick around in the room. I think it's just going to be maybe 2 minutes.
Good morning, Dr. Pacife. Thank you so much for joining us this morning, and thank you. You can see everyone who's come to attend in person, and we all had the privilege of listening to your wonderful talk, and so thank you so much for sharing your story and really illustrating the power of advocacy and really passion and drive and really enacting change related to sickle cell. And so your talk has been very inspiring for all of us, and I think has really motivated us to take steps forward in our own advocacy here in Canada. So thank you again.
Thank you. Thank you so much. Thank you for the kind words. And hello, Canada. I wish I was in the room with you. I'm here in warm Houston. I don't know if it's and we're actually celebrating our Sickle Cell Education and Research Day. You heard me mention that in the presentation, and so that's why I've decked out in my sickle cell gear. But thank you again.
Okay, that's wonderful. Thank you. And we're actually also celebrating Sickle Cell Awareness Month here in Canada as well. So it's wonderful that we can have you here for our CanHaem conference. And so we'd like to open the floor for questions. And so we're going to have a combination of questions from our in-person attendees and also our online attendees who are going to ask questions through the chat. Yes, and so so we have microphones in the back. So if you do have questions, please feel free to raise your hand, and then we'll pass you a microphone. Okay, all right, so you know what, I'll start if there's no question there. And so again, I was really moved by your story and your experience, and you really highlighted how in the beginning of your journey, how isolating it can be to have sickle cell, and I think that was really eye-opening for many of us. And I think you really highlighted the importance of bringing individuals together with sickle cell so they can see others who are also living with that experience. And I think for all of us, we have our local initiatives to try to do similar work. And so one question I have though is, how can we as healthcare professionals, so we've gathered here today as professionals and we don't have our patient advocacy group here today, but how can we better engage our patients in some of this advocacy work and empower them to also take steps to lead some of these initiatives?
Thank you. That's a great question. So I think it's important to recognize the space that you're entering. And I've always said we need to respect the space when it comes to entering the community and discussing with individuals affected by a disease or the families that have been impacted by it. And this is particularly true for rare diseases. So I think that isolating experience is not just one that's mine. If you investigate and ask each of your patients and their families, some of them may have never even met another family who was dealing with the disease. And even though sickle cell is a little bit less rare than conditions where maybe you don't have thousands, like hundreds of people with the disease or tens of people with the disease, it's still a small number. And so first recognize that they feel isolated, they do. And when a community group feels isolated, what ends up happening is that they have a grassroots mentality to the work that they're doing. They're extremely passionate because the motivation comes from either a loved one or their own experiences or a combination. And so sometimes they feel as if it's us against the world, like how am I gonna save sickle cell? And it's a lot of weight on one's shoulders. I also think there's something that I call the scarcity phenomenon. It's something that I'm familiar with being from Nigeria, where when there's less resources, it causes extreme stress and even in a weird way, competition. So you might see that various groups feel that stress of caring so much about the disease and yet worried that there's not enough resources for all of them to do each other's work. So just recognizing that space and being respectful of it, not being judgmental. And so that's that humble component, the respect. Then the second part is actually asking them what it is that they want. And this can come across in different ways. I think now
There's the concept of a community advisory board. I don't know how many of your institutions work with one. It's something that's new for my institution. I think a lot of institutions have an advisory board that's made up of families and patients, but likely your rare disorders like sickle cell may not fully be represented, on those boards. So I think making sure that they're at the table and able to let the institution know some of their concerns, that's very important. So that includes listening sessions, focus groups, and so yeah, let me pause there. I will say that it takes patience as well, and it also takes persistence, because I hinted at this, I don't know if I actually used the words, but there is this mistrust component as well. And so sometimes institutions and academic institutions, even when well-meaning, they might come across as a big bad wolf in a way at times. And so I think, again, really being respectful, humble, and showing that you're there to listen. Even if it's something that doesn't fully make sense to you, it's okay. Just listen and then start from there. So let me pause there because I can ramble. Right. But that's what I would suggest. So you know your current ones, whether it's locally or nationally, and some of the work that they're already doing. Show them that you are proud of their work, even if it looks small potatoes to you or small scale. Show them that you see the value in their work, and then focus on a way to become partners.
Okay. Thank you so much. That's very helpful. Thank you. And we have a question from online.
There's a question from online, and our setup here I'm going to be kind of leaning over. So it's from Dr. Stephen Ambrusco from University of Buffalo, Oishé Children's Roswell Park. And the question is, what efforts do you know of and do you suggest for our colleagues in emergency medicine, often on the front lines seeing patients, and often where systemic racism against sickle cell disease patients is most seen?
Okay, so I smiled. You just named the arch enemy of every sickle cell individual, right? So it's sad that it's a trigger word. Emergency department, emergency room, emergency center. They end up being trigger words for individuals with sickle cell, especially on the adult side. Pediatrics, everybody gets a lollipop, everybody loves everybody, but adult side, it's really tricky. And you know, the teenagers, you start seeing some of that. But so how, this is another space that I saw in front of my eyes, how traumatic the issues are. And so because of that, it takes first some champions from the emergency department side. I was privileged to actually meet what I consider emergency department champions. These people speak sickle cell and they seem to get it. And they can be the ones to help you speak to their colleagues. And so the correlate for you, like CanHaem, the version of this for emergency physicians, find a buddy and start small. Start having conversation. And I think with the emergency department, there's two sides to this. I can see both sides because I've done medicine, but clearly I am very biased as well. But I would say that a person in the emergency department for any disease does not have the full understanding of what it means to carry that disease in a daily life situation. And we're not always given the opportunity for that. And this goes not just for the emergency department, but even in medical school. You see a glimpse, you learn about medicine, but you don't really understand the human component of having the disease. And so one, I think implicit bias training is essential for all physicians, but I think that would help in the emergency department setting if you're thinking of a global approach. And this is regardless of just sickle cell disease, but I think we don't realize the power of our implicit biases in situations where lives might be at stake. And so I think that's one component. And then the other component is making sure that they're introduced to that space. So back to the emergency physician champions. You make a friend and you start having conversations about, why is this space messy? Why does it always seem like there's a us versus them? And you know, the doctors are very distressed by this too, right? They're like, well, we think we're practicing medicine appropriately, but why do we keep on hearing this, that patients are having this a negative experience? So it starts with having conversations. I want to give a shout out to a group called I think they're called the ESC3 Initiative. It's an Emergency Physicians Sickle Cell Coalition. And it's a partnership between emergency physicians from the American College of Emergency Physicians, as well as advocates in the sickle cell space. And together, now with the American Society of Hematology, they've created they had several meetings, work groups, released several documents. But one of the most recent achievements is this emergency department point of care tool, where literally the first line is like, believe the patient, or patient is gold standard. And it's not meant to trivialize anything or dumb anything down, but it's meant to see that when it comes to caring for sickle cell, there's some evidence-based things that need to be addressed. Those elephants in the room are evidence-based, and they need to be addressed. And so I don't know if you are familiar with that tool. I can share it with you guys later or put it in the chat, the link. But I was impressed that emergency physicians created that document, partnering with hematologists, partnering with individuals with the sickle cell space. So does that mean that now all the emergency people are happy with sickle cell? No, it's a long climb. But the goal is that as you keep on spreading that message, people will slowly realize that part of the mismanagement of sickle cell involves stigma and bias, and that just has to be addressed. It has to be addressed.
Absolutely. Yeah, thank you. And do we have any questions in the
I
room?
want to, did somebody else have a
absolutely.
question?
Someone has a question, but if you're
Because I wanted to add something.
Okay.
Because
Go
I
ahead.
didn't have time to say this. I learned that I had to change my lexicon when it came to sickle cell. And I want to attribute another reference. There was a Pediatrics in Review article that I read when I was in residency, and it talked about the ethics of sickle cell pain contract, and it had a case presentation. But I realized that there's some dictionary words we need to exchange. So one of the words was exchanging drug seeking for care seeking. That was just, it sounds like a small thing, but it really does matter. Drug seeking for care seeking, no matter what it is you think you're seeing. The other one is the concept of pseudo addiction, which, is not the best word, but at least it attacks, again, the thing that makes doctors have that weird alarm bell go off when they care for a person with sickle cell. You're not seeing a drug addict. You're seeing evidence of a person who has been in a system that does not trust them. And so you now have seen some maladaptive behaviors because of that. So that's the concept of pseudo addiction. But it's things like that. I just started realizing that I don't care how challenging this patient situation is, just like with any patient situation, not just sickle cell. I need to get behind what's going on with this patient. And so at the first step is see them as care seeking. They're care seeking. There's a reason why they came to seek your care. And then I'll say one last thing. I'm gonna give a lot of shout outs today. Dr. Marilyn Tellen from Duke, she once told me, I think if doctors realize that what's behind every pain crisis is a fear of dying, I think they would approach a patient a little bit more humanely as well, because there's a reminder with pain. Something's wrong, and with certain types of pain, death is the thing that flashes in your mind. So I can ramble on this forever, but I wanted to make those points as well.
Thank you very much. That was really powerful, and I think it put things in perspective for us. Thank you. And so Reve had a question. Do you have a microphone? Okay. We have a question from our live audience here.
Thank you. Hi, my name is Reve Ejapon. I just had a question for you. Thank you so much for your presentation. It was amazing. I learned a lot, and thank you for sharing your experience. But I was just wondering, so how do you suggest that we work with the stigma and the fear associated with sickle cell disease? You mentioned that one big thing that changed for you was, meeting your cousin, meeting someone else with sickle cell disease. But I find that it's hard to connect some patients even at events and things like that, because those who are not already accepting of the disease, they're not going to show up to events and conferences and things like that, because there is the stigma and people might feel ashamed and things like that to even come out. So do you think that it is appropriate or encouraged, maybe in a clinical setting, to have group sessions with families, with kids around the same age, or draw those kids in? And if so, at what age do you think that that would be appropriate?
Okay. So this question is very important, and it has a few layers to it. So first, I've been fascinated by how the stigma with sickle cell, it exists everywhere, it just looks different. So even in Africa, there's a stigma with sickle cell. It's a social stigma, the concept of having bad blood, or things that you don't want associated with your family, that kind of thing. So there's a shame that comes with that too. The stigma that tends to happen in countries like Canada and the United States tends to be circled around race, but you might see some overlay of shame as well, of that concept of something's wrong with me, having this gene mutation, that kind of thing. And there is a type of, again, chip on the shoulder pride associated with it's me against the world. So how do you break down some of those barriers? Now, I'm in pediatrics, so I will say that I think the adult side has the more challenging versions of what I'm going to describe, but I realize that I have a powerful tool, the internet and social media, and if a person feels uncomfortable coming into a physical space, you can start dropping the seeds by giving them a digital one. So I often print out some of those blogs you saw on my presentation, or even stories about like the basketball player, like so the young guy. I want to first show them that there's old people with sickle cell, because I think because again, back to that death comment, many of them are primed to think they're going to have a premature death, and whatever number is in their head. When I was young, mine was 18. My cousin was 17, and my mom's nursing textbook said 18. So I really thought, like, I literally thought something bad was going to happen to me in that year. And so first, I want to show them somebody older than them. So if it's a 5-year-old, show them a 10-year-old, and so forth. When they're already an adult, just showing them another adult is enough. It doesn't have to be somebody necessarily older than them. And so whether that's a story, or whether that's a digital space, a chat, whatever they're into, Instagram, whatever, I don't know, Twitter, whatnot. And you don't have to be savvy. I'm not on half of those things, but I know that those spaces exist. And when you hear somebody else talk about the sickle cell, the connection happens. Like there's this kindred spirit kind of thing that happens with it. So for the ones that are shyer, or the ones that seem to have a shame component, or they just have they appear to have a lack of interest for in-person gatherings, you can try that strategy. When it comes to bringing people together, what does that really look like? I think sometimes we'll think of a great idea, oh, well, the families are gonna love this, or the patients are gonna love this, and then it's like crickets. You're not seeing your registration, enrollment seems down, you're like, I don't understand. And that's probably because you may not be speaking their language the way that they want to receive it. So partnering with, again, a sickle cell organization will always be helpful, because that face can be part of what they see. So it's a more welcoming space for them already. And then being thoughtful about who you bring to be the speakers, because I think you do sometimes need someone to help shake up this kind of sleeping giant component to, I don't want to call it an apathy. It's almost like a historical disappointment. You just inherited this ancestral struggle in your mind, nothing ever seems to be working right. Nobody cares. There's a lot going on there. So I think it does take a thought and time. I think adults are much more challenging, but it is possible. Make sure you have food, and make sure you think about the burden of that too. Like making sure it's like comfortable space. The other thing is, if you feel like, they don't trust us yet as a group, but hey, the Sickle Cell Community Consortium, I'm shouting out a group in America that some of you may have heard of. Those events are popping. They are like lots of people with sickle cell, very engaged spaces. And so showing them even a glimpse of that, they have Facebook, they have all this kind of stuff, that shows them that, okay, I'm not by myself. There's people that are outside of the space of my hospital that are engaging in this disease. I don't know if I talked on all the parts of stigma that you were emphasizing, because it sounded like you were talking about both types of stigma, the stigma of being, a patient with a disease, and then the stigma, the social stigma. But yeah.
No, that was great. Thank you so much. That's helpful. We can at least start planning and moving forward with something to get our families more engaged. Thanks.
Thank you. And so we have time for maybe one quick question. I don't know if anybody in the room. Okay.
I'll just actually, while we're doing that, there's 2 comments on the chat. One says, thank you, great suggestions and points to the question about ED. And then there's another comment here. Thanks to Dr. Fasipe for sharing your very intriguing personal story with sickle cell and for capturing the history that helps us understand how we got here. A very powerful way to call us all to continued action. So, and then we'll over to the last question from the audience.
Thank you so much. This was beautiful and moving and very appreciated. I trained in US, so this hits home a lot. My question to you was, so there are 2 tiers of advocacy, right? One is establishing the trust and relationship with the patients, and the second one is engaging the people who give the money in an effective way to cater to the sickle cell population. And this can include, in Canada quite often, the health ministries. And just like there is stigma in medical profession, I'm sure there is some element of stigma at that level too. So what has worked for you in dealing with, let's say, ministry officials or your states and other people in terms of overcoming those barriers?
Okay, this is actually the proper question, right? For especially y'all are wanting to be a light in the dark. I love the theme. So I have learned a lot about this space. So one, I don't know, do y'all call them politicians? I don't know what health ministers, the health ministers are, I mean, the people who make your...
Yeah, so people who hold our purse strings on a provincial level, basically.
Yeah. People who are important, they're very, very important people. They mostly don't know anything about medicine, right? You already know this because you see policies that are like scratching your head. So there are going to be some, though, that I believe have a background in medicine. If it works the same way in America, anybody can be in politics. I'm going to just make up stuff. But so one, a champion that's easier to convince is sometimes one that has a medical background. So there's that. And another champion is one whose population is likely to be more affected. Those people, you should not assume that they know anything about sickle cell just because they're Black or just because they have an MD or your equivalent. So educate them, but they at least will be a quicker listening ear than somebody who was like a business background and they're coming from a very different space. So it's interesting. In Texas, the representative that put all those 4 bills out, he knew nothing about sickle cell, but then I think one of his relatives, a niece, ended up having it. And so he had these distant talks with relatives that she was not doing well. And then an advocacy group came to him and told him about sickle cell. And then all of a sudden he's popping out bills left and right. And, we're like, thank you, sir. And you can tell he does not know, and I hope this doesn't reach his door. He needed education about sickle cell, like many people do. So he's not pretending to be an expert, but he had the passion, he had the the access to be a champion, a sponsor, to open the door. So you find your friendly face. It's almost like the infiltration of the emergency department. You find your friendly face, you help them see the issues in the community. For better or worse, it's now a hot topic to care about disparity. It's a hot topic to care about, things like Black Lives Matter, and whether or not it's fully sincere or not, it's still an area that you can leverage, if you will. I hate to say it like that, but it helps people realize that I've been looking for a way to show that I do care about these issues. This is a clear example that ticks so many buttons. It's a healthcare disparity. You're reaching a disenfranchised population. And then there's still a lot of gaps. Every developed country sees themselves as the best. I'm assuming Canada thinks they're the best. And so what does it mean to be the best? You guys kill it with the healthcare, but yet do you kill it? I don't know. Because we're always jealous of y'all. Oh, they have that free healthcare up there. That's why they're smiling all the time. I don't know. And so, but I heard it gets a little tricky when you go down to the weeds, right? There's still a disparity. And so exposing it and having a champion that kind of partially speaks your language, but that you can coach and really get them there is very important. I don't know, I think I'm way over time. So, but yeah, you just energized a whole other conversation point, but it's actually the most important one. You don't have to be a policy expert. I am definitely, again, I stumbled over all those words about politicians because I really don't know. I avoided it like a plague in high school and college. But I realized that they are the people they are your kings. They are the entry points to how things get done. And we have to find a way to allow the king to have his ear. There's a scripture that talks about, that with Nehemiah, the king, when you have the king's ear, don't let the king ignore you. They'll listen and you can stay there. And it's very impressive what can happen when you finally get those kings to pay attention. Because even in their own small ways, they can open doors and it can just lead to one door after another. And like I said, the winds of change that have started, they're not going. You guys have already started in this space since the 2000s. It's not going to fall down. You are going to continue rising. I commend you all for the work that you do. I also have to say a personal thank you to all of you for just caring about sickle cell, man. I was, part of my isolation was finding doctors who got it. So every time I met a doctor that talked compassionately about sickle cell, it took me aback. I was always like, oh, you like sickle cell, okay. And I have to say, it really means the world, because that fight that I said, when you feel like it's just you against the whole world, I realized that no, it's not just me. We have a team, and we have caring people out there that love children, adults, individuals with sickle cell, and I want to clone all of you for every sickle cell patient that does not have that. But so again, thank you for this opportunity. I hope I can meet you all one day. I wasn't able to see the faces of the people asking the questions, but please, if y'all come to ASH or anything like that, I'd love to say hello. And when I come to Canada, I'll look, as big as it is, I'll see what I can do. I'll see what I can do.
Thank you so much, Dr. Fasife. We really, really appreciate this. And we will bring you to Canada so we can meet you in person. Yes, that would be wonderful. And we're very grateful for your sharing your experience, your wisdom with such candor and really practical, tangible advice that we can hopefully follow. And at the risk of sounding corny, you had made a reference to superheroes in that New York Times article, and I think you're the perfect example of how superheroes don't always wear capes, right? And so we really appreciate your work and you taking the time to talk to us today and to be here. Okay, thank you so much.
You're very kind. Thank you so much. I really can't wait to meet you in person. I have to say thank you, especially to you, for organizing everything, and very humbled and honored. Truly, truly am. Thank you.
Okay, thank you again. Okay.
is in the blue sheet inside your thing a marking score. What we want is your top abstract. We will collect those. Just so I find it really hard when you're watching 8 back-to-back personally, so you can take your little notes and stuff. Please be kind. Everybody's trainee for the most part, except for one staff, I think, who's presenting. So remember where you were at this stage. If you write any comments down, and we are going to save the questions for all the abstracts at the end for our 2 moderators, the one in person and Stephanie, who will be virtual with us. Okay, is that pretty clear? Sorry, we'll see how as we go, but I do want your top abstract afterwards, and we will pick up those papers and hopefully be able to announce the abstract winner at the end of the day, if we can get that all together at the end of the day. Well, we will. Kevin's optimistic.
We always do.
Six years. I have no disclosures. As most of us are aware, sickle cell disease is an inherited blood disorder where the shape of red cells is affected, leading to ischemia and multi-organ disease. This project was based on the fact that patients with sickle cell disease are high utilizers of the healthcare system and often seek emergency care through the ED for vaso-occlusive crisis. From Ontario data, we know that there's usually about 1,000 visits to the emergency department for vaso-occlusive crisis per year. Recently, the American Society of Hematology released guidelines regarding the care of acute pain in sickle cell disease, which recommended analgesia within 1 hour of presentation, the use of NSAIDs in addition to opioids, and frequent reassessment of pain. This project focuses specifically on rapid analgesia and the use of NSAIDs. Up until 2019, there was no standardized method of care for vaso-occlusive crisis in our emergency department in London. We developed an emergency department order set based on patient-reported concerns to help standardize care, including opioids, NSAIDs, fluids, antibiotics, etc., for a variety of sickle cell disease presentations. This went live in September 2019, but its impact hadn't yet been assessed, hence this project. The overarching goals of our project are to quantify our performance in relation to the ASH guidelines and to design and implement a strategy to improve the care of sickle cell disease patients in the emergency department, although this presentation will focus more on the first goal. For the years of 2016 to 2021, we screened for ED encounters for vaso-occlusive crises using ICD-10 codes and the Red Cell Disorders Clinic List, then included encounters where triage notes mentioned acute atraumatic pain or sickle cell crisis. We looked at the demographics, ED order set use, analgesia type, route and time of administration, and analyzed data descriptively. Overall, we identified 94 encounters contributed to by 34 unique patients. Their average age was 29.7 years, mostly female and mostly at Victoria Hospital. When we look at the overall stats from 2016 to 2021, parenteral analgesia was received 72% of the time, but was only received within the target of 60 minutes 15% of the time, which is reflected in the bottom graph there, where blue is analgesia receipt and orange is analgesia receipt within 60 minutes. The average time to parenteral analgesia was 2.1 hours, ranging from 12 minutes to 10 hours after triage. NSAIDs were received 37% of the time, which is reflected by the orange bars on the top of the graph. Next, we look specifically at the possible impact of the ED order set. It was first used on September 1st, 2019, and since then it has been used on 27 out of 48 occasions, or about 56% of the time. In these graphs, the blue represents the order set not being used, and red represents the order set being used. The top graph shows analgesia use in all three domains of NSAIDs, parenteral analgesia, and parenteral analgesia within 60 minutes. The ED order set use was associated with an increase in use. 45% increase in NSAIDs, 17% increase in parenteral analgesia in general, and 46% increase in parenteral analgesia within 60 minutes. The bottom graph depicts the time to first receipt of parenteral analgesia in hours. You can see when the order set was not used, the average time to receipt was 2.3 hours versus 1.75 hours for a 31% reduction in time. In conclusion, our ED care of patients with sickle cell disease presenting with vaso-occlusive crises does not meet targets set out by ASH, including the use of parenteral analgesia, time to parenteral analgesia, or use of NSAIDs. Use of the order set was associated with an improvement in these metrics. However, the uptake of the ED order set was suboptimal, and even in those patients for whom the order set was used, the treatment targets were still not reached, which taken together means that there's still quite a bit of work to be done. In terms of next steps, as with any quality improvement project, we will identify champions in relevant groups such as ED physicians, residents, and nurses, and perform root cause analysis involving relevant stakeholders. Then we will formulate our next intervention and reassess impact. Informally, I'm pleased to report that we presented some of this data to the Department of Emergency Medicine at a recent grand rounds, and there have been some suggestions from their end, all of which have led to the initiation of a directive, including the use of ketorolac in the ED waiting room, which will be very interesting to explore moving forward. Thank you so much for your attention. These are my acknowledgements, and I'm happy to take any questions.
Hi everyone, my name is Jules Ross. I've just completed my hematology training at University of Montreal, and I'll be presenting today red cell exchange with the targeted hematocrit of 34 in sickle cell disease, which is a study from CanHaem. So I don't have any disclosure. So approximately 10% of patients with SC rely on chronic red cell transfusions as part of their management, yet the optimal strategy for regular transfusion program is not well established. The 2020 ASH guidelines suggest using a red cell exchange over simple transfusions in patients receiving chronic transfusions, as the later approach could lead to iron overload and subsequent end organ damage. In addition to this already challenging aspects of SCD management, the COVID-19 pandemic created a severe blood shortage, as we all know, which was especially critical for patients with SCD who rely on chronic RCE. In order to alleviate this blood shortage, the Children's Hospital of Philadelphia has published this article last year in which they suggested two measures to reduce their blood use, one of which was raising the hematocrit after RCE to enhance suppression of erythropoiesis. And they actually demonstrated a reduction of their red cell units transfused, but also concluded that this strategy should be reserved for severe blood shortages only, as it led to iron accumulation over time. We decided to review our own outcomes here, considering we've been adopting a similar approach for quite a long time. So here at CanHaem, the post-transfusion hematocrit is at 34 regardless of pre-transfusion level. And you can see here the RC targets, they're established as detailed here. We try to achieve our goals through adjustments in transfusion interval. So we used OASIS and Traceline softwares to identify patients. Adult patients were included if they were treated with chronic RC programs for at least 6 months in the last 3 years. So 101 patients were included. You can see here the basic demographics of our patients, with the mean transfusion interval being 6.9 weeks, and the majority of our patients being of HBSS genotype. The most common indication for chronic RC was progressive cerebrovascular disease, and approximately half of our patients had more than one indication for enrollment. So we then divided our cohort in 2 distinct groups. 50 patients had their post-transfusion hematocrit increased with RCE, most of whom were of HBSS genotype, compared to 43 patients who were enrolled in a neutral hematocrit balance strategy. And in that group, both genotypes were seen. So when we compare transfusion requirement outcomes between those 2 groups, we noticed that the higher hematocrit group required less red cell units per procedure, but also per year, and that remained consistent even when correcting for patients' weight. So that's what we did here when we used the red cell volume instead. However, in terms of iron-related outcomes, a significantly higher number of patients in the higher hematocrit group reached a ferritin value above 1,000. And in that group, half of the patients were prescribed iron chelators during their RC program. So the time from start of RC and chelation prescription was the mean time was 19 months. What we saw with the other group was quite the opposite, as half of that group was prescribed iron supplement instead. So that was quite interesting. So in conclusion, at our center, half of patients on chronic RC have more than one indication, with neurologic disease being the most prevalent. Patients with an increased post-transfusion hematocrit require less red cell unit per year, and raising hematocrit more than 2% above pre-transfusion level for at least 6 months results in iron overload in 64% of patients and prescription of chelation in half of patients. This suggests that hematocrit balance before and after RC can reliably predict net iron balance in patients on chronic transfusion therapy. We think that increasing post-transfusion hematocrit is feasible, and this strategy could be deployed effectively in regular practice while ensuring close iron level monitoring. However, it should be formally compared with an isohematocrit strategy in patients with a comparable baseline hematocrit. You might have noticed that it was not the case here. The groups were quite different in terms of pre-transfusion hematocrit. In terms of limitations, lack of data baselines for patients who started the program before 2010. Ferritin balance between start and end of the program was impacted, obviously, by iron-directed therapies, but this is why we chose iron-directed intervention as an outcome. And also, specific outcomes were not collected. They were outside of the scope of the study and could be part of the subsequent study. This is mostly food for thought, as I won't have the time to answer these, but I'll be very happy to answer questions during live Q&A. And I thank Dr. Soulière and Dr. Forte and all the other physicians who helped me a lot with this project. And thank you very much.
Hi, my name is Justin Desroches. I'm a hematology fellow at McGill University. Today, I'll be presenting our project called COVID-19 and Sickle Cell Disease in the Province of Quebec, Canada, Outcomes After 2 Years of Pandemic. I have no disclosures to report. About 1,500 people are diagnosed with sickle cell disease in Quebec. Sickle cell disease patients may be at higher risk of severe COVID-19 infection based on the following: their pro-inflammatory and pro-thrombotic state, splenic dysfunction and relative immunosuppression, and sickle cell disease-related comorbidities like pulmonary hypertension and CKD. Registries from around the world have reported various outcomes of COVID-19 infection in this population. The Secure SCD Registry, an American initiative regrouping 750 cases, reported hospitalization rates of 46.7%, ICU admission rates of 7.4%, and mortality rates of 1.8%. However, in April 2021, an American study comparing patients with sickle cell disease or trait with Afro-Americans without sickle cell disease or trait found no difference in mortality and morbidity. Therefore, there's a clear discrepancy between studies, and the morbidity and mortality rates of COVID-19 and sickle cell disease remain uncertain. Our objectives were to describe the epidemiology, baseline characteristics, and clinical outcomes of sickle cell disease patients with COVID-19 infection in Quebec. We also wanted to identify risk factors for hospitalization and severe disease. We built a web-based sickle cell disease COVID-19 registry, regrouping 3 adult and 4 pediatric tertiary care hospitals in Quebec. All sickle cell disease patients with confirmed SARS-CoV-2 infection by PCR between March 2020 and March 2022 were included. As of January 2022, patients with a positive antigen test were also included due to PCR testing restrictions. We then compared infection and hospitalization rates of sickle cell disease patients to the general population of Quebec using data from the National Institute of Public Health of Quebec. All in all, 185 patients were included. The median age was 12 years old. 65% of patients had hemoglobin SS or hemoglobin S beta 0 genotypes. 65% were on hydroxyurea, and 14% were on chronic transfusion therapy. Among sickle cell disease patients infected by COVID-19, 72% had mild disease and did not require hospitalization, 24% were hospitalized without ICU admission, and 4% required an ICU admission. However, no deaths were recorded in our study. When we compared this to the general population of Quebec, we noticed a higher rate of COVID-19 infection with a relative risk of 1.30, a higher rate of hospitalization with a relative risk of 5.15, and a higher rate of ICU admission with a relative risk of 4.56. We also found that a history of ACS in the past year and known arterial hypertension were associated with a higher risk of severe disease, which meant hospitalization. So here for ACS, the relative risk was 2.27, and for arterial hypertension, 3.06. Hospitalized patients also had lower hemoglobin F levels than non-hospitalized patients, 12% compared to 17%, but we found no significant difference with age, sex, genotype, blood group, baseline therapy, or other medical comorbidity. Once vaccination was available, 25 out of 26 patients were adequately vaccinated, and none of them required hospitalization. In conclusion, sickle cell disease patients are at high risk of severe disease, as proven by their higher rates of hospitalization and ICU admissions, but no deaths were recorded, which contrasts with other registries. This could be explained by the younger age of our population, fewer baseline comorbidities, and potentially by universal access to healthcare in Canada and the comprehensive care of sickle cell disease patients in our country. This registry is a result of collective work among all sickle cell disease treating centers in Quebec, allowing us to reach more than 1,500 patients. It has its limitations, including the fact that only tertiary care centers were involved, and also the fact that we had a lower threshold for COVID-19 testing in this population. During the first wave, also, there was a tendency to hospitalize patients for observations, which might have increased the hospitalization rates in our population. Registries are critical to rapidly support preventive measures, and because of this registry, we were able to establish preventive withdrawal from work and prioritize vaccination for sickle cell disease patients. And they're also crucial to follow the impact of COVID-19 variants and vaccination among our population. However, further investigation is warranted to explain the differences in mortality and morbidity rates among the different registries around the world. I want to thank all these people, but especially Drs. Mathias Castonguay and Dr. Stéphanie Forté, and those are my references for the presentation. Thank you.
Good morning. It's my pleasure to be presenting our quality improvement project, optimizing use of automated isovolumic hemodilution red cell exchange in a patient cohort with sickle cell disease at the Ottawa Hospital. Many of you in the audience will be aware that red cell exchange is a mainstay of treatment for both acute and chronic complications of sickle cell disease. It is a resource-intensive intervention that requires the transfusion of large volumes of antigen-matched red blood cells. Identifying suitable red blood cell units can be challenging due to the variability in blood group phenotypes between patients with sickle cell disease and the donor population. This often results in the use of O-negative units, which are a scarce resource. A prior audit at the Ottawa Hospital demonstrated that 29% of red blood cell units transfused in patients with sickle cell disease were O-negative. Efforts to reduce the volume of red blood cells transfused while maintaining therapeutic efficacy is an important clinical need. Isovolumic hemodilution prior to red cell exchange reduces the required volume of red blood cell units transfused. The aim of this project is to evaluate the effect of a change to isovolemic hemodilution red cell exchange on red blood cell utilization with patients with sickle cell disease already receiving standard chronic red cell exchanges. All adult patients with sickle cell disease receiving red cell exchanges at the Ottawa Hospital were identified for inclusion. To safely attain a meaningful reduction in transfused red blood cells, red cell exchange treatment parameters were individualized for each patient, and red blood cell volumes required for either isovolemic hemodilution or conventional red cell exchanges were estimated for each patient. These calculations were performed on the Terumo BCT red blood cell exchange calculator. Ultimately, a protocol change to isovolemic hemodilution red cell exchange would only be performed if an estimated reduction in red blood cell volume of at least 200 mL was expected with this transition. The isovolemic hemodilution red cell exchange protocol was adapted from prior publications where this modality is more widely utilized. The post-procedure isovolemic hemodilution hematocrit was never allowed to drop below 20%, and thus individuals presenting with a pre-procedure hematocrit of less than 20% were excluded from a protocol change. Depending on the pre-procedure hematocrit, the post-procedure isovolemic hemodilution hematocrit was individualized. Ultimately, the end procedure hematocrit that was targeted following the complete red cell exchange session to that as the same of the pre-procedure hematocrit. The change in red cell exchange protocols to isovolemic hemodilution took place in January this year. Transfusion and clinical data were obtained from databases at the Ottawa Hospital in the 6 months preceding and succeeding the change in protocols to allow for a pre and post intervention comparison. 34 adult patients receiving regular red cell exchanges were identified for inclusion, of whom 22 patients met criteria for a protocol change to isovolemic hemodilution red cell exchange. The mean age of the cohort was 31 years, with males comprising 73% of this cohort, with the most frequent genotype being hemoglobin SS. Over the 1-year study period, 1,963 RBC units were transfused, 1,035 in the pre-intervention period, 928 in the post-intervention period. This represented a reduction of 107 RBC units in the 6 months following a change to isovolemic hemodilution red cell exchange. The mean number of RBC units transfused per patient in the pre and post-intervention periods were 47 and 42.4 units respectively. The mean number of RBC units per red cell exchange session per patient was significantly reduced from 8.7 units in the pre-intervention period to 7.8 units in the isovolemic hemodilution red cell exchange period. A total of 236 red cell exchange sessions occurred during the study period. No difference in red cell exchange frequency was observed with a change to isovolemic hemodilution red cell exchange during the 6-month study period, nor the time between red cell exchange sessions. Therapeutic efficacy in attaining target hemoglobin S levels was not affected by the change to isovolemic hemodilution red cell exchanges. No adverse patient safety signals were observed during the sessions to date. This study demonstrates that isovolemic hemodilution red cell exchange, compared to standard red cell exchanges, is both safe and efficacious and can substantially reduce red blood cell utilization. A total of 107 units were conserved in our patient cohort of 22 chronic red cell exchange patients in the 6-month period of time, whereby they were transitioned to isovolemic hemodilution red cell exchanges from standard red cell exchanges. Based on local RBC per unit cost, this corresponds to an annualized savings of 95,444 Canadian dollars. With pressure on blood banks to provide appropriately matched units and risks of alum immunization and delayed hemolytic transfusion reactions amongst our chronically transfused patients with sickle cell disease, increased uptake of isovolemic hemodilution red cell exchanges should be considered for patients with sickle cell disease on chronic red cell exchanges. I thank you for your time.
Hello, this is Riley Plott. I'm a 3rd-year medical student from the University of Saskatchewan. I'm here to present on my research empowering sickle cell patients and families by innovative education methods. Jump into background, sickle cell disease is a group of inherited blood disorders caused by a mutation in the beta subunit of hemoglobin. From here out, I'll refer to it as sickle cell anemia, just because this is the term that our patients and their families use. So there are approximately 5,000 Canadians living with sickle cell anemia, including children. And when the beta subunit of hemoglobin becomes mutated, this leads to polymerization of the hemoglobin, sickling of red blood cells, and then vaso-occlusive pain crises that can lead to complications in many organ systems in the body. And of course, we get anemia. So why did we do this project? Well, we know from the literature that pediatric sickle cell anemia patient education can improve knowledge, decrease hospitalization, improve medication possession ratio, lead to better sickle cell anemia related functioning, and lower pain impacts. As well, there's a lack of information out there for our youth. And during the transition from peds to adult care, this is a really important time as we see an increase in acute care visits and rehospitalizations. So if our youth and their families have an expectation that they can make a change to their management, this will equal the self-efficacy for them to manage their sickle cell anemia. So we hypothesized that by creating an innovative educational cartoon video targeted towards our youth with sickle cell anemia, that this would improve knowledge and self-efficacy regarding illness management of patients and their families. So we created an educational cartoon, and this cartoon was reviewed by the CanHaem team and focused on sickle cell management and as well as emergencies. There's just some screenshots from the video. So we have Dr. CanHaem here teaching. We had some questions that were meant to reinforce some of those knowledge concepts. Here's Jen, our main character with sickle cell anemia, interacting with her superheroes. So we sent out flyers to patients and their families and through our partner organizations. 5 kids with sickle cell anemia were recruited, 8 to 18 years old, and 5 parents of patients were recruited. We held a focus group over Zoom, one separately for the parents and one separately for patients. And then the results of this focus group were transcribed, and somatic coding and analysis was done using in vivo. A number of themes came out of the focus group. So first of all, age appropriateness. I was humbled very early on talking with our teens when they explained to me that maybe the video was better suited for children, that it grasps their attention, it's not too complex, and maybe an infographic would be more beneficial to teenagers, or a website with, just short and sweet information. Empowerment was another key finding. One parent said the usage of magma, it gives you an understanding better of what can happen, and the thought that you have some control over it, that it doesn't have to erupt. So that makes me feel good. Highlighted knowledge gaps that the video addressed. Our youngest participant said, I learned that sickle cells can't really bring oxygen, other blood cells can. There was a patient and their parent that brought to the attention of the team the need for the video to be linguistically accessible. Medication adherence was another common theme. One of our teenage participants added how maybe we could add something about how it's useful and what your life would look like if you were taking your medicine every day versus like if you kind of just never took it. As well, one of our teenage participants touched on the theme of strength in the community. So like maybe an infographic, they always have stats. Maybe if there's a stat, like how many other kids also deal with sickle cell, they thought it was just them. And transition to adult care is especially important. One parent mentioned they're not ready yet to deal with sicklers coming in as young adults, and information needs to be there ASAP. So to conclude, the video is well received, thought to be educational for all ages, and brought peace of mind. The materials need to be age appropriate, linguistically accessible. Education requires a great deal of family and community support. The feedback we received will be incorporated into a final version of the educational material, and we'll continue to collaborate with peds and adult CanHaem departments as well as emergency departments to develop sickle cell resources. I'd just like to thank my supervisor, Dr. Spina, the CanHaem team, our voice actors, patient organization ScanSK, and the CDAC, as well as the College of Medicine at the U of S for funding. These are my references, and thank you for listening.
Hello, everybody. Very nice to be here in sunny Canmore, right in the Rockies. It's really nice to be together after such a long time. I'm doing this presentation on behalf of my colleague, Philippos Konzakis, who I've been collaborating with in other years, and we did the initial part of the study was done and presented at this conference 5 years ago. So it's quite exciting to actually go further and talk about the impact of quality of life on thalassemia patients during the pandemic. So we know that thalassemia patients have a decreased quality of life, and we know that the pandemic had an impact on the general population's quality of life. So the purpose of this study was to see what the intersection between thalassemia and quality of life is, because thalassemia patients are at high risk for severe COVID. There was a decrease in donors because of the pandemic, and then the regular visits to the hospital potentially put patients at risk for infection. So prior to the pandemic, booking an appointment for a thalassemia patient was a relatively simple thing. You just picked up the phone and you called and you made an appointment. During the pandemic, you can see it was much more complicated. This was put out by the Thalassemia International Federation. And you can see the complexities of having your transfusion during that time period. So the research question was, what was the effect of COVID-19 on the quality of life of transfusion-dependent thalassemia patients? And was there a more vulnerable subgroup of patients? And did the government in Greece, their supportive measures potentially protect thalassemia patients? So this took place in the largest adult thalassemia clinic in northern Greece during this stringent lockdown period from November to December 2020. And you can see that 98 out of 120 patients participated, so a very good participation rate. And they completed 2 questionnaires, the SF36 and the disease-specific Tranquil, which I've been an author, a developer of. And they all were asked this question: did your quality of life get worse during the COVID-19 pandemic? And you can see that when we compared to the work that we did back in 2018 to 2020, we had almost the same number of patients. You can see the scores were pretty much almost identical, with a slight difference in the mental health scores of the SF36, but that did not achieve clinical significance. We do know that quality of life deteriorates in thalassemia patients as they get older, and you can see here, it's very nice that younger than 30, quality of life is definitely much better than when you're older, in your 50s. I think that applies to a lot of us. So when we looked between specific patient groups, you can see that the quality of life of the higher educated patients was much lower than those who had just a high school education. And same, interestingly, it was lower for married people than not married patients. Again, this is specifically during the pandemic. And we did a backward stepwise linear regression analysis, which again emphasized that independently, education status, higher education, being married, and being older all independently contribute to a lower quality of life. So the good news is that overall the quality of life of thalassemia patients didn't decline compared to the pre-COVID era, which indicates that the government seemed to do a good job of protecting this high-risk group, due to telemedicine and access to the transfusions. But there was a very interesting subgroup, which is the higher educated, married, and older patients, which were more affected by the pandemic, and is a group that might be the focus of healthcare providers going forward. Thank you very much.
Hi everyone, my name is Sarah Monteforge. I'm a second-year resident at the University of Montreal in internal medicine. Today, as part of the CanHaem conference, I will present to you this study called Cognitive Screening in Adults with Sickle Cell Disease, Prospective Validation of the Roldan Universal Dementia Assessment Scale. As a disclosure, I have no actual or potential conflict of interest in relation to this presentation. As you probably know, adults with sickle cell disease or SCD are at increased risk of early cognitive decline. The American Society of Hematology has no clear guidelines, but they say that physicians must screen for this decline. Optimal screening strategies have not been established yet. The RUDAS is a short screening questionnaire developed in culturally diverse patient populations. This is an example of the different cognitive domains that are evaluated by the RUDAS. The total score is out of 30 points. It takes about 6 minutes to do. It can be done by any health professional, and it's free. So it's much more accessible than other questionnaires like the MOCA, for example. We hypothesize that the RUDAS is a valid tool to predict neurocognitive disorder or NCD in adults with sickle cell disease. The aims of the study were to describe trends in RUDAS scores during long-term cognitive surveillance and evaluate the ability of RUDAS scores to predict the diagnosis of NCD. This is a timeline to show you how the study was conducted. So in 2018, there was the first RUDAS, and then in 2021 or 2022, there was a second evaluation with an assessment by a multidisciplinary team of neurologists, hematologists, nurse, neuropsychologists, and the patients had a second RUDAS. The diagnosis of NCD was made by either a neurologist or a neuropsychologist. 92 patients were assessed, and 28 adults met the inclusion criteria. The median age was 39 years old. About half of the patients were female. The median educational level was 14 years. There was no established diagnosis of NCD prior to the study, and there was 18% of people who had a prior history of stroke. This is a figure to show you the genotype distribution. So 64% were SS or S beta 0 thalassemia, and 36% were SC or S beta plus thalassemia. The mean RUDAS scores were 26.7 in 2018 and 27.3 in 2021 and 2022. Overall, the scores did not significantly change over time. The table 1 shows you the changes in RUDAS scores between 2018 and 2021 and 2022 according to the presence or absence of NCD. This first group is the group that was diagnosed with NCD. As you can see, there was a decline in RUDAS scores of 0.9 points, which was not statistically significant. In the second group, which had no diagnosis of NCD, there was an improvement of RUDAS scores by 1.7 points, which was statistically significant. We then looked at the scores in a specific year between the two groups. And as you can see, there was a statistically significant difference in the scores with 25.5 as a mean value in the NCD group and 28.6 in the no NCD group. From this data, we then did the second table, which is this one. It tells us that a RUDAS score under 28 and even more significantly under 23 were highly predictive of a diagnosis of NCD with a PPV of 86% with a score under 28 and 100% under 23. To conclude, and for future directions, the result of our study suggests that lower RUDAS scores are associated with the diagnosis of NCD in adults with sickle cell disease. Prospective validation is ongoing with a larger sample size. In addition, patient characteristics will be explored as potential predictors of NCD. I want to thank all those people that have contributed to this study, and more importantly, Dr. Kuo and Dr. Forte, who initiated the project. Thank you all for listening, and I'll gladly answer questions if you have any.
Do you want to talk? Are you talking?
I have, yeah.
Okay,
I'll
go ahead.
answer any questions.
All right. So I want to thank all the presenters for these excellent presentations. It's great to showcase hemoglobinopathy research in Canada. So to begin, we have 25 minutes to go through the 7 abstracts or questions, so 3.5 minutes each. So please keep your questions brief. I will start with abstract number 6 by Eric To on the ED management. So I have a question online, and I'm going to read this out, Stephanie. Also, for those who are online, please email the questions, or please enter the questions on the chat box. So from Beatriz Mugay Kahenya, would the study findings suggest that the ER order set for patients with severe continuous pain, including a standard order for short opiates, say every 4 hours, short acting, and also a breakthrough opiate every 30 minutes to an hour PRN? Or would the recommendation be just to have a PRN dosing?
I think that's a great question, and it's something that we didn't really talk about with this study or look into. Right now, as it stands, the order set is including PRN doses of opioids, and one of the things that we've been talking about with the emergency department is the potential of instituting something before the patient is assessed by a physician, including PRN parenteral analgesia for up to 3 doses, Q 15 to 30 minutes apart. But I think that the possibility of doing analgesia on a more regular basis with breakthrough doses would be something that would be definitely we would want to look into.
Okay, go ahead, Stephanie.
Yes, hello. Excellent presentation. Congratulations. I'm interested on what type of measures were suggested to improve the care of these patients in the ER. Do you have some specific examples? Maybe we could get inspired as well.
Yeah, so in addition to the initiation of the directive of ketorolac that can be administered in the waiting room before the patient's actually assessed by a physician, one of the other things that I think may be helpful, they've been talking about the potential of initiating a direct-to-hematology consult for patients who present with sickle cell disease and acute pain. So, not necessarily that they would be admitted under hematology, but just that the hematology inpatient consult service at Victoria Hospital would be notified that the patient is there. And so, sometimes part of the delay in care can be the actual ordering of parenteral analgesia and not so much kind of it's ordered and they're waiting to receive it. And so that might be something that might help in terms of getting more timely access to parenteral analgesia.
So we have a question live in the audience. Go ahead.
There we are. So very nice study. It reflects one of the challenges, though, in doing this kind of research when backgrounds of care are changing. Often we are dealing with improvements in control care, but right now we're dealing with the fact that our emergency rooms have gone to hell and can't look after anybody for anything. So how do we factor that in evaluating trying to make a quality improvement like this?
Yeah, I've been thinking about that in the background as well, just as we know, how much of the increased wait times that we've seen since the COVID-19 pandemic can we, do we have to discount because of COVID-19, and how do we interpret that in terms of actual effects of ED order sets and whatnot? And I don't really know that I have an answer for that, other than that, one of the ways that we tried to help control for that is by changing it so that the time to administration of opioid, we measure it as time from triage to administration as opposed to time to registration, knowing that sometimes there is a delay between showing up to the emergency room and actually being triaged. But in terms of other ways to do that, I'm not entirely sure. I think that's certainly one of the ways that we could potentially look at, and something that's not really tapped in this study is looking at actual patient opinions about how their care has taken place in the emergency department. So maybe the patients themselves would have something to say about that.
Okay, great. Because of time, we'll move on to the next abstract.
Okay, so the next abstract was by Julien Mercier-Ross from University of Montreal. It was about the hematocrit of 34% in chronic exchange transfusions. Are there any questions in the audience? One of the questions we had was how was it determined which patients had high hematocrit, post-transfusion hematocrit, and who had a low post-transfusion hematocrit? How was that determined?
So the balance itself, it was determined, we actually separated in 3 groups. So when we said the same hematocrit, it was actually between, the balance was between -2 and +2. So for us, it was considered that, it was a neutral balance rather than increased or raising the hematocrit more than 2%. And that was the mean increased during the 6 months, at least 6 months.
Okay. We have a question from the audience. Go ahead.
Hi, my question would be, except for the numbers of transfusion and diminishing the number of transfusion every years, what would be, you'd say, the impact on the patient, because then the transfusion are spaced like longer, so for the quality of life, have you noted stuff like this?
Yeah, that's really interesting. So I think, when we start with a lower hematocrit, it is expected that you would use a lower red cell volume because you have a lower red cell volume to exchange. So that's just, it just confirms what we already know. But as you said, the question is, are we able to increase the transfusion interval? So the answer is, it was not statistically significant for us. It was there was a trend toward longer interval for this first strategy, so increasing the hematocrit, but it was not significant. When we compare with other cohorts, so many cohorts and the Philadelphia cohort, our transfusion interval, it is longer than most of the cohorts, so it's almost 7 weeks. Most of the cohort, it's more between 3 to 5 weeks. So it would be reasonable to think that it helps increasing the interval, but we have not been able to demonstrate that with our data.
Thank you. We'll move on to the next abstract, abstract number 9 by Justin Desrochers. And Lauren Bolster, I believe, has a question online. What proportion of patients receive treatments with anti-COVID therapy for positive infection?
Yes, hi, sorry. So depending on the treatment, we did look at that oxygen therapy versus steroids versus remdesivir. I would have to look up the exact numbers, depending on the therapy that you're interested in. Was there a specific, therapy you were?
No, that was just a general question from Lauren.
Yeah, 2 seconds. Dr. Forte, do you remember the numbers?
I think, overwhelmingly the patients were young patients, so children, and many were managed outside of the hospital. But for those that were hospitalized, it depends on the wave and on the therapies that were available. So we did update it in the database. I think there was they received the best available was available at the time they were hospitalized, so that changed all the time. But yes, we had some of the antibodies were available, the remdesivir. Now we have Paxlovid and the latest one. So
I have it open here. So during hospitalization, the COVID-19 patients who needed hospitalization, 24% were on antibiotics, 4% only received dexamethasone, and 2% needed the anti-IL-6 monoclonals. So most of them, just were observed and did not require oxygen. Actually, only 20% were on oxygen.
Thank you. Any questions from the live audience here? Okay, seeing none, I'll pass it back on to Stephanie to talk about the next abstract. It's abstract number 4.
So, Kevin, could you please repeat the title of abstract number 4?
So abstract number 4 is by Kelly Uminski, is on optimizing use of automated isovolemic hemodilution red cell exchange transfusion in patients with sickle cell disease. Is Kelsey in the audience? Oh, hey, Kelsey. Okay, great. Sorry. The line of sight was blocking. So any questions online?
No questions online.
Thank you. Any questions from the audience? Yes, go ahead.
Yeah, so I guess my one question is, well, first of all, I'm a little confused because we had one presentation that said having a high hematocrit at the end reduced the amount of blood you use, and then your presentation said having a low hematocrit at the end had decreased red cell transfusion. So I was a little bit confused about that.
Oh, well, thank you for your question, Dr. Clausen. So I guess to clarify our protocol, so this was a 2-stage process with the red cell exchange. So the first part was isovolumic hemodilution, where someone's coming with a hematocrit of, let's say, 32. We bring it down with the replacement fluid being normal saline, and then we subsequently conduct a regular red cell exchange, and we actually bring them back up to the hematocrit that they first came in. So there was actually there's no difference between the hematocrit that they're coming in with prior to the red cell exchange being initiated and when they're actually leaving. It's just a conservation effort with trying to minimize the number of red cell units we're using by actually diluting down their hematocrit with first the replacement fluid being normal saline, and then we bring it back up to where they were before.
If I can make a comment as well and a question. One is that in the high hematocrit abstract, we didn't see any adjustment for red cell and hemoglobin S recovery kinetics, because everybody's recovery is different. Some people recover their sickle hemoglobin much slower, some people recover it much faster. So that would certainly impact on like how much blood, quote unquote, you can save and what's the interval of the exchange. I guess my question to you then is, did you use albumin during the isovolemic hemodilution phase?
So no, our choice was to proceed with normal saline. Some other centers do use albumin, and the rationale might be that you're avoiding the potential interprocedure hypotension with the colloid manipulation. And so that's why we were thoughtful in terms of thinking about our target hematocrit that we would lower it down to. So we excluded we did not drop it below 20%. And then it was individualized depending on what the hematocrit of the individual was coming in. So we didn't want to precipitate a relative anemia. We didn't want to precipitate any hypotension. But when we're thinking about trying, albumin is also a very expensive resource for our blood banks. And so that was the rationale for the choice of normal saline. But I do recognize in other centers, particularly in the States where this is a little bit more common, albumin can be used.
Recognizing that the most important thing for the patient is having the same outcome with less red cells, did you look at the percentage of your O-neg use that could have been met with O-positive use? So aside from saving blood, how much of the 30% of O-neg that you're using in your population is because of phenotype?
Yeah, so I don't believe that there is any changes in terms of our utilization of the O-negative units for this population because it is stemming from the phenotypes of the individual patients. But I certainly think that, you know, we are going from the perspective of this being a blood conservation intervention, and that was sort of the rationale for not wanting to change just making one change at a time. We're not. Next stages may look at trying to stagger out the frequency of our red cell exchanges to see if that can improve quality of life and the burden of this intervention on patients. But we had not seen that this was changing it was decreasing the volume of our units administered, but not the the grouping.
Go ahead, Stephanie.
Okay, thank you. Very interesting. So let's move on to the next abstract. So this one is by Riley Plett, so about novel strategies to empower patients with sickle cell disease. Are you present in the audience?
Hi, yeah, I'm here.
Why don't you just stand up?
well,
You can come over to,
okay,
to the panel.
I'll stand over here.
So,
Thanks, Riley.
so this was very interesting, and I received some questions whether we can have access to the video, because I think people are very curious to see more of it.
Oh, very soon. Stay tuned. So within the next couple weeks, actually, I'm planning on making the few changes that our patients and their families suggested. So it should be available quite soon here.
Any questions from the audience? Go ahead.
When you launch it, would you be open to doing it as a larger study, like on a national basis or something, where you ask for feedback from the patients who are using it in different pediatric clinics around the country, and then adapting it potentially, or leaving it the same based on what the patient's feedback would be on a more national level?
Yeah, we would definitely be interested in doing that. And I can leave my email for anybody who's interested in being a part of that. It was a great process to be a part of, and so far the feedback has been really good from our patients.
I've one question. So currently, according to Accreditation Canada, the gold standard for transition in hemoglobinopathies is the use of a transition program with a transition navigator. How do you envision the integration of your video into this schema?
Mm-hmm. And I think part of the transition and the feedback that we heard from participants, especially our teenage participants, is that actually it might be also useful to develop some sort of infographic, which I'm also working on, might be a preferred method for them for reading and learning some of these things. So I think like a combination of those things, online resources for our teens that are short and sweet, concise, they can look at it on Instagram, like whatever, we can share it widely. But absolutely, I think it'd be useful to have resources like this available for transition, and not just transition, but also starting young. Like that's why we made the video to be accessible to kids of all ages, because it really does start young. Like our one participant said there, he learned about that normal blood cells can carry oxygen, sickle cells can't, and I just like that just warmed my heart when he said that he took that away from the video. So yeah, it definitely could be a part of that, but also starting young.
Mm-hmm. One last comment before we move on, if you don't mind. So Marianne de Montalembert from l'Hôpital Necker in Paris, she has developed what we call Education Thérapeutique. It's a very comprehensive, I can show it to you afterwards, from Rossef. It's a very good sort of package that sort of includes elements of what you're doing as well. I think that's something maybe you can look into as well.
Yeah, that's very interesting. Thank you.
Okay, moving on to the next. Thank you very much.
Thank you.
So moving into abstract 10 by Rob Klassen, presented by Rob Klassen on quality of life in transfusion-dependent thalassaemic patients during COVID-19 in Greece. Do you have any questions, Stephanie, from the online audience?
No.
I have a question. How do you postulate that people who are married and have higher educational status with thalassemia had a worse quality of life?
I'm screwed.
During COVID.
Yeah, so I think I'm a little bit of a disadvantage because I don't live in northern Greece. So I did ask because obviously is a initially kind of surprising concept, but I think better educated people kind of understood the concerns around COVID, whereas less educated people kind of maybe ignored it. So I think the education to me is clearer. The marriage one I didn't totally understand, but the thought was the fact that you're more worried about bringing the COVID home to your family and to your children. So I think there's this I think there's just a lot more worry in that group. And there's, you have to keep in mind that there's definitely overlap between older people tend to be married and tend to, I guess the education less so, but I think the marriage and the age, but he did say that they're independent variables. So I thought that was, but it does kind of make sense when you think about being more worried when you're about catching something. And I certainly know I have single daughters. They worried much less about COVID than potentially, older people because they're out having fun.
So Rob, I've got a question for you. So what is the VIF then for the three things that you described: education, the marriage, and being older? Did you see collinearity in these three variables, or were there none?
Well, like I say, there's definitely certainly age and marriage tend to run together, but they were sort of. Again, I didn't actually do the data analysis. Philippos did that, so I could certainly ask him about how much they kind of run together.
It'll be interesting to see what the VIF is, because if it's above 2, then you know that there's some sort of collinearity involved, and it's just being older sucks, as you say. I don't know how you kept a straight face on when you're recording that video.
I think there was some data, though, that people who are married suffered more during COVID, maybe because you were locked down in a house together, not going to work all the time. But I remember that in the beginning of COVID, there was a lot of, at least media and some data on that in the very beginning, mainly from New York, maybe because they live in small apartments.
Yes. Yeah. Great.
Anyone else from either online or from the live audience here? Okay, and seeing none, I'm going to ask Stephanie to introduce the last abstract.
So the last abstract was by Sarah Maud Desforges. So it's the abstract about the prospective validation of the RUDAS. I don't have any questions online right now. Maybe in the audience.
I had a question about, so your scores went up.
Yeah.
In the population that had no neurological damage, correct?
Yes, exactly.
Okay. Any postulations on why?
Yeah, we thought about that because we talked with a neuropsychologist, and there could have been, like the test could have become more familiar to the patients. So maybe a few years later it was more familiar. And also there could have been intensification of the treatment over the years. So that could have been an explanation too. So we're not sure.
Good old Hawthorne effect.
But we plan to study that afterwards to see if it could have been the reason why. Yeah.
It's really heartening to see, though. It's positive data about cognitive function, not at least declining even a few years apart. Though it's lovely to see that.
Yeah.
Stephanie, anyone from the online audience?
No.
Okay.
Thank you.
All right, thank you. So this concludes the abstract presentation. Thank you very much again to all the participants, and also to everyone who is present either online or in person. Please make sure you fill in your evaluations for the abstract, because we will be dishing out prizes, I presume. Yeah. Well, apparently there's a surprise prize, so please help out. We need that distributed. Thanks, Stephanie.
Thanks, Stephanie. Thank you, everyone. We're running about 12 minutes behind, which is not terrible. I think we still need a coffee break and people stretch their legs and that sort of thing. But if you could come back within about 10 minutes, that would be wonderful. Our next speaker will be virtual again, and Tanya's going to introduce the speakers at that time. So if you could be a little bit punctual coming back in 10 minutes, grab coffee, stretch your legs. Oh yes, please mark the top abstract, fold up the paper. If you can't pick out number 1, do a 1, 2, 3 thing, fold up the paper, because we have, of course, curious potential winners. And then maybe stick them on the front table and we'll collect them during the coffee break.
Thank you. We have a lot to cover today and some exciting panel discussions at the end, so we really want to get back on track if we can, please. Thank you. I'm Tanya Petrasco from Canadian Blood Services in Vancouver. I'm really thrilled to be here. I would ask the gentleman at the back to bring up the pre-recorded presentation, if you would. Thank you, while I introduce the next two speakers. And if it's all right with Dr. Bruce, I'll introduce both of them at the same time. Okay, great. So the first speaker, so I'm happy that two of my colleagues are here from Canadian Blood Services to talk to you about our rare blood program, our current state in genomics, and the future potentially of genomics at Canadian Blood Services. Our first speaker is Dr. Selena Montemayor. She unfortunately is remote from Toronto, having recorded her talk there, but she originally earned her medical degree in Mexico and holds a PhD in molecular and cellular biology from Baylor College of Medicine in Texas. She's board certified in anatomic pathology, clinical pathology, and transfusion medicine by the American Board of Pathology. She completed her clinical and research transfusion medicine fellowship at the U.S. National Institutes of Health in 2017, and she subsequently joined the NIH Clinical Center staff as an assistant clinical investigator in the Department of Transfusion Medicine. She joined Canadian Blood Services in August 2020, and she provides medical services for the rare blood and red cell genotyping programs. She's Dr. Montemayor's main clinical and research interest is the application of genomics and bioinformatics into the field of immunohematology. At the NIH, she developed an open source software that translates next generation sequencing into a precise, extended RBC and platelet phenotype. Dr. Montemayor has presented her research at various Canadian and US forums, as well as internationally, and she addressed the transformative power of genomics for the future of blood industry at the 2019 National Foundation Cord Summit. She is a huge champion of diversity, equity, inclusion, and access to healthcare for all patients. She'll be followed by my colleague, Dr. Clark, who is here with us. She's a hematopathologist and transfusion medicine physician who trained and later worked for many years in Edmonton and at the University of Alberta, following her medical and postgraduate training. Currently, she works in transfusion medicine with us at Canadian Blood Services, and she's the medical lead for donor testing and diagnostic patient testing, all of our laboratories. And she's the medical lead for the Canadian Blood Services rare blood program, and she neglected to say that she established this. This was something that she created and has been her brainchild and her passion, one of many. She also works in diagnostic hematopathology with Island Health in Victoria, BC, and her clinical research interests include rare red cell phenotypes, immunohematology testing, and prenatal immunohematology. She teaches residents in transfusion medicine, volunteers with the Royal College of Physicians and Surgeons as the residency program accreditation reviewer for transfusion medicine, and she serves as the Secretary General for ISBT, the International Society of Blood Transfusion. And when she's not at work, she loves to bake bread, read books, and go for long rambles with her dog Kel, who you might know is named after a blood antigen. So we'll turn the floor over to Dr. Montemayor's recorded presentation.
Hello, everyone. Thank you for the invitation to present to you today on the genotyping of blood group antigens that we perform at CBS. Today, I'd like to discuss with you the applications of molecular testing to provide a precise and comprehensive donor and patient blood type. To do this, we will first review the genomic basis of blood groups and the genomic acid principles that are used to predict a blood phenotype. We will describe the blood group genetic diversity that has been documented in Canadian donors per self-reported race and ethnicity. And finally, we will also discuss the CBS educational resources and our clinical consultation support for red cell antigen genotyping. Let's start with the basics. What is a blood group? When we think about a blood group, we are thinking of polymorphic molecules that are in the surface of the red blood cells. I like to use the KIT blood group as an example, which is the one that you are looking at right now. KIT If we were to zoom in on the surface of this red blood cell, it's actually a transmembrane protein, as you can see, whose role is to transport urea. It just so happens that this molecule can look different in different people. And specifically in this extracellular loop in position 280. About half of us listening to this lecture have at least some copies of aspartic acid in this position, while some of the population may have a different amino acid, asparagine, in this position. If, for example, all my molecules carry aspartic acid, and I get transfused with a red blood cell from a donor that has asparagine in this position, my immune system may look at this different amino acid and recognize it as foreign, and it may do its job, which is to make antibodies to foreign molecule. That is the basis of alloimmunization and blood compatibility. As we all know, the compatibility of the transfused blood product with the recipient's blood type is critical so that the transfusion has clinical efficacy and it is safe. The traditional way of doing blood typing to determine this compatibility is through a method known as serologic agglutination. You may be familiar with it. It consists of adding an antibody to the blood sample that is directed to the cognate antigen, for example, blood group A or blood group B. Then sometimes we need to add additional antibodies, but if this antibody finds its antigen on the red blood cell, this results in the cells clumping up or agglutinating, which we can look at visually, and this will be called a positive agglutination. This works very well. However, it is not valid if the patient is frequently or recently transfused. For example, if this patient had been transfused 2 weeks ago, how do we know if the agglutinated cells are those of the own patient and the antigens that the patient recognizes as self, or those of the transfused circulating cells? In these cases, however, we can take advantage of molecular testing. This is the list of blood groups that we know today. We know 43 blood groups that encode for 378 polymorphic molecules in the surface of the red blood cells. For 345 of them, we know the genetic basis that encodes them. So that's when we start talking about DNA and molecular assays. Think of DNA as a book of a combination of 4 letters. And if we know exactly which chapter, which page, and which line to look at, we can actually read to understand which are the antigens of the blood cells that are being encoded and expressed. If we go back to the example that we were looking at, which is KID, this polymorphic blood antigen is encoded right here on chromosome 18 in the long arm. If we were to zoom in into this area, we would see that this gene, which encodes for KID, is located there. The areas that are in blue blobs are the ones that actually encode for the protein. They're known as exons. And in this area right here, if we were to zoom in, is where that difference of JKA and JKB is encoded. Specifically, if we start counting those letters from here all the way here, when we get to position 45,739,554, then if we find a G, it means that it's encoding for aspartic acid and for the JKA antigen. But if we find an A, that means that it is encoding for the JKB antigen. Now remember, traditionally we carry 2 copies of every gene, one inherited from each parent. Therefore, you could also carry 1 G and 1 A. And in that case, some molecules are JKA pos, some are JKB pos, and the patient is positive for both and will not form an allo antibody to either of them. This is how we read the book. We read the DNA to predict with precision which are the blood antigens that are expressed in the donor's or a patient's red cells. So we come back again to our list of 43 blood groups and 348 antigens distributed here, for which we know the genetic basis. There are over 1,600 specific DNA variants that are documented that we can now assay with molecular methods to determine this precise phenotype. All of these genes are located across the human genome in all but 5 of the human chromosomes. Each chromosome is inherited independently. So what this means is that there is a very, very wide and vast number of possible combinations of the different blood antigens, and that these are inherited. They are inherited within populations, and therefore they tend to show different frequencies within the different geographic areas of the globe. The highest diversity that we observe is in individuals of African descent. Let's talk about another advantage of doing genotyping when it comes to blood antigens. For example, these are 2 different genotypes that we can find in patients with hemoglobinopathy. If we were to do the traditional serologic typing, we would find that there is agglutination with anti-little e, and we would call both units little e positive. However, there are slight differences in that DNA encoding and in the shape of each of these molecules. And in reality, now we know that, for example, this genotype lacks an antigen known as HRV, and this genotype lacks an antigen known as HRS. We can only determine that through molecular methods, and in fact, these 2 units would not be compatible for a patient of the opposite genotype. And sometimes it is optimal to give a transfusion that is most similar genetically to the patient. So molecular methods give us this higher precision to detect what we call variant or partial antigen expression. So to summarize, genotyping of red cell antigens is useful for patients that have been recently transfused, for patients that have antibodies to antigens that have high or low frequency, for which, for example, we don't have serology or that antibody available commercially to do the traditional serologic agglutination, and to identify this partial or variant antigen expression. In addition, it is helpful to identify rare donors. At CBS, every donor is provided an optional question 1 time to self-identify within a given racial and ethnic group. The categories that you see here are the categories that are currently available for the donor to select. We understand that they do not accurately describe the wide diversity of identities in our communities, and they will be revised shortly. We also welcome feedback. When we select donor samples for genotyping, we do it according to a predetermined plan in order to enrich for diversity. So here you see the 2,720 donors that had genotyping for red cell antigens performed between the period of May 2018 and January of this year. And the graph is showing you the distribution of self-reported race and ethnicity for this cohort. This is the assay that we currently use for genotyping of red cell antigens. I'll just go over it very briefly. Essentially, it involves amplifying each of those specific segments of the DNA that we know are important for encoding those different blood antigens. Then there are beads that have different colors, and the DNA that we amplify will hybridize or not to a probe that is bound to those beads. All of this complex then goes through a modified flow cytometry where lasers tell us which is the color of the bead and therefore what the probe is interrogating for, and also they tell us if that sample's DNA was a match and is hybridized and is present attached to the bead. These are the results for the cohort of donors that I was showing earlier. In the top, you see the list of all the 38 blood group antigens that we can predict with this molecular assay in one go. Compare this, for example, to 11 antigens that we routinely test for by the serologic agglutination method. And in every row, you can see each of the self-identified race and ethnicity categories when entered by that donor. So in this graph, the percent of positivity for each of the antigens listed at the top is color-coded. The closer the square goes to this dark cyan blue, then it means that it's closer to 100%. Every type donor was positive. The closer that the shade goes to zero, or to white, then it means that that frequency is closer to zero. And as you can see already through the graph, different patterns jump out right away. For example, here we see that in the V and the VS antigen, in these two columns, these two squares are darker. And this is the higher frequency of the V and the VS antigens, which is identified in the group of donors that self-identifies as Black. The next higher frequency was observed in the group of donors that self-identified as Arabic. If we look around in the table, we'll see, for example, that the lowest shade and the lowest frequency of Duffy B, as well as the lowest frequency of the Big S and the Dunbrook A, were found in the donor population that self-identified as Asian. On the other hand, the highest frequency of the Big K, the highest frequency of YTB and lowest of YTA is found in the group of donor that self-identifies as Arabic. Finally, let's take a look at the U antigen, or universal. While this is very darkly colored and very frequent across all donors, we see that the presence of a negative U antigen typing is identified in the group of donors that self-identifies as Black. So now let's look at phenotype combinations. Here we see, for each of the racial and ethnic categories, the frequency of finding a unit that is positive for the D antigen, negative for big C, negative for big E, and negative for big K. This is a frequent extended phenotype request to support the transfusion of hemoglobinopathy patients. As you can see, the probability of finding such a unit is higher in the donor group that self-identifies as Black. If we look for even more extended matching, meaning JKB negative and Duffy A negative, also a frequent combination requested for hemoglobinopathy patients, the same trend remains. And again, if we extend and add Big S negative, which is an extended phenotype that may be requested for hemoglobinopathy patients, we see the same trend, where the probability of finding this type of compatible unit is higher among the group of donors that self-identifies as Black. If we look at those variants in the RHCE system that we were talking about earlier, where the antigens have small differences, and we can find that through molecular, then we also see that they are more frequent in the donor population that self-identifies as Black. And when we compare that to the genotyping that we obtained from patient typing, for example, last year, we see that 8% of our patients are actually carrying one of these variants. Because variation is even more frequent in the RHD gene, then samples from hemoglobinopathy patients that are reported to be D-pos or undetermined for the D antigen are automatically reflex for RHD genotyping. Now I'd like to pivot and tell you a little bit about the educational resources and our consultation support. We have created open educational modules that you can access at the professionaleducation.blog.ca site that is listed here. You can find it through the best practices section in the red cell antigen genotyping reports. If you click on it, you'll see that currently we have an open module, which we call the quick glance to the red cell antigen genotyping report, and that there is a second course that will be coming very soon. This is what that quick glance course looks like. It is an interactive module where you can click through the different parts of the report, and it'll display an explanation for how the results are reported, and also an interpretation of the specific example that is depicted in this model report. There is also an option to download a PDF of a one-page summary of all the content of the course, so that you can print it and have it handy to look at it whenever you're interpreting a red cell genotyping report. And most importantly, it highlights our contact number, which is right here. I welcome all of you to call us anytime if you would like to consult with us regarding the interpretation of a red cell antigen genotyping report or the determination of an optimal transfusion strategy for our hemoglobinopathy patients. If you call this number and hit option 3, which is genotyping, a member of our staff will take your message. If it's after hours, you may leave a message, and within 24 hours, one of us will call you back to talk to you and discuss any possible questions. Again, this is our contact number, and this is one of the statements that we have in our training modules. As you know, hemoglobinopathy transfusion support may be complex, and we have to take into account many different variables, not just the genotyping results, but also the phenotyping history, alloimmunization history, the clinical situation, the history of transfusion support throughout the patient's lifetime. So all of these pieces have to be put together to arrive at the best transfusion strategy for each patient. We are also available to provide this support. For example, this is what one of our red cell antigen reports was reporting, and this is one of the cases where the customer called us to discuss further details about the case. When we do that, we are also happy to issue a supplementary report that documents the conversation that we had verbally and the recommendations. For example, in this case, the diagnosis, the history of alloimmunization, the results of the antibody screen were discussed, and then we give an interim transfusion strategy as well as recommendations for monitoring for alloimmunization. This is a second example of a red cell antigen genotyping report that resulted also in a consultation where we learned about the recent transfusions, the antibody screen results, the fact that there have been no transfusion reactions or complications, and again, we conclude with a transfusion strategy recommendation as well as for instructions for monitoring for alloimmunization. Please don't hesitate to call us if you have any questions or if you'd like further consultation. I would also like to show you the second training course, which will be released shortly. This is a more comprehensive course that is walking our students through more details of the genotyping assay, as well as through some of the specific blood group genomic variants that we can find in hemoglobinopathy patients. As you can see, it has 9 sections. I'll show you a couple of examples. One of the sections focuses on the Duffy-Kata box variation that we can see in hemoglobinopathy patients. It contains videos, as the one you see here. These videos are narrated, and we will include captions. Then it also has this type of tables with summary, highlights your key learning points, special notes and exceptions, and references with hyperlinks that will take you straight to the source of this paper so that you can download and review. You can go back and go through every section as many times as necessary. This is another example where this chapter dives deeply into the R' S allele, a variant in the Rh blood groups that we can also find in hemoglobinopathy patients. As you can see, there is a narrated video, goes slowly through every single variation and its implications, but then we provide a table summary and the key learning point. There is also at the end a form to provide us with feedback or to request additional training materials or topics to be addressed in our future educational resources. This comprehensive course also includes a knowledge check at the end and the possibility of downloading a certificate of completion. So, as you remember, molecular is very powerful in clinical scenarios for hemoglobinopathy patients, and it allows us to look at this very wide range of blood group antigens in one assay. But the assays are directed to the variants that are most frequently found. So, let's remember our example. For example, our assay, when it comes to the KIT blood group, is looking at variations in these 3 positions, which are JKA, JKB, and variations that make it a KIT no, that silence the expression. And these are the most frequent. But for example, if the sample is carrying a variation in this area of the gene, which is a very rare variant that has been reported and that leads to silencing of the whole blood group, then an assay that is only looking at these sections will miss it. So when we suspect that there is a rare or novel variant, we turn to DNA sequencing. DNA sequencing essentially takes that gene and just reads from beginning to end. So it is able to find every variant, not just the most common ones, but also the rare ones. And it can also detect any new variants that may be identified in our population that may not yet be documented in the literature. In 2021, we referred over 100 patient and donor samples for gene sequencing, and this resulted in 20 samples that revealed a novel blood group genomic variant in our population. Our aspiration is to create these sequencing assays here in Canada and bring them into our Canadian laboratories and to grow our genomics program so that we can provide precise typing for also rare and novel variants. In conclusion, donor and patient blood groups are a testament to our wide population diversity, and recruitment and retention of an inclusive and diverse donor base, along with a growing genomics program, can strengthen our rare blood inventory. Remember that CBS consultation is always available for the interpretation of red cell genotyping reports and transfusion support of hemoglobinopathy patients. I'd like to acknowledge our donors and the genomics staff at CBS. I leave you with our contact number. Thank you for your attention today, and I will be happy to take any questions.
We'll save questions to the end, and I'd like to invite Dr. Clark up.
Thank you. I've learned several things today. One of them is try not to follow Selena's presentations. Anyway, having said that, I think it actually fits together pretty well. So thank you very much to Aisha and all the organizers for inviting me to come and speak to you today. It's really a pleasure, and as Selena highlighted, I think it's really important that we work together as blood suppliers and as treaters to make sure that we're providing the right products to these patients. So I'm going to talk to you a bit today about finding rare blood in Canada. So what are the tools that we can use to identify the best units for your patients who have these unique phenotypes and combinations? I have no conflicts to declare. And basically what I'm going to do is outline the basis of rare phenotypes. So what makes somebody rare? So a little bit about what Selena already talked about and a few additional details. Then I'm going to discuss the Rare Blood Program and how we try and work with you to find the best units for your patients. And along the way, we're going to discuss a couple of case examples. So this is just a primer, really, quite a bit lower level than Selena just presented to you, but I think will serve to illustrate a few things. So as Selena went over, alloimmunization to red cell antigens, whenever we transfuse something that's not exactly like our own red cells, is a risk. And all transfusion recipients are at risk of developing antibodies to red cell antigens that are different than their own. So if we just look at a broad swath of all transfusion recipients and you look in the literature, the risk of making an antibody is really wide depending on who you read, anywhere between 2 and 10%. I usually quote about 5% of all transfusion recipients. If you narrow that down a little bit to just those people that get a lot of blood, so people that are transfused very regularly, and the definition is shown there, then that rate of alloimmunization goes up because you're exposing them more often or over a longer period of time, and it ends up being about 12% across all patient subgroups. If you narrow that down further to patients with hematologic disorders that are regularly transfused, it goes up even more. And if you look at sickle cell disease patients, then we know that for many reasons, some of which are not very well understood, the alloimmunization rate is even higher, up to maybe as many as 30, and some literature suggests even higher populations over long-term transfusions. So this is a problem in everybody we transfuse, and it's a problem that's magnified in those that we transfuse chronically and in those with hemoglobinopathies. Why do we want to avoid this? Well, once somebody has an alloantibody, not only does it complicate their future transfusion therapy, but of course, it also may have impacts on their clinical care in terms of the risk for delayed transfusion reactions or hyperhemolysis. So mostly we want to prevent this where we can. And so really that's what the rest of this talk is about, is how can we match people that have really unusual or rare phenotypes in order to help prevent alloimmunization even in this subgroup of patients. So this is a very basic primer on blood group antigens. We're all aware probably of what our ABO and our H blood group are. So this is a group A red cell. The one on the right side of the screen is Rh positive, and you can see that it has A antigens stuck onto something called an H precursor substance, and there's some D hanging around. That's the Rh part, the Rh positive. So the one on the right is an Rh positive. The one on the left has A hanging onto the outside of the red cells, but there is no D antigen, so that's a negative red cell. If we do the same thing with group O, then we see that we don't have any A or B on these cells. We still have that H precursor substance, and you either do or do not have D, making you Rh positive on the right or Rh negative on the left. But of course, as Selena alluded to, there's many other red cell antigens, and this is an example of an O positive red cell. There's no A or B, there's lots of H, there's D on this cell, so it's Rh positive, and there's all these other things, Kel, big C, big E, little e. And again, as Selena talked about, the particular variation that you have probably is related to your ethnic background. So the combinations of antigens that we have, just like the color of our hair or our eyes, depend on what our ethnic background is. And some examples that I've shown here is that O positive with negative for big C, big E, Cal, and Duffy A or B is more common amongst those of African ancestry. On the other hand, being O positive or B positive but missing JKA and JKB is more common amongst those with Filipino or Pacific Islander background. So variations in which of these antigens you have or which combinations you have does depend on ethnic group, and what's rare in one ethnic group might be less rare in another. So what's rare? Well, here's a rare cell that lacks a common red blood cell antigen. So what I'm showing you now is just a common O positive combination of red cell antigens, and you'll note in particular that both big S and little s are present. So if somebody lacks both of those, like this cell, then they'll also be U negative. That's another antigen that Selena alluded to. And being U negative is quite unusual. And you might make an anti-U, and if that happened, then since almost everybody else has a U, then it's going to be hard to find blood for you, and you're going to be a rare patient, or if we're lucky, a rare donor. Another way that we could find something rare is you can see this person has E and C antigens on them, small e and big C, but I've taken a chunk out of one of them and added something onto the other. So this is somebody that has the regular antigens, but they're not, but they're varied or variant antigens. So another way to be rare is to have a regular complement of antigens on your red cells, but with variations in those particular antigens. So somebody that has this variation may be able to make an antibody to a regular or wild type little e. And so rare variants, or making variants, is also another way to be rare. So to summarize all of that, you can be rare in broadly 3 ways. You can have an unusual combination of antigens, different than most donors. You can have negative for high prevalence, the U negative that I showed you, so you're missing something that almost everybody else has. Or you can have a variation in your particular antigens that makes your antigens just a little bit different than other people's antigens with the same name, but different enough that you could still make an antibody. So those are very simplistically and broadly what we refer to as people with rare phenotypes. I'm just going to tempt you with a little story about a patient, TG, a sickle cell disease patient who had a history of hyperhemolysis and also had multiple antibodies and a rare combination phenotype. So O positive, CE Cal negative, Duffy A neg, B neg, JKB neg, S neg, and a range of other things that I didn't really talk about in those previous slides, all of which added up to, when we look just in our regular inventory, I'm going to show you more of these, but this is an inventory search at CBS, and the bottom line is it's empty. So if we just did a search at that minute for that patient that entirely matched their phenotype, we found nothing. So I'm going to talk to you for the rest of the presentation about how we would go about filling up this chart a little bit better. So how do we find rare red cell donors with the combinations that we need? So this was an interesting photograph search to do. In the end, I had to appeal to my kid to figure out how to do this search. What I was looking for is a way to illustrate something that I consider sort of a unique architectural gem in the midst of a modern manufacturing environment. And that's really what the Rare Blood Program at CBS is. So it is within our Medical Services division at Canadian Blood Services. And what we do is manage inquiries and orders. So if you're just calling to ask about, would you guys have any donors that would meet this need? So inquiries or actual orders for blood cells for patients that would be considered rare, where we do that search and the search comes up empty. That's where the Rare Blood program comes in. And so what do? Well, we consult with the clinical team. That's probably the most important thing. Thinking about things like, what's the timing of this need? Do you need it yesterday, or is this something that we can work towards over the next month or so? What is the best phenotype for the patient, and how close can we get to that optimal phenotype? And what are the options? What's plan A, plan B, and plan C for this patient? So working together based on what do we have in the donor registry and what does your patient need? And doing so, trying to prospectively recruit donors to fill up that inventory sheet a little better. In the background, of course, if we have more donors that have these rare phenotypes, then we're less likely to have that empty search. So the Rare Blood program is also involved, along with our partners in marketing and donor recruitment and donor relations, in recruiting and retaining donors that are known to have rare phenotypes, and in identifying and communicating with new rare donors to try and make sure that they're part of our donation program as well. So how do we do all this? It seems to take about 3 clicks for every. So the Rare Blood program works across a few different things. When we're trying to optimize this, we really need to think about recruiting new donors and maintaining the ones we have, as I alluded to. But as Selena alluded to, it also helps if we test the largest number of donors possible so that we can find those in our midst that are rare but we haven't found yet. So testing for rare red cell antigens and antibodies using both phenotyping and genotyping. Sometimes we're triggered to the idea that this person has a rare phenotype because they have an antibody. This could be a donor or a patient. It's the antibody that they made that tells us that they're missing a common antigen, and then we can phenotype and genotype them to confirm that and ideally recruit them to be an ongoing blood donor. So we want to see all of these patient samples, ideally at our National Reference Lab where we have the tools that Selena alluded to. And we also test our donors through that National Reference Lab, again, trying to identify the maximal number that have rare phenotypes. Once we find them, we try and maintain them as part of our registry of rare donors. We notify them that they're rare, we send them letters and cards of thanks when they come in to donate, and probably most importantly, we stay in touch. So we try and touch base with even the donors that don't donate regularly, that come in only intermittently when we ask them to. We at least try and stay in touch with them annually or semi-annually to make sure that they keep their demographics up to date and that we can find them when we need to. We have lots of great stories about finding donors after long periods away, and so that's an important part of what the staff in the Rare Blood program do. We also maintain a really expansive frozen inventory of units that I'll allude to a little bit more later in the presentation, but we have a complex series of rules around which units we should be freezing. And having those in frozen inventory offers us a really nice, stable repository of those rare units that will be there within hours of when you need them, whereas recruiting a donor or new donors in might take considerably longer. So that's a really important linchpin of the Rare Blood program. And then last but not least, collaborating with blood suppliers from around Canada in terms of Héma-Québec, and also from around the world to recruit and retain units from other countries where a particular phenotype may be more common. So all of these are tools that we use to try and meet the needs of individual patients. Just going back to the testing portion of that slide, as Selena talked about, we do both phenotyping and genotyping of donors. And this is an interesting slide from a presentation that our colleague Dr. Goldman made at CSTM earlier this year, where they looked at the donor ethnicity question, which helps to guide what tests we do on the blood. 96% of donors actually answer that voluntary question. And as you can see in the graphs at the bottom, first-time donors are substantially more diverse than repeat donors. So on the far left of the screen is just a StatsCan general population diversity graph showing non-white versus white individuals in Canada in 2016. And you can see that if we look at all donors on the far right, repeat donors, the number that are from diverse populations is relatively small compared to the Canadian population. But if you look at the graph in the middle of first-time donors, we're a lot closer to the Canadian population. And that really reflects the efforts of all of you and many at CBS in trying to ensure that donors that we're recruiting reflect the diversity of the Canadian population. So a long way to go, but certainly we're making steps forward when you look at our new donor recruitments in the recent past. When we look at some of our genotyping results from 2020 and 2021, this is just a little snapshot of some of the rare phenotypes that we found through that testing program. So just again, a list of rare phenotypes and the number of donors. And you know, when you think of hundreds of thousands of donors that come through our doors every year, this is really a small drop in the bucket. But we're really happy when we find 2 or 3 of these rare donors. That makes a big difference to the patients that have these phenotypes. So finding 2 or 3 or 10 donors in a year really is a huge success. One of the important tools that we use in terms of sourcing blood for patients is making sure that we're using our whole national inventory. So it used to be, prior to the days of the Rare Blood Program, that every center dealt pretty locally with trying to meet patient needs in that province or that region of the country. And now we really encourage all of our distribution staff to look widely across the country, because it could very well be that there are units that we could use that were collected in Halifax, or units that are needed in Brampton may have been collected in Vancouver. So one of the big powerful features of our Red Blood Program is really making use of our national inventory, and we do that regularly. The stars in Vancouver, Edmonton, Brampton, and Dartmouth reflect where we store our rare frozen inventory, and again, that's intentional, trying to make sure that we have a frozen bank located in cities across the country, so that there's somewhere relatively close by for patients regardless of where they may reside in Canada. And we will move frozen inventory around the country as required in order, if we know that there's a patient, for example, right now we have a patient that is going to need blood at delivery in the Toronto area, and we have units in Vancouver. So prior to her date of delivery, we will ensure that we move frozen inventory from one end of the country to the other. So that's another of our tools, making use of our geographic locations of our frozen bank. There we go. So how do we decide how many units we need to keep frozen? There's lots of things that go into making a frozen inventory, deciding what ought to be stocked in your freezers, and things including just what is the frequency information in the literature around that particular phenotype. How often have we had requests for that before? So there's odd little pockets. So when you go to international conferences about rare blood, one of the ones that comes up often is the so-called Bombay phenotype, which is missing that H antigen that I showed on all of my original slides. Oddly enough, we have quite a lot of H-negative donors in Canada. So that often isn't a problem for us. We have a pretty big frozen bank. So one of the things we look at when deciding how many to keep is how often we get requests, and how many donors do we have that have that phenotype. How often do we have to do urgent demand typing to find those units, or urgent recruitment to bring those donors in. All of those things would make us want to stock a little bit more in our frozen bank. And then we review the donor and unit numbers. And we have some stats that we've developed over the years to figure out roughly how many donors would have to have that phenotype in order for there to be a liquid unit on the shelf. We've also done modeling studies that suggest to us that if a phenotype is less common than 1 in 3,000, then we won't have it on the shelf at any one time, but if it's more common than that, then we will. So we've used a lot of these tools in developing what is basically a min-max schedule that helps us establish what units we should freeze. And you don't need to read the details of that chart, but basically this is the chart of null phenotypes where a whole antigen is missing. And for these are so rare that any time one of those donors comes through the door, if there isn't immediate need for that unit by a patient, if we haven't recruited the donor in order for it to be transfused to somebody, then we freeze them all across all ABO groups, whether they're RHD positive or RHD negative, and with any associated phenotype. So this is sort of our freeze all category. For phenotype combinations, we try and be a little bit more strategic. So on the right, we see donations from donors known to be Duffy A neg, B neg. And you can see that we've got a sort of min-max inventory where if they're also big C, big E, and JKA neg, then we save 3 to 5 units in our frozen inventory at all time if it's O pos, 5 to 15 if it's O neg, et cetera. So we take an ongoing view of what's in our frozen bank based on how many donors we have with that phenotype, and this is basically a moving target that we adjust every year or two. When a rare donor comes in the door, we want them to be recognized by everybody along the supply chain within Canadian Blood Services. So when they come in, they have what's called an R code or a rare code that the greeters and the donor centers will be able to recognize that they are rare, and we'll be able to converse with them about that. And then, yes, exactly, roll out the red carpet. And then we tag their donation right there in the donor center with that bright green tag that says it's rare. And that's great for the donor, but it's also good for the production and distribution staff to see that this is a unit that needs to be handled with particular care. Not that we don't handle all of our donations with care, and not that we're not grateful for every one that comes in the door. But these are ones that we don't want to lose because of a minor accident. And in fact, if something happened to it, like a little pen mark got on the label, that would be considered a quality event at CBS. We want everything to be perfect. And if it was a regular O-positive unit, we might not keep it. But if it was a unit with a green tag, they certainly wouldn't initiate a quality event and discard that unit without further conversation. So this green tag has a very important purpose in terms of making us think about every step along the way and decide whether there's anything that's happened to that unit that would preclude us from keeping it and putting it in our frozen stores. And of course, once it gets to production, the staff will evaluate it according to that complicated chart that I showed you and decide whether it's one that needs to be frozen. So how do we go about finding these units once we stock them away in our bank? Well, we have a series of really kind of fun search strategies that allow us to put in what we want. So on the left-hand side, we can see negative for whatever, you know, Duffy A neg, Duffy B neg, Cal neg, C neg, E neg. We tally that all up. We say, where do we want it from? And generally, I would select all. I don't care where it was collected, and I don't care where we stored it. There'll be an ABO and RH type that we particularly want to use. And so we fill all those in, and we end up getting a chart of, like the one I showed you earlier that was empty, that shows us what the inventory is. We have a similar search strategy that allows us to find donors with RH-CE variants. And so this is very helpful for those patients that have an RH-CE variant to see if we have any donors that match them precisely. And then last but not least, as I mentioned earlier, we are participants in the International Rare Donor Panel. And this is basically, at this point, a web-based search strategy, similar to the one I've shown you that we use internally within Canadian Blood Services, but internationally. And subscribers to this, participating blood suppliers from all over the world, provide 6 monthly updates to the donors and the frozen inventory that we have on hand. And then anybody in the world that is from one of these blood suppliers can search it and can call us up and say, hey Gwen, do you guys have a JKA neg, JKB neg unit that we could have? And we will supply it to them. You can imagine that the logistics can be a bit difficult, and particularly so during COVID. But for example, we have shipped units to Norway and Hong Kong and to Spain in the last couple of years. Conversely, we have imported units from the American Rare Donor Program, from Quebec quite often, and from Spain as well for one of our patients. So this certainly goes in both directions and is a really important tool for some of the rarest phenotypes. So to go back to our patient TG, remember that initial antigen search yielded no units. This is just a reprint of that. So what we did was look for donors. So what I showed you before was inventory, how many units we had, none. But how many donors do we have? Well, look, it turns out there's a few that actually meet the precise phenotype needs that she had, just that none of them had happened to donate. So we contacted these donors, we told them that there was a patient in need, and we asked them to donate then and to continue donating as soon as they were eligible. And in doing so, we were able to basically build up a bank of frozen units from those few donors, even though there were only 3 donors. If they all come in on their regular donor schedule, over a couple of years we built up about 20 frozen units that are now available when she comes in and needs blood in a hurry. So we've got this stable bank of units that are perfect for TG, that are in our frozen inventory and able to be used if she needs them. There's a list there, so you can, all the frozen inventory that we now have available from those donors that are O negative and O positive and matched all of the other phenotype characteristics that we wanted. This is another patient. I'm able to show her picture because her story has been shared on the Canadian Blood Services website, and I've got the link there below. AM, the little girl in blue, has sickle cell disease, and she has a history of hyperhemolysis and requires regular exchange transfusions of a few units every 4 to 6 weeks. She's CE Cal negative, Duffy A neg, B neg, and those antigens that Selena alluded to, V and VS, negative for her. Those are low prevalence antigens, meaning most donors don't have them, but it also means that we don't often test for them. So in her case, we needed to find units that were otherwise a match and make sure that we had donors that had that phenotype characteristic that were also tested for and labeled for V and VS. So we did a donor search for the basic antigen negative units. Then we undertook some regular recruitment of donors, similar to what we did for TG, and we made sure that those donors we were recruiting had extra testing so that those V and VS antigens would be known and labeled on the units. And then whenever those donors come in and their units are not needed immediately, we freeze them and once again have built up a frozen bank. So for most of her exchanges, there are enough liquid units on the shelf now that are tested and also known to be V and VS negative. But in addition, if we were 1 or 2 units short, we have a frozen inventory that we could deglycerylize, the fancy word for thaw, in order to top up the exchange transfusion for that patient. So now she's able to have regular 5-unit, fully matched transfusion using usually a combination of liquid and frozen inventory. And the last patient is that of a 19-year-old with a hemoglobinopathy that only requires intermittent transfusions. She has an incredibly complex phenotype, partial D, variant CE, with one of the variants that Selena alluded to. She also has an anti-D and an antibody to the very high-frequency anti-RH18 and RH19. So this is really a difficult combination. We had 1 unit collected for her on a prior admission from the American Rare Donor Program. It was specifically held in reserve and is to this day for her. We also have a unit that just lacks all of the RH antigens, so that works. And that's available. That was a prior international import for a patient that did not require it and does not have ongoing need for it. We know that the American Rare Donor Program has 2 donors that are exactly the same genotype as this patient. So that's kind of on our list of places we could go to if we needed units for her. And we have 2 donors that are D positive but lack C and E genes and therefore are also a reasonably good match. We've done some advanced in vitro studies to show that this patient's anti-D is probably not clinically significant. So earlier in the talk I referred to Plan A, Plan B, and Plan C. That's kind of it for her. Plan A would be to find an exact genome match from our partners at the American Rare Donor Program. Plan B would be to use the RH null donors that we have in our inventory. And Plan C would be to not worry about the anti-D and use some additional donors that we have available in Canada. So working with the clinical teams, we can come up with this kind of strategy that would say, what do we do if this patient comes in? So fortunately, she has required relatively few transfusions, and we could meet an acute need with the little stock that we've developed for her, but you could see that ongoing transfusion support, given that we're mainly supplying these from outside of the country, would be very difficult. And this is one of the reasons why we need to proceed with the kind of work that Selena was describing, so that virtually all of our donors are typed and we know all of the ones that have variants and have an even bigger supply of these rare units. So to just summarize, with planning and collaboration, we can source red cells for patients with rare phenotypes, even those with complex needs. TM consultation at your hospital and with CBS in patients that have multiple or rare antibodies can help figure out what that plan is. Who are the donors? Where are those units held? And urgent or chronic transfusion therapy can be difficult to manage, but usually we can help. Suitable units can be saved, frozen, used for a planned transfusion, or possibly for transplantation. Again, some important websites that you can go to, the email for the Rare Blood Program for an inquiry, or just through your regular distribution site. So your blood bank has a good line to CBS at every city in the country, and the distribution staff can certainly forward you to someone from Rare Blood if it's an inquiry about a rare patient. And we have some more information on the Rare Blood Program on the CBS website as well. So I will end there, and thank you very much for your attention.
Here's a microphone.
Thank you. I think I have to work this chat box, so if you don't mind. Thank you.
So, thank you very much, Gwen and Selena. Are we pulling? Perfect, there's Selena up. Those were fabulous presentations, and these are wonderful individuals to actually have in your back pocket. There's been many times on a weekend and late at night I've called one or both of them as I need help. So it is a fabulous program, fabulous resources, and it's amazing in terms of the changes that have been able to be implemented over the last several years under your direction. Are there any questions in the chat box, Tanya? Okay, so Ziad, if we can get you to speak in the mic.
Thank you guys, both amazing talks, and you know, we live and breathe transfusion, and we still learn so much every time we listen to you guys talking. So I have 2 questions. My first question is to Gwen, and my second is to both of you. My first question is about patient AM, the one who had a history of hyperhemolysis, and we're still transfusing. So you know, I guess she's no longer as sensitized maybe, but you know, this would not be likely very sustainable long term as she grows and her weight rises and her transfusion needs rise for that exchange transfusion indication if it remains. And so does CBS have a way to sustain that long term, or are there conversations with the clinicians to transplant the patient and kind of cure the disease? Would CBS have a role in that sense?
Yeah, great question. I didn't plant it, but it's actually one of my big bandwagons. I actually spoke with one of our other CBS physicians, Matt Septel, at the transplant meeting earlier in June to really encourage all of you treaters to consider transplant. I worry that sometimes when there's a really complex phenotype that you sort of think, well, we're not going to transplant because the phenotype is too hard. But I think on a one-time basis to maintain somebody through transplant, we're much more likely to be able to do that than to maintain a chronic transfusion regimen for their lifetime. So, I'm not a transplant expert, but I would encourage you to think about that and to talk about it with your transplant colleagues as a collaboration to figure out how could we source enough units to get this particular patient through transplant. And I think that's really an important conversation.
Right. A follow-up to that is, so how was the decision made to keep transfusing someone like this? Because it's an absolute contraindication to stop transfusion.
In her case, maybe I overstated hyperhemolysis. She had a hemolytic event around the time of a surgical procedure and was thought to be hyperhemolysis. But I can't speak to the details, but her treaters seem to think that this is the best regimen for her at present.
Okay, well, I have a similar patient. I might call you, but I'll let you know.
I can connect you with her doctors.
The second question I have was to both of you. And so we get these beautiful reports of genotyping, and the summary at the end speaks to just the exact concerns with the rare genotype. But it would be great for hospitals to also receive a bit of well, this combination leads to an incidence in our donor pool of only 1% or only 5% or only 20%. Just that's easier to communicate to patients than here's your big, genotype report, or which translates into a phenotype prediction. Is that already in the reports that I've missed, or is that something we can work towards?
Yeah, Selena, do you want to comment on putting the percentage?
Can you guys hear me?
Yeah.
That's good. I may have missed a little bit of the question, but as far as I understand, it's about given, say, the frequency of that particular extended phenotype in our donor population. Is that correct?
Yes.
Okay, good. Thank you. So great suggestion. Thank you. We welcome this and all the feedback that you may have. We currently have some statistics. In particular, some of these rare phenotypes, as we spoke, really require the molecular technology to be able to be detected. So we hope that we're able to grow the genomics program. And now some of the statistics that we have, we do aspire to place them in our website and to periodically update them as a reference. As far as given the particular combination, there are a few items that are important, which is when we give the genotype, that's the entire predicted phenotype, it really requires a knowledge of the entire case, including the diagnosis, prior alloimmunization, to truly know what's the degree of extended matching that is needed. And on that degree of extended matching, then the percentage of, say, compatible donors would depend. So that's why sometimes when we provide the genotype report, we really encourage you to call us so that we can discuss the case further. We can narrow down that transfusion strategy, and then we will work towards getting additional donor genotype and posting those statistics on our website. Thank you for the suggestion.
Okay, and I saw a question in the back.
Hi, thanks. This is for Dr. Montemayor. So this is a bit of a philosophical question, I guess, but there are two sides to making an antibody to a blood group. One is to have a mismatched blood group, but the other is to make the antibody. And we give blood to people all the time that have antigens that they don't have, and most of them don't make an antibody. So is there movement to testing the immune response side as part of our profiling?
What a wonderful question. Thank you. That is, in my opinion, one of the biggest questions in immunohematology.
as you said, not everybody actually makes an allo antibody when exposed to a foreign antigen. And Dr. Clark did a very good job of describing the different incidences of alloimmunization that have been documented. But if we're able to understand what determines that a particular patient will respond upon being exposed to a foreign antigen, that would totally change the way that we do transfusion management and product selection. At the moment, we do not know that. But clinical experience suggests that there are some individuals that may be more prone to this type of response, and it may actually also be related to the clinical scenario, the degree of inflammation. There is active work in this area, and I think it should be a priority for immunohematology.
Thank you. The mic's there.
I just kind of want to make a comment for people who haven't been in the game as long as I have. When I started the Children's Hospital of Eastern Ontario, which is a standalone children's hospital, we have a very small blood bank. I took over the hemoglobinopathies program about 20 years ago. They were not doing any extended testing, and I talked to our blood bank, and their philosophy was, well, we'll wait till somebody develops an antibody, and then we'll do the extended testing. And so I just want to say, kudos to you guys for it's so advanced so much in a very short period of time. Like, this is amazing. I just want to make a comment.
Thank you for that.
Just a note in the chat from Lauren Bolster, the University of Alberta. Thank you to Gwen and Susan and the whole TM team for supporting our patients.
We've got another question over there. Is there a mic?
I have a loud voice. Although you can't hear it on the recording.
Hello? Okay. Dr. Clark, in particular, I wanted to thank you because recently I've been in touch with your department about a new patient to our clinic who's S negative. And of course, that sent us, well, me particularly, into a panic. I know Dr. Bolster wasn't so much in a panic, but because I was in touch with the patient to talk to him about it, and he was quite concerned, but I had to reassure him, and we wanted to move forward on how to find out about resources for him should he ever need a transfusion. Now, of course, at the moment he's very stable, doesn't need anything like that, but with that particular antigen negative case, I'm very interested to know what are the resources that we currently know about for this patient.
So the way to do that, even though they don't need blood, arguably that's the best time to sort of sort out a plan, and just making an inquiry. So having the blood bank at the U of A send an inquiry to the distribution site would make its way to the rare blood program, and we would basically open a case file, talk to you about the particular phenotype and the likely transfusion needs, if any, and let you know what have we got right now. Plan A, Plan B, and Plan C.
And I have one question that could be to Gwen, Selena, or Tanya, because historically when we started down the path of trying to prevent alloimmunization, we were largely looking at providing big C neg, big E neg, Cal negative for the vast majority of patients. And so really, in most blood banks, that's our O negatives, even if the patient was Rh positive. So we did see a huge burden on the O negative donors. Now that the program is a little bit more established and we're going through, are we seeing a shift to more donors with Rh positivity in terms of the D antigen being provided for these patients' transfusion and exchange support rather than using O negatives as a surrogate or substitute?
Yeah, that's a great question, and it's certainly an area of active work. There's three problems. So as Susan alluded to, if you want CE Cal negative, the easiest way to find that is to just take an O neg unit off your shelf. There are Rh positive, CE negative, Cal negative donors available, and we have been on a 2-year campaign to find them, to keep them, to attract more of them. We have that as a performance indicator, looking every month at the number of new CE Cal negative Rh positive donors that we've collected. we also encourage our distribution sites when they're putting together a package of red cells for exchange to do their very best to use Rh positive first. They can't always, so they might, if the request is for 8 or 10 units, it may be they used to give 6 or 7 of them as Rh negative, now they might give 2 or 3 of them as O negative. So in short, we don't have enough, but there's a very active goal to improve both the recruitment of the donors, the number of tests that we do to find these people, and also to distribute it effectively to make sure that we're not sending out CE-Cal negative for other reasons, but rather we're keeping them for this population who actually need Rh positive. So very much an area of active effort to try and prevent the use of ONEG for this purpose. Not done yet, but actively underway.
Hi, it's Kevin Kuo here from Toronto. So I've encountered in the past, and actually more recently as well, that when we request frozen units, often the bags would break upon, thawing, or that there would be a lot of hemolytic artifacts. And as we all know, people with sickle cell, when we transfuse them, often they are already hemolyzing. And it's kind of hard for me to tell whether they're hemolyzing on the unit or whether the increased hemolysis is just, bad disease getting worse, or whether I'm dealing with even a hyperhemolytic episode. It's all very confusing. Do you have any strategies in terms of sorting one versus the other out? And are there any new sort of storage methods in the horizon that would help, especially around the thawing? I mean, I've heard some mythical stories about units being stored for 60 years, that type of thing. And, I can just imagine this like big cryopreservation, unit, like sort of in the movies,
So
those
it's
were questions.
true that rare blood banks around the world probably hardly ever throw out the rarest of their units. What ends up being the end of the unit is really advances in testing when we don't have access to the donor anymore, and we now do such advanced transmissible disease testing, for example, that wasn't available even 20 years ago, let alone 60 years ago. So that would limit the use of really old units. In terms of cryopreservation, I'm channeling here our friend and colleague, Dr. Acker, Jason Acker, who would tell you that he would any day take a modern deglycerolized unit over a 42-day-old liquid unit. The quality is very good, and the hemolysis in a relatively recently deglyced frozen unit shouldn't be any hazard. We have used them successfully for intrauterine transfusions. They're very good quality units, and deglycerolization really means washing them very extensively, so any hemolytic products should be gone. We have our newer units that have been frozen since about 2017 are done on what's called a closed system processor, and so that it is closed system and sterile, but in addition, quite gentle. And those units can be stored for 14 days post-deglycerolization. They're also much less likely to break. So I share horror stories about breaking. I said that we redistribute these frozen inventory, and I always do so with my fingers and toes crossed, because there's no doubt that sending units that are in dry ice across the country puts them at risk of cracking and breaking, and then we lose a precious unit. But in general, again, the newer units are more stably frozen in better bags and are less likely to break. So again, it's certainly possible that we've used a unit that's older, that's maybe frozen in 2009, and there was a bit of a greater likelihood of breaking and some hemolysis. But in general, deglyced units have very low evidence of hemolysis and are really high quality.
Okay. And I think there was one question next to you, Ziad, before.
Hi, thank you so much for this really, really cool presentations. It was fun. So my question pertains to the donor aspect of things. As we know that certain donor types like RO, like Rh positive, but little c, big C, big E negative, are more prevalent in like African populations or even South Asian populations. I'm an RO, but I'm not O, so anyways. But when you guys are campaigning for donors, do you all, and I don't know if this is ethical or a correct question to ask, but do you all make a targeted effort to have those populations, like to make them aware that, why we have valuable blood, like every donor is valuable, but you guys are more valuable because you're much more likely to have a rare blood type that we need.
Yeah, so I mean, one of the reasons that we ask the question about ethnic background is because we target our testing according to ethnicity. And we tell people that. So the stem of the question actually says, in order to help us test the right things, knowing your ethnic background will help. So that's one basic thing. Donors are only asked that question once. So if they donate 100 times, that question may have been asked quite some time ago. As Selena alluded to, we're reframing that question and adding a much longer list of ethnic backgrounds in October. And so all donors will be asked once again. Once a donor, for example, an RO donor is identified, any of you that are blood donors will know that you may be contacted by text or by email or by phone call or maybe even by letter for some people. I think that you can say on your donor preferences what you'd like. And the messaging that goes out for specifically RO donors is a little bit different to acknowledge the fact that we want to alert these people to the fact that they have sort of a unique, they're O positive with a unique twist, and that we'd really like them to donate. So there is some targeted messaging. There's also specific donor campaigns that I'm not really qualified to talk about, but donor bring a donor kind of ideas where an established blood donor whose family or friends might be of a similar ethnic background or blood type, or even if they're not, you know, we certainly welcome all donors in the door. But that sort of donor bring a donor also, I think, targets individuals that may be more likely to have a particular phenotype that's of use. So we do, certainly the donor relations and marketing people make some effort to target the messaging to the groups that may have a particular phenotype, and especially in the case of RO. Do you want to add something to that?
Yeah, thanks. I think that will come up a bit more in the panel this afternoon about barriers to donation for racialized groups. Our marketing team have always, and are doing so more now, trying to market to, for example, Toronto versus rural Saskatchewan, where there may be more diversity there, and trying all kinds of novel ways to engage with racialized communities for precisely this purpose. But what we're learning, in part because we now have a chief diversity officer who's been educating our entire enterprise, and we're all growing on this journey, is that we're not necessarily engaging with the communities the way they want to be engaged. So it will take us some time, our marketing and DR folks, to understand that and change the way that they reach out to communities. So yeah, we absolutely want to focus our recruitment to certain racialized groups, and we're learning how to do that better.
I just heard at one of the patient advocacy groups, a good program for, it was Hema Quebec actually, going to the churches and going to the church basement, setting up a donor campaign. They're there, it doesn't take extra time, all that much extra time. And it seemed to work really well in certain rare communities. And I think Hervé and I were looking into that for a little while in Alberta because there are large church groups of different ethnicities that you potentially could target for those populations. And I think a lot of it's about restriction in terms of time for a lot of the donors.
There are many, many, many barriers. But one of the things we've learned from Dr. Isaac Adami in particular is that to be an outlet, like not just show up and tell the community what we need from them, but to actually go and show that we want to be part of the community and stay, right? Continue to be there. So these things take a long time. It's a very different model for Canadian Blood Services, and we're trying to adopt all of that. So yeah, to your point, yes, hopefully we can get invited to one of these communities and then stay there.
What's our time check?
Yeah. You know what? Actually, we're at time.
So I think there is one last question, and then we'll go to lunch. So hopefully it's
less of a question, more of a comment. So yeah, we do have in Quebec directed drives to communities of certain ethnic groups, and it works well on the French side. They didn't have a lot of access on the Anglo side, and we're very lucky in our clinic that our clerk or coordinator is actually black and a very, very well-known DJ in Montreal and several clubs, also in Europe, and a big part of the Anglo-Black community in churches and community groups and this and that. So we really did like a trail together through all these areas and got a lot of new donors to the program.
And the French side is the nurse that works for Hema Quebec, which is Haitienne from Haiti. So she's the one who goes in churches and does all that sensibilization. She works for Emma Quebec just for that, just for sensibilization of giving blood.
I think as providers, one of the things we can do is maybe get more information.
Microphone.
Sorry.
You should know better.
Sorry. Scolded. I think just as providers, I think we could actually be a bit more, I'll have to speak to for Reve and I's clinic. We could be a little bit more stronger advocates to get donors. Like we have the family members in clinic, right? And we could post more signs and do that sort of thing and just have it out there a bit more that this is something. We have a shared clinic space, so we're not allowed to put up signs and leave them up. So it's kind of one of those barriers for us. But I think as providers in general, encouraging donation from the community would probably be very helpful for our patient population.
Thank you, everyone. What time are we reconvening since we've gone over time?
So everyone, we should, we'll take an extra 15 minutes. So we'll come back at, let's say, 1:15. I know it's going to be a short lunch, but there is some presentations during lunch from our pharmaceutical partners. So just so you're aware, they're going to play at the end of the lunch period, which will be a little bit shorter. You guys, do you all want an hour? Is that what I'm getting the big looks and the big eyes for? Okay. Are you guys okay with that for a lunch break? Okay, perfect. Thank you guys. I really appreciate it. Thank you for coming, CBS. Wonderful new subcommittee leads for the registry subcommittee. They're going to run a panel discussion in terms of where we go. So this is really about stimulating ideas and trying to get some, I don't know, how do we say, new steps forward in registry and developing our registry panel. So I'm going to introduce Dr. Sarah Tessine from Saskatchewan. Saskatchewan, yes. But it's University Health, is it? The University of Saskatchewan. And Ziad from London, and London Health Centre? Okay, okay. I was close.
Thank you guys for having us, and thanks Aisha for inviting us to get this panel together to discuss steps forward for a true sickle cell disease and thalassemia registry, something that Dr. Arabina Simpson and Dr. Yves Pastori had worked really hard on over the past several years, and now they're passing the torch on to us to take on the next steps, which we're looking forward to.
Hi, thank you for this opportunity. The way we have structured the panel is that I'm going to super fast go through a very brief, almost like a backstage introduction of what we are doing and why we are doing it. And then I will invite all our panel members here, and then we will ask them our questions and kind of start from there. So I want to start with the how and why of the Canadian Hemoglobinopathy Registry. So why are we really wanting to do this thing? So what are the big questions in hemoglobinopathy world, especially as it pertains to Canada? So if you look at the epidemiologic data about sickle cell or thalassemia in Canada, what you will find is there are 3,000 patients in Ontario, maybe 6,000 in Canada, and there is literally no epidemiologic data when it comes to thalassemia. So this is a big deficit right there. We also know in our clinical practice that patients with similar disease phenotypes, patients with SS sickle cell disease, belonging to different families, different backgrounds, have very different disease severity, and we kind of don't know why. So informing this is important. There have been a number of new medications which have come to the market, and finding the optimal candidates for them is something which can also be helped by the presence of a registry. And then finally, the two big ones is we have to still learn what structures and what systems work the best for our patients, what clinical models are the most appropriate, and then how do we improve and foster our relationships in a way that we learn from our patients and also provide them opportunities for research and education. So why do I, or me and Ziad, want a hemoglobinopathy registry? Well, we want to describe the epidemiologic data. We want to understand why the disease is severe, learn how to practice medicine better, and then improve patient relationships and find opportunities for research. And these are the 4 steps which kind of break down a very, very big task into a brief picture. So obviously we have to determine what are the variables that we want to put in the registry, what is the timeline of them, and what are the objectives. Then we have to decide on what kind of platform we want to use, and that we have to look at something which is appropriate from an ethical and a privacy perspective, which is also important from a perspective of user-friendliness and adaptability. We have to look at our stakeholders, who are the healthcare team and the patients, and then some input from industry and the blood suppliers as well as to how to develop them so that we meet the needs of the stakeholders. And then the golden question. So we are gathering this data. Who gathers the data? Who owns the data? And what does that even mean? So to answer these very, very critical questions, I will like to invite our very, very esteemed panelists, and we will start asking our questions. Thank you so much for being a part of our team. I would like it if one of you just begin to come up, and then if you give one-liner introduction for yourselves, that will be great.
Yeah, come on up. So as they're taking their seats, Dr. Tonia Petrasco, Dr. Rabina Simpson, Dr. Giovanni Passiatore, and then Dr. to be in the future, Dami Bello, and Ms. Heather McCartney. So if we can just say a quick one-liner. We only have 25 minutes left, and we have a lot to cover. So I'm hoping, Tonia, just one-liner about who you are, for those that missed who you are.
I'm a clinical hematologist, currently the Senior Medical Director of Medical Laboratory and Stem Cell Services at Canadian Blood Services.
Great. And Heather McCartney?
I'm the nurse clinician for hemoglobinopathies at BC Children's Hospital in Vancouver.
Okay. Oh, I forgot to mention, Molly was an addition. I'm sorry. Please introduce yourself.
Hi, I'm Molly Warner. I'm an adult hematologist at McGill in Montreal, and I've been very involved with the registry for the hemophilia program in the country, and I think that's why I was asked to be here.
Yes, and although you're not on the program, you definitely are. So, Dami?
Hi, I'm Dami Bello. I'm a fourth-year medical student and a patient, a sickle cell patient as well.
Hi, I'm Arabna Simpson. I'm a pediatric hematologist oncologist in Ottawa at CHEO, and I was the former co-chair for the sickle cell registry for CanHaem.
Hi, I'm Giovanni Passiatore. I'm the head of U.S. Medical Science Liaison at Chiesi Global Rare Disease.
All right. So I'm going to start asking the questions starting from our medical student and our sickle cell patient. So you're up first. So the first question I want to ask you is, what are the two main reasons that our patients in Canada with hemoglobinopathies don't have adequate access to care? What do you think?
I think from my standpoint, I think obviously, as was touched initially with the first presentation, we have the discrimination that exists, unfortunately, when it comes to sickle cell disease, and the fact that, more often than not, sickle cell patients who come into emergency departments for pain crises are categorized as pain seekers. Also, I think another barrier that might exist for patients is the fragmentation of medical records and care transference. So across the country, so if I go to an ED, for instance, in Ontario, where my care team is in Alberta, then having that information transferred in a way that is easy and accessible for all parties has been tough. And then also, I think, generally in the community, lack of mental health support for people with chronic disease, especially in sickle cell or other rare diseases and hemoglobinopathies, has definitely presented a barrier for people to access healthcare in the way that should be guaranteed, I would say.
Thank you. That was helpful, super helpful. And then the other question I had for you was, if we develop a registry and we were to collect your data, how do you think the healthcare team should be utilizing this data for the benefit of patients and for the healthcare practice and for research? And what kind of permissions should be sought?
All right. Well, I can't speak for every sickle cell patient out there, but personally, I have no problem with my information being disseminated if it's going to help healthcare outcomes across the country for other sickle cell patients or for other people that may be suffering from hemoglobinopathies, but definitely with the right permissions. So, for instance, I would like to know where my information was being disseminated to and how it was being used primarily, and collecting those permissions should be relatively easy as far as everything is disclosed. I think
Yeah, that's excellent.
So do we have time for, I think if anyone from the audience has an opinion, we have 1 minute.
Yeah, I was told we have until 1:50, so it's 20 minutes and 4 more panelists. So perhaps we can do 2 more panelists and then take some questions, and then 3 more panelists and some questions, just for the interest of time. So the next set of questions is for Heather. So just 2 questions, perfect. Here you go. We couldn't post the questions because we didn't want to blind you with the projector. So Heather, can you think of a way that you and your nursing colleagues in the clinic to utilize the identified patient data to improve clinical practice?
Yeah, so I was just talking about this at lunch with some of the nurses here. I think what it would help us with is advocating for more resources for our patients and our clinics, advocating for things like social work, psychology, extra nursing, and extra physician time as well. It would give the powers that be a better understanding of what we're looking at in our clinics, what we're dealing with, and especially comparing it to other provinces in terms of equity. So-and-so has 600 patients, they have 2 nurses, we have 1,000 patients, we only have 1. So it gives us a platform to be able to advocate better for resources. I think it would also give us a chance to advocate for better drug funding from provinces, because I know it's not equal across Canada.
Makes sense. Those are some actually new things we hadn't thought of, so that's wonderful. The other question is more about the actual implementation of a registry. So a registry is data we have to enter, and someone has to enter it, and we have no models in hemophilia and other places where certain people are charged with entering the data. Is it reasonable to ask nurses who are frontliners or other healthcare practitioners to share responsibility or assume the responsibility for entering the patient registry data into the system? So if you can discuss feasibility.
All right. So the short answer is no. We would all love to be able to do it, but none of us have the time. And honestly, I think even if, personally speaking, not speaking on behalf of other nurses, if I was able to carve out 2 hours out of a day to do the initial data entry, it would probably be more like 8 for what you're looking for. But if I was able to carve that out, put that in, I would never in a million years be able to upkeep the information. So I think this is an ongoing thing that will need funding for CRA, or a research nurse might be able to do it, but it would have to be someone dedicated to that, because the physicians and nurses in our practice, I just don't think we have the time.
Yeah, and I think your skills are more needed elsewhere. Definitely, it's just something that often comes up with registry, so we thought we'd ask.
I appreciate that you did.
We just lay any kind of inkling out there to rest. So the next question is for Dr. Mali. So hematology physicians, and I think EB can also comment on this. What do you think are potentially 3 aspects of clinical practice of hemoglobinopathy patients that will benefit from a national registry data?
So when I think of registries, I think that they should have 3 sort of goals. The most important one would be improving patient care. And so knowing who's out there and what's happening with them at any given time will allow us, I truly believe, to give better patient care. And I think in terms of data entry, I would hope that somehow we could get to a model where the patients enter a lot of their own data into like a web-based system or whatever. The other benefits that I would see would be quality of care, looking at quality of care, and that would be using anonymized data. I think that the personalized data should and has to be only available to the treating team, but looking at anonymized data on a Canadian level to see, which of these strategies for red cell exchange is better, what the new medications are better, and so on, or any other research along those lines. And then the last thing that I would say is I think it's an important QA tool for our blood providers so that they know how many patients are out there who are going to need regular exchange transfusions, what rare blood products do we need, and so on. So that's the way that I would see it, and I would think that all those avenues would help patient care.
That's a wonderful summary. Evie?
All right, thank you. So a lot of great points have been made already, but I think touching on the points about transitions across different levels of care is really important. And I feel that having a registry would help to improve that process, in that our providers would have access information about severity of disease, complications, medications, et cetera, no matter where the patient would be. So that could be in the same province, going between hospitals or to another province. I think that could be really powerful. And then touching on what Heather had said about medications and advocacy, I think another potential strength or benefit of the registry would be that by knowing who the patients are, where they are, we'd be better able to advocate for new drugs, so that we can help to improve the access to these new medications that have already been approved in the US. And then with respect to quality of care and resource allocation, I think that having a registry will help us better plan our resources. So if we have patients with more severe disease in certain centers, then it helps us to better resource those centers and support centers for transplant or other services that our patients may need in terms of referrals to improve and optimize the outcomes for our patients. So
Perfect. So I'm going to give 30 seconds for this next question before we go to questions from the audience. What are strategies for patient engagement to get patients to be involved in the feasibility aspect of the registry?
Right. So I think patient engagement is huge, and that's I think we discussed that it was a challenge that we had encountered most recently in the I guess early last year when working on the registry. And so with respect to the use of the data, the ownership of the data, the anonymity of the data, I think that we need to engage partners in helping to develop the registry and really talk about how best to approach patients so that they trust that we are using the registry for their benefit and that it would be beneficial for patients to also enter the information and that we can share the data. Barriers that I had encountered in, I guess, my journey previously with the registry was that there was a great deal of mistrust. And when it came to ownership of the information, there was a bit of concern that by having involvement of the healthcare providers in establishing the registry, we would somehow be taking something away from our patients.
Okay, so Dami, we're going to need your help then for that part later on.
Yes. Thank you for the insight.
We're going to allow 3 minutes for audience questions just about these aspects that came up. Then we want to move on to asking Canadian Blood Services their perspective. So who has a question and a microphone? Yeah, we have 2 questions from the audience. That's probably all we can allow for. Go ahead, Mohammed.
Thanks so much. My question primarily is around the quality of the data that's going in. With registries, we have a lot of heterogeneity and sparse data, so data that might be missing. And so garbage in, garbage out. Can you maybe comment on how to control that?
Yeah, and I think, from my perspective, it would be, we would have to pilot the registry really well before we, implement it. And seeing who's entering the data and what type of rigor are we able to collect. But I'll let the panel comment. Yeah, who has the remote?
Okay, so I think it's a really important question. So thank you. And learning from previous models. So I'm a pediatric hematologist oncologist. So in pediatric oncology, clinical trials are a big part of the management of these patients, and we have dedicated individuals who are in charge of entering that data and ensuring that the data that's entered is of high quality. And I think we should learn from that in that, I think too often in medicine we delegate or we don't delegate enough and we end up taking on tasks that perhaps are not tasks that we should be doing. But we need the resources, of course, so that each center can have a dedicated person to be able to maintain the integrity of the data.
Right. Dr. Werner, do you have any tips from the hemophilia experience?
Well, the one thing I would say is we should start by deciding what we want to collect, because sometimes it will be easy, sometimes it will be much more difficult. So I think in starting a registry, we should aim to go for basics at first, like the question about increasing our resources from our ministries of health. I sometimes get the feeling they don't know a lot about sickle cell disease. They don't know how many patients are out there. They don't know. So just alone collecting that data will aid us in going to ministries and saying, listen, there are X thousand patients and growing in this province. You need to give us some resources for that. Yeah. But be careful what we decide to collect at first.
And I'm thankful Dr. Simpson and Dr. Pastor already came up with a list of phase 1 variables that are like epidemiological, and then phase 2 variables when we're ready for more heavy outcomes data. So I think we have a good plan. One more question is all we have time for this part. Go ahead. I think you had.
Oh,
your
hi.
hand up first.
Yeah, Maria from Edmonton, adult nurse for the hemoglobinopathy program. So one thing I've noticed is there's a big disparity in equity of care across Canada. We've got a lot of very far-flung, very small centres, and they just don't have the same resources available to them. And do you think that the registry will bring more equity to that? Like, you know, can patients or adult patients from those areas be, you know, get access to the bigger centres for treatment and for monitoring and management?
Let the panel take it on.
So I've been meeting with some ASH people regularly about advocating for sickle cell patients. They have this whole teaching group thing for 2 years. And sorry, give me the very last part of your question again.
For adults accessing care at bigger centers if they live far away.
Right. So they in the U.S. they've developed in many places what they call a hub and spoke model. So the hub would be like Toronto General, or in Montreal would be the CUSUM or the MUHC or CHUM. And then patients may live outside of those areas, so they come centrally once or twice a year, but other than that, it's communication with their generalist or family physician in that area. So that hub and spoke model has been shown to be very effective in those areas.
Is that across state lines, though?
No, from what I can tell, it's usually within the state. But there are many smaller towns where there can be people affected with the disease, where they just can't go every 2 months or 3 months or whatever.
Yeah, which is what we do in Alberta. I'm just wondering, like, there are some provinces that just don't have the numbers and the resources. Do you think it's feasible then, you know, for interprovincial sharing of responsibility of those patients?
I actually do think it's feasible, and I know that it took a long time, but it's worked very, very well in hemophilia, and I think it's already working much better in hemoglobinopathies. So yeah, I have a lot of faith that, you know, we're heading in that direction.
Great discussion. So I'd like to move in the last 9 minutes. I'm going to say 9 minutes, actually 8 minutes, to Madeline told me not to go over. Okay, so the blood supplier perspective, our Canadian Blood Services and Héma-Québec are blood suppliers. We have CBS represented today. So what patient data will aid in the timely arrangement of blood products for both sickle cell disease and thalassemia patients?
The type of hemoglobinopathy and the red cell phenotype, genotype, and antibodies. So essentially their entire transfusion history. But those things, their preferred clinic, their geography, history of hyperhemolysis, and history of transfusion reactions. The intent would be that it would be fantastic if CBS could see and be part of the registry. We don't for the hemophilia registry. But when we launched a new product for hemophiliacs that was only available to a subset of severe hemophiliacs that met with inhibitors, we were able to reach out to all the clinics, and they provided us a list of those patients so that we could set up our systems to be able to make sure those patients got that. So I envision something like that. But if I think about it starting at the bottom and instead of going from the sky, to make sure that nobody dies, I'm not talking about optimizing care, but make sure nobody dies, we want to make sure that those who need transfusion, for whom transfusion is a part of their care, they get the right blood. So if we can see at CBS that you have traveled to another location and you're not able to advocate for yourself, and we know that someone ordered the wrong blood for you, we can make an intervention and build programs. Or at least, I mean, with this community, or at least then call you or UHN or something. Similarly, with the hemophiliacs in British Columbia, at least, there was a central services interprovincial program that's I don't think any hemophiliac anywhere in BC has anyone do anything to them until they talk to one of the docs in Vancouver. And we, you know, so if you have that arrangement on the registry, that would help.
So I think we will ask a big favor of CBS to, you know, create a list of variables that they are interested in.
Absolutely.
And then we can probably have meetings about those. The other question, which you probably answered mostly, but you can expand on, is what do you think are two very important questions for Canadian Blood Services regarding transfusion in sickle cell disease patients sickle cell disease and thalassemia patients that can be potentially addressed by a national registry?
Well, I engaged Dr. Clark and Dr. Montemure for this question, and I have 4.
Great.
Predictive markers for hyperhemolysis and predictive markers for alloimmunization for sure. So so could we identify patients on this registry who we might recruit for a study to look at that? And what's the clinical course of folks who have novel variants so that we can decide that if I have a novel variant, it is or isn't clinically meaningful. And just to document the range of genotypes in Canada, all the published data on genotypes is international or American. We don't have Canadian data. So just to your point about describing the epidemiology.
Okay. And so I think, you know, the cherry on top, and last but not least, is our industry sponsors and industry partners that you know, are creating all these wonderful therapies for our patients. And we need to be able to you know, create a registry that will tie that in so that patients can benefit from that perspective as well. So I have 2 to 3 questions for you. So what would your research goals be for sickle cell disease, and separately, what would your research goals be for thalassemia as an industry?
Well, we have a lot of. Okay, we have a lot of. I don't know if you can hear that. Oh. Well, we have a lot of research going on, but for now we don't have a registry currently. So the way that we are working on and to try to figuring out a way that to receiving actually idea from you. So and we can sponsor if it is a fit. So there is a way that to can propose potential like registry ideas, and we will evaluate and investigator-initiated trials. And that's the way that we are starting to work in right now from Canada list. It also already applies in the US. So at Chiesi, we do have a registry, but not in sickle cells. And we are actually working on a new form of registry called Disease Monitoring Program, which is more a little set of questions asked ahead before kind of a little bit with was asked, and also putting a lot in consideration patient report outcomes.
Are there any
really
specific kind of responses to the question, or we're all going to learn from each other, but are there any specific?
That's just completely
and if
different.
There's any other industry partners in the audience, please feel free.
Yeah, this is completely different disease state, and non, but like it's we're trying to look at a little new way to look at the registry currently. But for sickle cell disease right now, unfortunately, we don't have anything planned, but we are looking to listen if any of you have any research idea for us.
Excellent. I'm told we have questions in the chat. Should I read them directly? I guess so. So, now I know what Madeline was dealing with. Okay. Dr. Tinmouth, Alan Tinmouth is asking, could we harness the power of current data captured in hospital databases? We could collect a huge amount of the data needed through electronic download.
More of a comment, right?
Yeah. Yeah, so that would be probably a source, definitely.
And does anyone from the panel have a comment about that? Go ahead. Can I just ask it?
So, as you know, in Quebec, we're quite lucky in that we have Traceline, which keeps all this data on anybody who's ever transfused, including previous reactions and allos and autos and so on. Is the rest of Canada, CBS, anywhere near having that kind of a registry for all transfusion? And then maybe you could put an interface with the sickle cell world.
So that has to come from the Ministries of Health in the province. We have had discussions with treaters in Ontario to look at that, and in fact it's been Dr. Clark who's been at the table to talk about how we use eTraceline to report certain things. And then my understanding is the Ministry of Health has taken this away to look at it for some perinatal testing results and other things which could be extended. So that has to come from ministry, and CBS would absolutely partner and could bring that on. And I know the industry, Mac eProgesa, who runs eTraceline, is interested in expanding, but again, that's beyond CBS.
Okay. Questions from the audience? Please use a microphone.
This is more of a comment because I think with all the discussions we've had around patient-centered, having a patient-centered focus to everything that we do, is it possible to create a database that has almost 2 interfaces? One, a patient-owned section where they input their data, we believe what they're saying. They say they have 12 pain crises in a month at home, whatever. We're not documenting those necessarily in the clinic data, but then we put in, if they allow us, put in the hospitalizations or those sorts of in-hospital face data, because I think there's two components to that. I think there's an untapped amount of morbidity there that we're not recording, right? That it's there, and that people might tell you in clinic, but does it actually make it into any sort of database ever, right? And so that believing the patient and allowing them to access their own clinical database record.
Kevin, if there's a remote for, not a remote, a microphone for Kevin.
Hi, Demi. This question is directed to you. I'm Kevin from Toronto. As a patient, from your perspective, would it be acceptable if we have a mixed opt-in, opt-out format for the registry, meaning that for the purposes of patient care and quality improvement, that patients have to opt out in order to not be on the registry to provide data for quality improvement and safety purposes and clinical purposes. But for things like research and providing anonymous information to, say, our industry partners, that they need to opt in to provide that information. Would that be acceptable? And the reason I say that is because, I mean, we can imagine, like, say, you know, for safety purposes, right? It would be nice to have a national registry for their phenotype, for their blood phenotype, so that, you know, they can be portable. If they go to uni in BC, then, you know, they can be transfused safely. So that's more of a safety issue. Whereas for research and, you know, supplying information to our industry partners, that's not necessary per se. Yeah.
From my perspective, I think actually that would be one of the ways to go about obtaining that data. I think definitely at the point of follow-up or diagnosis, the initial meeting that you have with your provider, you can definitely opt in at that point in time. They're taking your demographics anyway. So at that point in time, if it's explained that it would be added to a registry, and the patient can choose at that point either to opt out, which I don't think most people would be inclined to do, because again, it would affect their disease course potentially over time. And then also, definitely, I think, yes, in terms of research and reporting to other institutions that are not necessarily focused on your healthcare, that's something you need to elicit permission for exclusively at that point in time. And then patients can choose whether to opt in, and that information would be disseminated as such. So yeah, I think so.
We have time for one more question.
I was wondering, in the same idea of the patient participating in the registry or just gaining their trust, if it was considered that there would be like updates every year shared to all the patients to let them know, hey, you're participating to that registry. Here's what has been done with it this year. Here's what it helped with this year. And also thinking about the isolation issue, maybe like they would feel like, oh, wow, that's what's in Canada, that's what's been done, and that's all the people that are around that are like me.
That's a really good idea, and we can make it like publicly available that and de-identify that X% of SC patients are in Saskatchewan and X% are in another province, and then just sharing that information would definitely, I think, help to foster patient trust, especially in that particular aspect in group of patients. Thank you.
I think that was a very exciting discussion. Thank you guys for all your perspectives, and you know, it's really nice to pull all your expertise together and clarify, you know, our path forward as we venture into this registry. Thank you all again.
Thank you. That was super helpful.
I think next is Dr. Simpson.
So 30 minutes.
Yeah.
that's great. Okay, thank you. Or should we, I mean, it doesn't have to be, I just noticed that.
Yeah, that would be fantastic.
Thank you. I just noticed.
Hi guys, we're going to move on to our final panel of the day. Everybody just talks louder right now. We can tell we need a bit more break time in the day. So we're going to move on to another panel. This is really to bring home the EDI conversations, and Dr. Ravana Simpson is going to lead it. Madeline is going to be our moderator, and they will introduce the panel members and invite them up.
Okay, great, perfect. So thank you for that. And so we're very fortunate to have a number of a number of expert panelists will be joining us. So if you could all come up, I can call you by name as well. So Dr. Gwen Clark, Dr. Tanya Prochasko, Dr. Runa Sinha, Dami Bello, and Durhan Wong Rayner, Dr. Wong Rayner, sorry. If you could all come up and just take a seat here, that'd be perfect. There's an extra chair here if we need it.
I'll sit over here.
Okay, we have one more seat here. Yeah, thank you. Okay. All right, thank you. So thank you all for agreeing to be part of our panel. And so the goal of this panel is to talk about what some of the equity issues that surround blood transfusion in terms of finding donors, and also equity with respect to accessibility to blood products for our patients. And so I have a number of questions. We only have 30 minutes, so I thought that we'll tackle maybe a few of the questions, and if you could each give your perspectives, either from the perspective of a clinical care provider, a transfusion specialist, as a patient, as an advocate, I think that would be really valuable. So we saw in...
There's two new panelists from the last panel.
Oh, yes. Oh, okay. We'll know everybody. Okay. All right. Thank you. So actually, I'll just ask if you could introduce yourselves.
Sure. Durham Wong Rieger. I am President and CEO of the Canadian Organization for Rare Disorders. So thank you very much.
Thank you.
Hi, I'm Runette, and I'm a pediatric hematologist oncologist in Saskatoon, and I've done a little bit of work in EDI with the undergraduate curriculum at the U of S, and also with READY, so which is Reconciliation plus EDI through Ronald McDonald House Charities.
And you all met me this morning. I'm a transfusion medicine physician with Canadian Blood Services, specifically associated with the immunohematology reference labs, where we do the testing for antibodies and genotyping, and with the rare blood program. Gwen Clark, thanks.
Okay, perfect, thank you. And so earlier today we heard about the importance of diversity in our donors, and we also heard about the association between ethnic ancestry and genotypes. So the first question I wanted to ask was about your thoughts about how we can increase the diversity of our blood donors so that we can better serve our patients, knowing that there's an element of mistrust. And it's actually interesting to see that the diversity actually decreased with repeat donors when you presented that data. And so it'd be interesting to also hear your thoughts about what those barriers are and how we can better address. So I don't know if you want to start, Dr. Clark.
So maybe just to clarify the data. Just to clarify that data slide a little bit, the data on the repeat donors reflects donors, some of whom have been donors for 20 or 30 years, right? So people that are dedicated blood donors are often dedicated for a lifetime. So when we look at our whole group of donors in Canada, it certainly includes a lot of people who may have been donating for many, many years, maybe from a time when we didn't focus so much on racialized communities as being members of our donor population. So the heartening fact that I take from those data is really that our new donors that are coming in the doors are a better reflection of the Canadian diversity than used to be the case. So we're not there yet, but it's a step forward. That's the first part. In terms of barriers, there's many, and I think all of you in this room could probably address those better than I can, but certainly mistrust is part of it. Geography might be part of it in terms of where the donors are versus where we're doing recruitment of donors, and Tanya touched on that a bit in terms of ongoing efforts to make sure that we're recruiting donors from communities where there is a wide spectrum of diversity that is similar to the Canadian population. And then there's some of the donor questionnaire items, which are designed with safety in mind, absolutely, but which nevertheless can sometimes serve as barriers to donation. So I think just as there are a huge variety of barriers, I'm hoping that there are a variety of solutions that we can collectively work on together to make sure that we can continue to recruit people who represent the full diversity of Canada.
Okay, thank you. And Dami, did you want to provide some thoughts?
I think actually most of my thoughts were just touched on, but I remember, I think it was my first year of undergrad, I convinced one of my friends to go try to donate blood. And the questionnaire alone was the turnoff, because there was no explanation for anything. I think I checked the Canadian Blood Services website not too long ago, and like now it's improved where, they're telling you for some of the questions why they're asking these questions. But previously it wasn't so, and that served as a barrier for a lot of people as well. And then also diversity in those you go to the clinic and see that are donating blood, right? At the end of the day, I think a lot of marketing when it came to blood donation wasn't, marketed to ethnic communities or Indigenous communities or BIPOC individuals generally. And those serve as barriers as well because there's no representation. So, and the importance of donation is not stressed in these communities as well. And so I think it's very important to reach out to these communities specifically that do have these rare blood types and, show that you're invested not only in their blood, but in them,
Thank you.
So I might make a few comments, which is I think that the making sure that we're targeting some of the campaigns toward the ethnic groups is really important. So I remember that I saw some flyers from an East Asian group, and so I'm East Asian, and I remember seeing a lot of the people around me kind of really thinking about donation and kind of who hadn't really thought about it before. And so getting people out really makes a difference from that point of view. I think another thing that we as clinicians can do a better job of is making sure our patients understand what transfusion is and what it looks like. Because especially, it seems like when they're coming from another country, I think that where there's more of a role of, directed transfusions a lot of the time, I think they think that that's the way things work here as well, and that directed transfusions is kind of when they need a transfusion, they have to go out and find someone at that time, and that's not the way it works in Canada. So I think some education we can do with our families, with those communities, is really helpful as well.
I would echo all of that. We have a social science researcher with us, Dr. Jenny Ha, who's been working for some time, and she was actually approached by the sickle cell community to do a community, there's a term for it, community development research, looking at barriers and enablers to donation, and they presented an abstract, a poster at CSTM, and they will be publishing it. And it's a brilliant document because it was developed with the community, and it will be published and written with the community. And it talks about barriers, some of which have been mentioned, and potential enablers, some of which are education. So we're looking forward to that. The other thing is talking about our website. It's embarrassingly low-hanging fruit, actually. Even now, the number of Canadians or donors who come and are deferred on clinic for malaria because they've lived in an endemic area. We can talk about that donation criteria, but they should not come to clinic and then be turned away. They experience embarrassment at minimum. Some feel racialized, some feel discriminated against, and everything in between that I can only imagine. So we need to do a better job of helping donors self-defer before they come out, let alone changing that criteria when it's safe, as it's safe to do so. So we have a sickle cell working group at Canadian Blood Services. We've had it now for about less than a year, doing many things, but one of them is we're actually meeting next week to talk about that. So there's an eligibility quiz that any of us can do. Am I eligible to donate? And it talks about travel deferral for malaria, but it's really buried down below if you've ever been a resident in an endemic area. So you can say, no, I haven't traveled in the last year, and then get to clinic and be deferred because actually you lived there 5 years ago. So that's a relatively easy thing for us to switch. And then we have also on our website, we have high up there are questions around sexual behaviors, which have just changed. our questions for that, and questions for trans individuals, and we highlight some key populations who, for whom deferral is particularly painful and appears to be or is discriminatory, or is perceived as and received as. So we can add malaria there. Same thing. It's a huge potentially huge donor population and an important population that we can work on making it easier. So that's one of the things there. And then Jenny's research tells us what we can do in clinic, at our collection sites, and in the community with the communities to make it a safer and a more pleasant place to donate. And just understanding why. I just want to share something that really struck me when Dr. Isaac Odami came and spoke to our entire corporation. And he was talking about the perception in some Black, Caribbean, and African folk that, all things being equal, someone would give white blood to a Black person. And they said it that crudely. That it reminds me of that experiment when they had two dolls, a black doll and a white doll, and they said which is the good doll and which is the bad doll. It's astonishing to me, as much as I think it's clear that blood transfusion relates to your ancestry, that if you are not white, it's likely that a match for you is from blood from a donor who's also not white. But the perception among some humans that I'm not going to give blood because you're just going to give white blood anyhow. Like, there are huge things we have to understand and educate about. So sorry, get off my soapbox.
That's helpful. That's awesome. Thank you.
Thank you very much. I'm going to say something that's probably not very popular, but I do that all the time. So I don't know if some of you know, I was on the original board of directors for the Canadian Blood Services. And it was way back in. And we were getting the blood system away from the Red Cross, and for lots of good reasons, you know. And at that time, I was still president of the Canadian Hemophilia Society. And there was a big challenge came to us. We pushed, as the hemophilia community, to say we need to have a publicly transparent, publicly owned blood system, and that it need to be taken away from closed doors. And that was the goal underneath the CBS. And I sat on their first board of directors. I would say the promise was never quite met, but I think the thing that convinced the government says we can't take away the blood services from the Red Cross because people stop donating. We were able to prove that really patients don't donate to an entity, they don't donate to an organization, they donate to other patients. And that's where the campaign came from, right? We did the surveys. And those initial years and those initial beginnings was you featured the people that were receiving the blood. And the reach out was, who are you donating to? You're donating to, and it didn't have to be somebody that looked just like you, but it was somebody. But we also used patients in that community, patients receiving bloods, to do the draw, right? We did it, I mean, you can remember, and I know CBS did a great job with it, with some of the bone marrow transplantations. One of the most successful campaigns was that young Chinese gal who did the outreach because, exactly. I mean, I think we've lost some of that. And quite frankly, if what we're stressing over is how do, you know, questions, who owns the blood services? The public owns it. It's not owned by an entity. And we've lost that, I think. I think we slid away from it too much. And I think some of the things that you're saying, all these requirements, et cetera, has kind of pushed it back into the ownership is the organization. And it happens over time. Organizations become their own entities over time. And I love the fact that CBS now has a much broader, you know, community advisory group, and hopefully they'll use that strongly. I think the perception has to come back. People own the blood services, and the recipients are the ones that you're donating to. You're not donating to an entity. And I think we've lost some of that over time. I can tell you the couple of things that really grated me, and one of the reasons why I actually left the board of the CBS at one time was the whole issue around the deferrals for people who've been to the UK over a cumulative period of time. Because to me, that was absolute nonsense. And we insisted on it, and we insisted on it, and people could see it was nonsense. And so when you as an entity do things that are nonsensical, as you're saying with the malaria, right? People get it. They're not fooled. And so suddenly that creates a divide between the entity and the people, not only people donating, but the people receiving. I would love to see us recast. You're a donor, you're donating to somebody else who needs it. It's a direct action, and it's a direct service of the giving. So I'd love to see us go back to that. I mean, I think Canada's done a great job in terms of, you know, both with Hemo Quebec and with CBS, But I would say is that we never quite got all the way that we needed to. So when we get to the point where donors are coming in and they recognize, I'm giving because I can see the other person on the other side is going to receive it. That's why I'm here. And I think that's the important part. It's also this whole plasma conversation, which we're not talking about now, has not helped in terms of improving the image of who this entity is. Because again, it feels like, here's the rules, here's why we set the rules. And it doesn't matter if it doesn't make sense to you, that's the rules. That's where people back off. You know, so I think, as I say, probably not very popular what I'm saying, but I'm just telling you how I see it.
No, it's really helpful. Yeah, thank you so much. And I'd like to open the questions to the audience. So Dr. Soul has a question.
Thank you so much. That was a really nice discussion. I wanted to hone in on the malaria discussion, and it's such an important one. And right now we have the intercept technology, which is pathogen reduction, and I think it's only platelets currently at CBS. So would it be a feasible first step for this donor population who feels discriminated against to allow them to donate for intercept-treated platelet products?
They can. They're
Yeah.
eligible for platelets and plasma right now.
So should that be
It's just
advertised very well?
Exactly, and that is not up in front in our website. That's my point about low-hanging fruit. They are eligible now, right? We just need clarity around what patients can, what donors can and cannot donate.
And then I'll put you on the spot. What's CBS doing to get, pathogen-treated red cells, which is what our patients need? They don't need plasma and platelets as much.
We are working with CIRRUS, not working with, we're remaining in touch with them as they plan to bring that product to market, which is still probably beyond 5 years away. But yes, absolutely. It is part of our roadmap for pathogen inactivation. We're pursuing platelets now, followed by plasma, and our intention is that red cell inactivation will be licensed at some point in time, hopefully by more than one vendor, so we can have a choice, and we will plan to implement it.
Thank you. Do you have any questions from the? Okay. Any other questions from the audience? Okay, yes, thank you. She needs a microphone. Oh, there's one coming, yeah.
Hi, this is a question again about recruitment of donors. And so we were just discussing, that have issues. And I wondered if, a program where in grade 12, there's a little bit of education about blood groups and antigens and how to empower, because kids at that age want to feel empowered, they want to feel like they can contribute, that they learn how, if they are a visible minority, how this is how they can directly contribute to their community. And it's a time when they're really keen to learn this stuff and become a valuable part of society. I just wonder, is that something that's ever been looked at?
I don't know, Gwen, if you know the answer to that. I'm not that close to what our donor recruitment teams actually do, and everything stopped in the pandemic as well. So some of these campaigns are being brought up again. Our youngest age for recruitment is 17, as opposed to the stage which is 16. So I'm not entirely sure we do a lot of work with high schools, but we do with universities, and that's an excellent point that you raise.
Not so much for them to donate in immediately, but to put the kernel in their head for moving forward in life, that they understand how valuable they are as a donor.
We're still trying to educate physicians about how to use blood.
Is that a mic drop?
Yeah.
Not to be facetious.
And did Dr. Clark also want to comment? Or?
I don't think I.
Okay.
I don't think I have very much to add to that. I think there are examples in other countries where throughout schools there is some focus on just the idea of blood groups and variation between individuals and the necessity of blood donation. And I mean, our overall percentage of eligible donors in Canada is staggeringly low. So I think whoever we could educate at whatever age would probably be a step forward. Certainly those of you that watch TV, the stem cell registry commercials right now are focused on young people who are, anxious to, as you say, become involved. And I think they have a good focus on what Dr. Wong Rieger was saying as well, on you're doing this to help other people. not to help CBS. In fact, I think that commercial hardly even touches on the organization. It just talks about donating stem cells, and so it's a similar idea with blood for sure.
Okay, thank you. And we do have a question from online.
Sorry, I'm okay to put it on top. It's not a very long question, but I'll have it in front of me. So there's a question here. Just out of curiosity, where are the malaria endemic countries in Africa getting their blood for transfusions?
In Africa.
Do you want to, somebody want to take the microphone?
I had the pleasure of being in Tanzania in 2013, and I got to tour the blood bank in, can't remember the name of the town I was in, I apologize. And their malaria deferral question is, have you had malaria in the last 3 weeks? Yeah, very different.
I was just in Ghana this last year, and we had some of those similar kind of issues came up, and I think it was actually also around COVID. And people kind of looked up and said, like, what's the point, hey? We have so many other things that are of issue here. Why are we angsting over these kinds of issues? And I think it's the reality of it.
Any other questions from the audience? I guess, because we have a few minutes left, right? Like 5 minutes left. Okay, so I wonder if we could maybe leave with your thoughts about how we as health providers can try to encourage our patients, their families, and better advocate for improving the number of donors who could potentially give blood here in Canada. And I don't know if you wanted to start.
You know, again, we go back to, remember the old days when in order to get blood, you had to find a donor to give blood. I think we need to recruit our patients actually to be recruiters, and we don't put the responsibility back on them. Getting blood is a gift. And we talk about the gift of life. I mean, you know, my program director, her daughter's thalassemia major, and they're very much involved in this, and they see it as a response, not to put more burden on the patient, but it goes back to the notion of patients give the patients. And I remember when CBS first started, right, and we were trying to do the recruitments, we always had patients who spoke, and it was always featuring a patient, and it goes back to that line. So, but I also think that, you know, patients would be very willing to, if they understood the benefit of their speaking up and being part of that recruitment. So I'm not saying that you have to go out and find a donor to replace the pint that you got, but I but I don't think that's a bad idea either.
There's so much in that. A couple important things that came out of the research that Dr. Haw did were one, that some Black, African, and Caribbean humans feel that they have to be better because they're of color or they're racialized. So don't make it harder for me now. Now I got to give blood, right? Only 1% of the African Canadian Black community, African Caribbean and Black community donate blood. Some people receive that as condemnation and blame, and so it's a burden, right? So I hear what you're saying. So we have to be. So we're learning. We have to be. Every patient's different. Every human's different. And then what we also heard from this research is, wow, I had no idea my blood was important. And teaching them and educating them to show that, okay, so whether you're a recipient or not, you have friends and family members who at least need to know who Canadian Blood Services and that we're on the same team, talking about allyship last night, and to even just go to our website, even just to go and to know, right? You know, you're on your way to Carabana, downtown Toronto. Maybe that's the wrong weekend, but you know, go by 67 College just to get it in the lexicon of some people some communities, sorry, who like it's that high level, I think, in some ways. I don't know if others have comments.
So I think you're right. I think a lot of the solution is with empowering our communities and empowering our patients. And I think that we can do a lot about helping empower our patients and our patient advocacy groups as well. So I know that CanHaem, for example, has had some excellent campaigns in the past. And with the pandemic, everything's petered down, but kind of helping support some of that to happen again and helping that advocacy happen again. I know that within hematology, one of the greatest groups that we've had excellent patient advocacy from is the hemophilia population, and the reason for that was there was money in that system, and there was money to help create some of the advocates. So I think in the same way we need to put effort, we need to put empowerment into our patient population to help them educate their peers, educate people in their communities, and work with us to find some solutions that will work for them.
Yeah, to echo all that's been said as well, with the particular patient population, especially in sickle cell disease as well as thalassemias, I think a lot of families are itching to get involved, and they don't know how they can get involved. And your kid might not necessarily need a transfusion at this point in time, but they might need a transfusion down the line. And it doesn't take much to get screened. I mean, that questionnaire is improving, so we thankful for that. But definitely, again, empowering our patients as well as empowering their families to get involved in the care of their kids or their relatives. At least somebody knows somebody who's been affected by sickle cell disease or another hemoglobinopathy or chronic disease. So I think definitely doing that would also help in some way, shape, or form.
As the last one on the line, I don't think I really have anything to add to all these great ideas.
Okay, all right, thank you. And then I guess we're at the end of the, is there any last question? Okay, all right. Well, thank you so much, everyone. That brings us to the end of our time. It was a really great discussion, and I think we learned a lot from all of you. So thank you.
Thank you, everyone. I am going to give everybody just a 5-minute break to stretch their legs. Please come back in 5 minutes sharp. I know we're running behind, but honestly, I feel like everybody just needs a good stretch and a little bit of a debrief for their brain, and then we'll get started with our last presentation of the day.
Riley Platt and Eric Toe. Apparently, the check is in the mail, but I suspect that they'll receive some email from some unknown website saying that they have won a certain amount of money if they only transfer all their critical information to that person.
Please don't answer that one, but we will send you your research prize.
Congratulations.
So I just updated your agenda. Okay, and I'm going to update the AGM.
The chair of the Consumer Advocare Network, the president and CEO of the Institute of Optimizing Health Outcomes, and the chair of the Canadian Heart Patient Alliance. I'm not going to read the rest of it in the interest of time, but I'm really very excited to pass over the mic to her because she will be telling us about how we can forward drug advocacy for our patient population. How do we get access to drugs? How do we get paid access to drugs for our patients who really need these resources and often can't afford them?
Thank you very much. I think there are slides here. I'm not exactly sure how the slide works. Somebody's doing the slides? Is that how it works? Oh, you have a clicker. That's even better.
I don't know where the clicker is. Oh, the clicker's right here.
Oh, okay. I can do this.
Yeah.
If I don't. So first of all, thank you very, very much for the opportunity to be here. I've actually followed the entire conference. I did half of it this morning just by sitting in the hotel room, so that was much easier than being downstairs, but it was great to be a part of it and to hear everything that was being presented. So I'm really thrilled to be here, and very much thank you for the invitation. Some of this, I'm sure, will be just old information, but I just want to go through it all just to kind of give a start. But really, I'm not going to go through all the slides. I wasn't sure exactly what you wanted, and I wasn't sure what the rest of the programs would be, so I probably got more slides than you actually need. But this is just but the interesting thing, of course, for many of you who are very solidly in the hemoglobinopathies, you may not have to deal a whole lot with the issues of drug reimbursement. And quite frankly, as you heard today, and as you've been experiencing, all of that's changing, right? Because many of these therapies are coming in. They're not going to be flow-throughs. CBS, God love CBS, is not going to be the ones going to be funding all those therapies, right? And even some of the therapies that are plasma-based are going to be subject to other kinds of analysis just because therapies are different. You know, it's one thing to say, I take out the blood, I filter it, and I'm going to give it back to you. It's another thing to say, we have to create new molecules that are actually going to be developed and have to come through a whole different change. And it makes great sense, right? So it's a huge challenge, but huge opportunities. So in many cases, you know, and certainly for patients, hemophiliacs, people with thalassemia, sickle cell disease, which never had anything, so it's never really worried about too much of the whole process here. I mean, true, right? The issue is how do we get access to these new medicines? And it's coming at a great time, though, because as you heard, certainly with the companies here, and certainly as people have been coming and talking to you, the horizon in terms of, you know, blood disorders, rare blood disorders, is amazing. We are going to be having such amazing therapies that have been coming into cancer, that have been coming to other rare diseases, now coming on your doorstep. As we say, the good news is that we've got all these new therapies. The bad news is that you'll have HTA. So this is the challenge we've got, right? Because now we'll be subject to a whole series of other assessments and evaluations that were probably not front and center in terms of whether or not, as Asia says, you're going to get the drug reimbursed. This is the process, as you know. It starts off with the submission. It goes through PMPRB that says what's the maximum pricing is going to be, and then it goes through a whole bunch of evaluations, including, you know, Health Canada to approve the therapy. It goes through the HTA agencies, CADIT or INES, in order to determine kind of not just whether it's cost effective. We think of that, just that, but it goes through a lot. Whether or not, you know, the drug is an added value to what's already there. Which patient populations that could be eligible for it, because Health Canada tends to give a broad label based on the clinical trials, but in fact, it may not be the same as one would say, okay, we should absolutely make that drug available to everybody it could be possibly indicated for, and certainly at the reimbursement end. Should we pay for everybody who might benefit from it? And quite frankly, as we know in many of these new therapies, as we talk about them, they come through with very different kinds of evidence than some of the traditional therapies. And even for a patient, one has to say, is this the right drug for me, based on the evidence that's already there, even though it could be approved for me. And I think that's that's the difference in terms of what it used to be. Makes it much more difficult. And then, of course, it goes through, as we say, once we go through CADIT, which actually will look at who is it eligible for, under what circumstances should be made available, and also how much should be paid for it, based on other therapies that are already in existence, based on the increasements in terms of the disease impact that it might have, the benefits that it might have, how much do we think we want to pay for it? And then it goes through another whole series of discussions with the pan-Canadian drug agencies that's going to negotiate how much they're willing to pay for it. And then after it goes through all that, and you even sign the letter of intent, it goes to each province who will basically say, well, I know that we said we'd pay that for it, but do we really want to make it available? And it will still go through, in some provinces, another HTA that says, we want to make it available, we're willing to pay for it, which patients are going to get it, and under what circumstances. So and that process, as you know, can take, at best, it can take you 1.5 years. At worst, it can take you 7 years or more. So you think about it, you got a new therapy coming in, you really want to make it available to your patients, it could be 7 years before you get it reimbursed. This is why we need to kind of do something different. We have an inordinately complicated drug reimbursement system in Canada. It's not the worst in the world, but it's far from being the best. And it's far from being absolutely functional. So this is the case. It goes through many, many steps, right? What we'd like to do, well, there must be a pointer in here, but I'm afraid to press it, because usually I end up with a black screen when I press what I think is a pointer. So what we like to do is to go from all those different steps to the to the down elevator that's on the escalator that's on the right there. We need to be able to get a product from the point at which it comes into Health Canada, and Health Canada says, yes, we think this is going to work, even before it gives the final approval, to say, okay, can I get it to my patients? And some of you will know as clinicians, you've got patients that are already getting it maybe through clinical trials, that you've already asked for compassionate access for, early access, or you've got your eye on it to say yes. Or you've got very smart patients who are saying, hello, when is it coming, when is it coming, when is it coming? And because they've seen it elsewhere, they've seen it in terms of, somebody has seen it advertised in the States, quite frankly, before we even get it. So this is the challenge, right? We want to get it. And we want to get it because in many cases, these are transformative therapies. And in sickle cell disease, as we know, some of these are going to be the first time you get an effective therapy for this treatment, right? And sometimes, in many cases, we're talking about a severe progressive disease, and Vertex-Nosis as well, and others as well, that you want to treat as soon as possible because the disease progresses, and you don't recover function. So the longer it takes to get the drug to the patient, the less likely it's going to provide the optimal, maximal benefit. And in some cases, as we saw with SMA, right, spinal muscular atrophy, if you pass the point at which they have actually been able to retain some of that muscular control, the child will not be able to walk, the child will not be able to breathe on their own. So we're losing function, and it doesn't come back. So this is kind of why, in many cases, some of this is so urgent. And the idea that, we get a drug and it's going to take 2, 3, 4, 5, 6, 7 years to get it. So how do we get it? How do we move forward, right? Well, we know how we do it in Canada. Well, this is the review progress, this is the timeline, okay, I won't belabor it. What we do know in Canada, quite frankly, is that we have a wonderful healthcare system, and we heard the first physician speak about it, you know, we're the envy of the world in some respects in terms of our healthcare system, but not if you have a rare disease. Let's be clear. If you have a common condition, if it's something that is easily treatable, or something that we've got already protocols for, you're in good shape, in many much better shape than those that might be in other countries. If you have a rare condition, didn't have a rare condition. My grandson went to the emergency room here in Canmore yesterday. He had some kind of a urinary infection or whatever. 6 hours he was there in emergency and never got to see the doctor. Never. Finally, in desperation, she calls her GP, gets a prescription, and leaves. Aisha should have called me. Aisha's actually his aunt, for God's sakes. I kept saying, I said, we got a hotel full of doctors. Like, why are we here? Can't we just go and find somebody who can actually do this? But then I'm thinking, like, maybe they're hematologists. Maybe they don't do urine infections. I have no idea how specialized it is. But anyway, the poor guy, he, 6 hours in an emergency room with a baby. They couldn't quite figure out how to get to him anyway. But as we know, in rare conditions, this is the challenge in Canada. We do common well. We don't do rare very well because our system is set up very optimally, right, for public health care, for providing the broadest access to patients with the broadest kind of care. And yes, in many cases, oftentimes very good care, but we don't do a good job. We also do not do a good job with drugs in this country. We lag most other OECD countries in terms of new drugs coming in, both in terms of timeliness and in terms of the number of drugs that are actually reimbursed. And there's lots of reasons for it, which we won't get into now, in part because there's a private-public system that's in play. And there's some assumption that if you have private insurance, fine, you're home free. If you have public insurance, well, we're going to wait a while to figure out whether or not we can get it to you. And as you know, with many of our patients, these are patients who are going to require the drugs to come through the public program. And this is a challenge because it's sort of seen as, well, we can kind of wait. It's not urgent. This is who pays for meds and how much for rare. As we can see, even though we have all this angst about the amount of money that's going into paying for rare disease drugs, at the end of the day, the amount of money that we pay for rare disease drugs is minuscule. The total budget impact is very, very, very small. Even with these very expensive individual drugs, we're not talking about a huge impact on the budget. So this is it's an interesting kind of a challenge, right? And I'm not here to justify whether or not the price that's, charged for an individual drug is right or wrong. That's not the case. But the case is that overall, as a country, can we afford these therapies? You betcha. There's absolutely no reason, especially when we're thinking about offsets in terms of what it costs to not treat. And I think that's the struggle, right? I mean, it's not a total offset, but it is the recognition that just because we don't pay for a therapy doesn't mean we're not paying for the disease. Just because we don't pay the patient to actually get access to the best treatment doesn't mean that we're not paying for that patient to get the wrong treatment or no treatment. So this is the challenge we've got. But at the end of the day, as we say, it isn't that big a deal when we think about the rare. Even if it comes in, estimates are that in the next 10 years, if we were to fund every rare disease drugs that came in, it would increase the budget to maybe about 6% or at most 10% of the public drug spend. It's not a lot. This is how we do lag many other countries. This is not the time to go into why. There's lots of reasons why we don't. It has a little bit to do with the fact that because we're so bad in terms of reimbursement, that companies don't come to us first. We also have some challenges in terms of clinical trials. We also can be smaller in terms of clinical sites. And we need to do a much better job of putting Canada into the position where it's really going to be attractive in terms of clinical trials. And guess what? We could do it. Companies look at us and say, you could do it. But what we need to do is do it smart. We're actually stupid when it comes to it. I'm serious, right? We force every company to go through each one of the ROVs. I mean, really? We could do one. When you think about the size of the clinical trials, and you think of the fact that all of you are connected to each other, you really need to do this in your own clinic, to actually have your own separate approvals and your own set of guidelines? We could do it together. And if we did that, we would be so attractive to companies. And if we could, we were talking about registries before, we had one database. Think of how wonderful that would be for a company to be able to collect. I think I was having a conversation with one of the other company reps, and we both had said, somewhat independently, the same thought. Canada is in the most amazing position. We're big enough that we actually have a big patient population. We're expert enough that we have really good clinicians and clinical sites. And we're actually small enough, though, that we could actually do things together if we wanted to. And proof of putting it, some of the things like, you know, hemophilia clinics, right? They actually work very well together. Proof it is in terms of our pediatric sites. They're all connected. I did not know that you can actually, they actually operate under one database. I mean, it's an amazing thought. You know, we could do this so much better if we build on the expertise that we have. And I will say, the CBS, even with CBS and Hemo Quebec, because they work very well together, is really the envy of many countries in terms of what we're able to do in terms of having a single unified blood collection system, and for the most part, an approval process in terms of these therapies. You know, the day was that if you had a rare blood disorder, you were so lucky because you had CBS to actually take care of you. I mean, it still is very much that case. And I love the new guidelines that you're coming out in terms of the approval process. So we'll see what September 27th tells us in terms of exactly how it's going to be executed. But we're very, very, I mean, we have the capabilities of doing this if we can figure out how to translate it into many of these other areas. So we don't need to be this. We do not need to be at the bottom of the OECD countries in getting new orphan drugs. We do not need to be among the last to actually get access to clinical trials. This is my little diagram of, you heard this morning talking about the Orphan Drug Act, right? Here's where we are. You know, we're still sitting here in Canada, still trying to decide whether or not we want to enter into this world, right? Every other country's coming in with orphan drug legislation. It doesn't mean that we have to have orphan drug legislation in the same way that says we provide benefits to companies if they do the clinical trials here, but it certainly helps. It puts us in the position to say we care about rare diseases and we care about orphan drugs in this country. So this is where we need to be, you know, and we need to make sure. I mean, I find nothing more distressing than to have researchers in our academic centers, in our clinical centers, that are working and developing new therapies, and they actually even set up startups. They get funding from, you know, venture capitalists to actually get to the point where they're actually being able to prove those molecules. They may even bring them through phase 2 clinical trials and then they sell the company, because we do not have the support for them to bring it to a full market here. So the companies disappear, they go south, right? I mean, at some point they get bought by a bigger company, but they do. They go to Boston, they go to, you know, California. Sometimes they even go to Switzerland because they can't do it here. I mean, what a shame. And then we cry about the fact that we lose all of that advantage that we invested in the medicine. Well, hello, it's because we didn't give them all the way through, right? It's sort of like funding a kid, you know, through the first 2 years of college and saying, well, good luck. You know, hope you get your degree at some point, you know, come back when you're, you know, successful. And then when we talk about the fact that, you know, these kids aren't graduating, we say, oh, yeah, you know, too bad on you. I mean, this is what we're doing. We're turning out our kids before they graduate. You know what I mean? We've got to figure out how we get into this game. And guess what? We're in such a great position to do it because we have the expertise. We have the capacity here. We have the desire. I spoke to a group of medical students who were actually in drug development programs. Who knew that there were so many medical students that were interested in drug development? But they are. And one of the questions is, how can we get better support from the regulator in terms of development? How do we get support in terms of venture capital, in terms of furthering our products? And it's so important. The other things we're good at is things like medical technology, which not many countries are really great in. I saw this robotic arm coming out of Quebec that it just blew me away. You know, I don't think I have a picture of it here. It was at the Spinal Muscular Atrophy Conference a few weeks ago, and this young man, you know, demonstrated this robotic arm developed in Quebec. Amazing arm, you know. It was so amazing, in fact. It wasn't him that was in the photo, but they had the photos and the videos of it, of somebody putting on mascara with a robotic arm. Can you imagine a robotic arm that does mascara? Probably does a better job than I do, right? Can you imagine, right? I mean, this is, but guess what? I'll tell you the tragedy of this. I'm segueing a bit, but that's okay. You're a great audience. The robotic arm is actually not funded. We do not reimburse for medical technology. Very few wheelchairs get fully funded in Canada. Very few medical technology that patients absolutely need in order to treat a disease, right, is absolutely well funded. Even when we think about some of the things around knees and other kinds of, you know, of issues, right? My husband has Parkinson's, you know, and a lot of the stuff that he could really benefit from is not going to be paid for by the government, right? So you know, we get it, right? I mean, though all his meds are. I mean, this is the challenge we've got. This robotic arm developed in Quebec, only country that really funds it is the Netherlands, but in Quebec, if you're in an accident and you actually have a spinal injury where you lose mobility, the ability to actually, you know, use your hands, and it can be managed by a very small little touchpad, you can actually get the robotic arm paid for. If you're a patient with spinal muscular atrophy or another kind of chronic condition which causes disability, you do not get it covered. Like, how is this making sense? I'm just saying, you know, these are the challenges we have. This just looks at how much we spend on rare in other developed countries. We're not doing a good job, you guys. This is a challenge we've got. We've got to step up to it. These are therapies that are coming in, and the situation's only going to get worse because more and more of these therapies are coming in, and we're actually falling farther and farther behind in being able to make them available. You heard some of the amazing, you know, treatments that are coming forth. Don't you want them for your patients? Wouldn't that make a big difference to you? Even some of the ones that are here now, beta thalassemia, Revasa. I mean, this is an amazing treatment. And it's still negotiating in terms of cost. I mean, it will get there eventually, but, you know. This is some of the other funding for rare disease drugs. As you can see, all the provinces are far behind most of the other OECD countries in terms of how much we spend. And this is what percentage of rare diseases are actually funded by the provinces versus what percentage of actually approved rare diseases are funded by the best advanced countries. We're, again, not up to speed here, you guys. These are some of the issues that we've got in terms of the therapies. The challenge, as we say, and I won't read through each one of these, is these new therapies are actually really difficult for our existing health technology assessment agencies to actually evaluate. It's very challenging for them. I mean, you think about the traditional HTA, and maybe you don't think about traditional HTA, but if you thought about traditional HTA, it was actually put in place to actually do comparative effectiveness. That is, if I have a protein pump inhibitor and I have a new protein pump inhibitor, how much better is it than the old one, and how much then should I pay for it? If I even have a chemotherapy and it's the 5th for this treatment, how many more years of life that it gives the patient, how much more does it cost, and how much then should we be paying for it? That's what it was all about. In many of these cases, we're talking about first-in-class treatment. There is no comparison. And so the sad news is that when you compare a very expensive drug to nothing, it's really expensive. My old treatment was 0, you know. So this is our challenge, right? So we need to figure, I will say, you know, Zolgensma, which is the gene therapy for spinal muscular atrophy, I don't know how, you know, whether you know of it, right? It's been approved, it's now made available, but we all know it would have never actually even been funded if it had not been for Spinraza being the first treatment for SMA. So this is a intrathecal infusion for SMA. It was the first treatment to come out for this disease. It's a spinal infusion. It really will slow the progression of the disease, but in many cases will not, you know, halt it completely. Very, very expensive, $700,000 a year is kind of a list price. Gene therapy comes out, and it is about $2.3 million is kind of what the list price is. God only knows what the negotiated price is, right? But when you think about it from a cost-effectiveness point of view, after 3 years, I've paid for it. And the patient is going to be mobile potentially for life. So as a cost comparison, it is really cost-effective. But if I hadn't had Spinraza approved to begin with, through dint of very strong advocacy, people would still be looking at that gene therapy and saying, oh my God, do I want to pay $2.3 million per patient? Guarantee you. We would have lots of patients who are now treated, have to treat them before they're 2 years old, at least, you know, to get the optimal benefit. Those patients would not have got treated. These are the challenges we've got, right, in terms of all these. Hypophosphatasia, I love it very much. It's a very important drug. It's one of the first drugs. It was an active drug that was invented in Canada, found by a physician at McGill, University of Montreal. The drug was exactly one of those I talked about. Once it got to a certain stage in development, it was bought up by a company in Boston. It moved to the States. They developed it further. But the first clinical trials were still in Canada because the drug had started here, and Health Canada approved it. And I remember seeing those patients come in. Hypophosphatasia is a really rare bone disease, and where children's bones are so fragile, sometimes on an X-ray you can't even see them. The first baby that we had in Canada came from Ireland. She was so fragile. She was 6 months old. She'd already had 60 broken bones. She was so delicate, only her parents could handle her because they knew how to lift her. 5 years later, we get the videos back after treatment. She's skipping rope. She's running around. I mean, this is what we're talking about, right? You know, but guess what? The drug, even today, after all these years, it's been a good 10, 12 years, is not approved for adults. Because they say it's a childhood disease. And if you are an adult, you probably have a milder version of the disease. Otherwise, children would actually not survive much into their late teens. They would not have survived, right? And so they're basically saying, we don't have good clinical evidence in terms of how well it works for adults. It's sort of like a blood transfusion. I don't have the clinical, results in terms of transfusion for a certain population, so we're not going to believe that a transfusion is going to do you any good. Well, it does work. It's the mechanism of action works. And we have patients who are adults who actually suffer over and over, broken ankles, an inability to work. And we know that when we give them the therapy, it works. But there's not the strict clinical trials that have been done. Today in Canada, it's still not approved for adults. I mean, these are the challenges we've got in terms of how these drugs are actually brought in and approved. And that's not the only one, that because it has a pediatric indication, and it was actually Pompe's disease was one of the first ones I worked on. Pompe's disease, which is a very severe lysosomal storage disease, where there's in fact, the inability to clear certain kinds of waste products, it was proved on infants. If in fact, for very severe infants, for infants with the severe disease, they actually solve for cardiovascular disease, usually by the age of 1. So it was a huge rescue. They did the clinical trials on that infant population, 2 reasons. One is it is a weight-based treatment, so they only had very small amounts of the product they were inventing, they could produce, so they did it for infants. And you can demonstrate the benefits really clearly in the infants. So it was approved by Health Canada for all Pompe's disease, but the clinical trials were only for infants. In the infinite wisdom of the HTA agency in Canada, they said, okay, the clinical trials only give us evidence for children under the age of 1 with cardiovascular disease. We will make it available to any child who is diagnosed under the age of 1 with Pompe's disease and has cardiovascular disease. Like, hello, we didn't have a child that fit that description for 3 years. We had lots of older kids, and we had adults that could benefit from it. And we didn't approve it. We did strong advocacy, but I will tell you, and this is much to where we were talking about in terms of patient information, patient registries. A real sad point is that we have not done a good job in figuring out for whom it works and who it does not. This is the sad point of how the system works, and this is when we talk about patient information and keeping patient information, what we really need to do with it. Only about 60% of the patients really respond well to it, and guess what? You know what the answer is. We don't know why. We have no freaking idea of which patients are actually going to benefit and which patients are not. And in fact, which patients even get adverse effects. We could know if we would actually do the post-market monitoring. All we would need to do is collect the genotypes of all these patients and enter them in the registry. All we would need to do is to be able to collect the information in terms of how they're responding over a period of time. And after, it's been 10 years, we would have enough data to let us be able to go back and say, what characteristics of the patients, even on the basis of their genotypes, could tell us which ones are responding, which ones don't. We still don't know. And so we do 2 stupid things. No, I'm serious, right? We give it to all the patients, and some of them respond and some of them don't. And we don't know which ones to take off because we haven't tracked this stuff. And so we're not only not treating the patients well, we're wasting a hell of a lot of money. And if you want to know where I'm going to get money from my next drug, we just need to be able to look at the patients who are not benefiting and not continue. Now, people say to us, when we're talking about some of these drug plans, well, patients won't come off of therapy once they're started on it. Those of you who are parents would know damn well that if your child is not responding to a therapy, and it also is difficult to take, and if it has some potential adverse effects, you're not going to keep that kid on the therapy. I use an interesting example. 60% of chemotherapy, right, doesn't work. And you come in and I say, okay, it's really clear, Asia, this drug is not working for you, okay? But you can still come in every week, 3 times a week. You'll get nausea, you'll lose your hair, you'll be, but it's okay. It's not working, but you can come in every week and we'll continue to, give you the chemotherapy. I'm sure you'll volunteer and say, here I am, right? We're not, you know, and yet we believe that's what's going to happen with some of these rare diseases. It is true. In many cases, people are desperate. They feel like it's the last hope. But that's where you got to bring the patients back into the equations. You got to help patients understand. You got to help patients be able to start from the very beginning and say, this indicates it's not working. So these are, we have so many of these. Prader-Willi I love. After 20 years, growth hormone therapy works for people, patients with Prader-Willi. We do not have clinical trials because patients were brought into this and given, you know, growth hormone therapy over the years. They've never done, you know, trials with it. In Canada, we still insist that Prader-Willi patients have a certain level of growth hormone, which would be for normal kids, would actually, well, kids that don't have Prader-Willi, would be an indication you need growth hormone therapy. For persons with Prader-Willi, that level is not right. They actually are going to suffer when their levels are actually much higher than that. And in every other country that I know of, kids get access to growth hormone therapy. In Canada, it's still on a province-by-province basis. Can you imagine? You know, and Health Canada says we can't change the indication until you do clinical trials. They've done some clinical trials now, but that's amazing. And the companies kept saying, we're not going to do clinical trials. Number one, we can't even find, you know, patients to actually do a placebo on. Everybody's getting treatment. I said, well, you got Canada. You can use it as a control group. I don't mean to be flippant about this, but yeah, this is us in terms of how we do drug advocacy. That was us sitting in front of the Parliament building. It was a great day. It was great. People were saying, we're going to march to the apartments, pouring rain. I said, all the better. A huge sympathy for a bunch of patients standing in front of, you know, freezing cold rain in front of the Parliament, right? Do not take it as a bad thing. That's a good thing. But this is, I mean, we shouldn't be. And I mean, this is way back. Let me see if I can go a few slides here. This is the first child who was getting access to a cystic fibrosis drug. Huge advocacy to get access to it because the government, after the company had agreed way back when that we're going to forgive everything except for the last 20%, they couldn't get the government to come forth with it. And so she was doing fundraising to get access to the therapy. This is my 2 Alberta patients who were trying to get access to spinal muscular atrophy to Zolgensma. They did fundraising, raising, you know, trying to raise $2 million. They actually got it, but, you know, again, Alberta actually stepped in at the time to do it. This is one of the other patients who got early access to the therapies. This is a set of twins who actually have spinal muscular atrophy. They were too old to qualify for the drug gene because they were misdiagnosed to begin with. They continue to be misdiagnosed. They were actually given, you know, the wrong treatments to begin with. By the time they got to the point where they could be diagnosed, they were too old for the therapy. I'll tell you this last because it's so important, is that they actually said by the time Novartis opened up clinical trials for kids over 2 years old. So these children are almost 3 at the time, but the limit at that time was 2 years old. They said, okay, we'll do a clinical trial. They have 1 clinical trial in Canada, 2 doses available to Dr. McMillan in Quebec. And he says, I've got a Quebec patient I promised it to. And he says, I can only do 1 of the twins. Now, if you were the mom, and she says, it's impossible, I can't do 1 twin. God bless Dr. McMillan. He went back to the company and says, I cannot just dose 1 twin. He says, number one, if I dose 1, the other twin is going to be there constantly. They're going to develop antibodies to this, you know, viral vector. I will never be able to treat this other child. For God's sake, if you can't put them in the clinical trial, just give us a compassionate dosage. And God bless Novartis, they finally came through after much effort on mother's part and on the doctor's part. I mean, I just want to say is that this is the way we do advocacy. This is not the way we should do advocacy. And what we are doing now, this is the gene therapy for blindness. And, you know, anyone looking at it, could not get access. This is a young man who's going to lose his eyesight. He's on the verge because you still have to have functioning cells in order to be able to get the gene therapy injected into it. He's losing it. He's going off to college. And we're desperately trying to get him access. His drug plan, private drug plan, says we can't approve it because it's a pre-existing condition. Well, yeah, you know, it's a genetic condition. The government says, no, we haven't negotiated the deal yet. And we're saying by the time he negotiates the deal, it's going to be too late. The doctor steps in and is fighting for it. Okay. Oh, okay, let me finish. Yes, let me get to my really jump point, okay? What I want to do, and this is the point we really want to get to, is we have the opportunity to actually bring into Canada, as you know, a new rare disease drug strategy. And I'm going to do this in the 1 minute. Canada, 2019, the federal government stood up and said, we're going to commit $1 billion to implementing a rare disease drug strategy. That was pretty amazing. That was a political decision, but it's okay. We don't care where it comes from. Now, COVID intervened, so we're trying to get consultations on it, and they kept saying we're dealing with COVID. So we began consultations. We've been consulting for almost 3 years now, and we come back with a proposal. I will tell you what we're asking for in this rare disease drug strategy. $1 billion to set it up, $500 million a year. I'm saying really strongly, I don't want it to pay for drugs. As you can imagine, $500 million isn't going to buy a whole lot of drugs. What we want it to do is invest in infrastructure. We've got to have the infrastructure. We want to invest in centers of excellence. We want to be able to invest in early, timely diagnosis. We want to do newborn screening, gene testing, genomic sequencing. That should be the rigor for anybody who might possibly have a genomic variation that would be amendable. We need to institute that. We have pilot programs on it. We want to have centers of excellence where the specialists, I mean, somebody was talking about the hub and spoke model. This is the recommendation. We need to have centralized hubs, and we need to have, we don't want to call them spokes. We're actually calling centers of excellence, and somebody called them centers of, in some other countries, they call them centers of competence. Centers of excellence and centers of, God, I forgot the word now. What's another word that's not quite excellence? Anyway. Better than competence, but a little less than excellence. Whatever it's called. The whole idea is you have a hub and spoke model. But what we realized is nobody wanted to be a spoke. So yeah, I used to have these centers of excellence connected to centers of distinction. That was it. Where you would get designated to be a center of excellence. And there are certain qualifications that go through. The U.S. just approved 31 of them. We're going to try to follow their model using their criteria. Indonesia has 8 of them. You know, we're going to try to follow through, right? So have sent that hub and spoke model. And again, it's got to, and the most important part of it is that we need to have, and I'm going to back away from the word patient registries. I'd listen to the wonderful discussion you have. We don't want to call them patient registries. They're really called patient monitoring and management information systems. The whole idea, right, is to be able to collect the information that you need to be able to, exactly what I said with Pompei's disease. For whom does this drug work? For whom does it not work? And for, you know, and how do we feed that information back into the system so that we can actually improve the criteria and to be able to treat those patients for whom we should be treating and do something else with the other patients. This is the essence of it, right? So but we got to have centers that do that. And we've got to have the information systems that are there. And I will guarantee you that data platform, in order to do this, is here already. We can do it. We do not need to do a whole lot of directions. I've talked to Zayed and Sarah about it. We're going to come back to it. So we need to have the centers. We need to have adaptive pathways. Remember that little escalator we saw on the side? We're going to make that the de-rigor. Drugs come in, whatever clinical information we've got, we're going to set it up so we've got managed access and we can follow it through. And what I say is I can guarantee you at the end of the period that we're setting it up, only the patients that were indicated for this treatment are going to be getting the treatment. I mean, that's all we want, right? We don't want, I mean, nobody wants to be treated, but we need to be able to do it at a timely fashion. And then the third one is patient engagement. Patients have to be fully engaged at every single level. And part of that means also that we need to not only support the patient organizations, but we need to upskill the patients. As you know at CBS, we can have patients in an advisory group, but we also need to have patients at various levels. Some that are patients, some that are going to sit on the community advisors, some are going to be part of that decision making. That's what we need. So this is the essence of the system. This is what we're asking the government to do. I can tell you, after 2.5 years of consultations we've been presenting to them, they parroted back to us all the things we're saying. Do you know what they offered us? And I'm going to say this, even though it's not the right thing to say. They offered what they would want to provide for in this rare disease drug strategy. They said, we'll give you a list of drugs that we want to fund. I said, like, huh? You cannot do this. I do not want a list of drugs that you're going to fund. They said, well, there are people that have gaps. They're not getting access. I said, fine, find them a drug plan. Do what Quebec does. Put them into a drug plan. This is a waste of money. We're already funding many of these drugs. And it's the wrong thing because this is what we need. Once we fund a list of drugs and we put our monies in there, we're not going to get back to where we have the opportunity to create these centers of excellence. They said, well, how much do you want to invest in infrastructure as opposed to drugs? I said, 75%. We need to put 75% in. The only thing I want for that 25% is a drug fund. I call it my slush fund. New drug comes in, we don't have the budget for it yet. That's fine, we got a little bit of a slush fund. And we want to have it double what we could actually have, because I want companies to contribute to the other half of it. We need a fund that we can immediately fund out of. If the drug works, we keep the patients on it, the drug plans pay it back. If it doesn't work, that's fine. We take the patients off of it. Make sense? Anyway, that's it. Okay.
And I think I'm going to steal this thing from you. Yes, maybe, well, you know what, you sit there, and I will steal this. And are you going to do the online questions? Yes, I'll stand right beside you, though, I think. And we need to get a microphone. Could I get a microphone? Oh, okay, perfect. Okay, how do I do this? Madeline?
It can stretch and sit
Oh,
here.
can it? Okay, perfect. And sorry, Madeline, how do you do this?
Here, you use that funny little nub in there.
Yeah.
This is like your mouse, your cursor here.
Oh, I see. And these are the last ones? These are just amends.
Yep, looks like there's nothing else.
Okay. I don't mean you're like.
Control plus, maybe that'll work. On that one?
Oh, look at you, fancy.
Where's the plus? No?
Nope.
Yeah, it doesn't change the font. No, it changes the font over there. Right.
Yeah, that's why everybody's been doing that. Yeah, exactly. So, would love to, well, thank you, first of all. Passionate presentation. I think we all buy into this model. As the providers, we love the idea, I believe, I speak for the room, about really funding the infrastructure. And as I think it was echoed by Dami at one point, like mental health resources, all of those things are lacking, and that would be part of the infrastructure, because it's not just the disease, it's living with the disease, right? So I think we love the model of care you're presenting, so thank you, and we'll love to take questions from the floor and questions from the chat.
Okay, questions from the floor. Go ahead.
Thanks, Durhan. My question is around what the most effective way you found in speaking to the many people that and organizations that you speak to in getting the point across around deferred direct costs that end up costing the system indirectly.
Well, we have wonderful examples elsewhere. So for instance, gene therapies, right? Really expensive up front, and the payback is unknown in some cases, right? Will it last? We don't have clinical evidence that shows it's going to last a lifetime, for God's sakes. People haven't been alive for a lifetime. You know, so one of the recommendations coming out, and it's being used in Europe, for instance, is in fact time lag payments. You know, we talked to the provinces here about it, and they said we don't have our system set up that way. I said, for God's sakes, that's a bookkeeping. You know, I think you can handle this. You know, all of you know how to deal with mortgages, don't you? You know, so it is, it can we have? And that's why I like to see a fund up front, have a fund. We need to have the financing up front set aside to say these innovative therapies are coming, you guys, so we need to be able to fund them, but we need to have agreements with the companies. Let's do some risk sharing, right? If it works, we continue to pay. If it doesn't work, then we don't. Even for the gene therapies, people say, well, how can you continue to do that? Because it's already, you know, it's a one-time thing. It's not like an ongoing, you know, continuous treatment, which you could say, okay, we'll stop if it doesn't work and we'll stop paying. It's, again, it's time lag. In the US, many of the drug plans are actually saying, we'll pay over 10 years. And as long as the patient is alive and meeting certain benchmarks, we will continue to make the payments. Somebody asked you this question, what if he gets run over by a truck? I said, oh, for God's sake. I don't have an answer to that, you know. But, you know, if it's related to it. But, you know, so there are models for it. We just have to think differently.
Thank you. Pay for performance. That's what we've entertained with a lot of the gene therapy assets.
And then the pay for performance, though, is something that really is part of that whole thing that you folks are talking about, is the ongoing patient management monitoring, right? What information is going to demonstrate that it's working? And we need to have agreement up front. What it indicates that it's working, right? Because that's the challenge we have as well, is that what indicates that it is performing as opposed to not performing. And that's, you know, part of it is going to be, you know, patient information. Part of it could be biomarkers. Part of it could be symptom management. But we just need to get the agreement that this is what we're looking for.
Can I take the prerogative of asking a question as a moderator? So this is focused on new drugs that are super expensive, but there's a bit of a gap here. What about cheap drugs that are old that nobody's going to make $1 billion from, and so aren't going to fund the development of, like hydroxyurea, learning how to use it properly, like low molecular weight heparin for sickle crisis and things like that?
Actually, there's some later slides here. I have a whole slide deck here. But so there are many gaps we have in our system. And certainly the ability to fund and to support older therapies, which quite frankly companies are not going to invest in, right? Because there's no return, or they're generic, and there are many other companies that may be involved in it, right? But that's where you've got to have a drug strategy step in. And we need to look at where's the barrier. Is the barrier at the regulatory end where they're saying, look, we don't have the clinical evidence. What can we negotiate on? If it, in fact, is being used in 14 different countries, is that enough? You know, if it's already collected information in real-world evidence, is that enough? Let's negotiate on that, right? I think the other thing we have to do, as you say, is set up a process. I'm part of the IRDIC, the International Research Consortium on Rare Diseases, and we have a number of major projects on repurposed therapies. And again, that's quite the case. Sometimes off-label use, sometimes genuinely repurposed. And it goes back to saying, we cannot just rely on one pathway. Right? And this is why we say we need multiple pathways that are suited to the therapies. We need a pathway for older therapies. We need a pathway for repurposed therapies, off-label use, absolutely. But that's kind of what this whole drug strategy is about. Let's start at the point where we can actually look at what we're doing now and not have one process that's going to fit everything.
Kevin?
Hi, Doreen. How do you propose that we, or federal government, overcome the iron grip of the provincial governments on healthcare, particularly given the fact that it's constitutionally entrenched?
You know, Kevin, you're under the mistake that the federal government knows what it's doing and the provinces don't. So I don't know if I want the federal government to, to release its iron grip. I'm only teasing, as you know. Here's an interesting thing. We took our plan to the provinces, and we've been speaking with them. And I'll give you, well, I'll even tell you what province. We went to a number of provinces. BC, which were one of the hardest customers we've got, right? Speaking to the Assistant Deputy Minister, we took our plan to him. And he said, this is the best thing I've seen. It is head and shoulders above what the federal government showed us. Provinces are ready to buy into something. They have actually rejected that first proposal because it means that the government's going to own their drug plans. They're going to manage it. They say, hands off. Even for pharmacare, as you can imagine, provinces are saying, hands off. We do not want a national drug agency, So I think provinces see it, right? What we're presenting to them, and what we need is some good economists to work with us. I'll tell you what we need more than anything else, and what I've been really delighted to see is clinicians. Aisha says talk about, patient advocacy. I really want to talk to you about clinician advocacy. Without the clinicians, nothing happens. And you know that. I mean, every one of the examples I gave you, it was a clinician stepping up, or more than one clinician who steps up and says, this is what I need. The patients can be there. The patients can be in the streets, right? We can be in front of the parliament, but we're not going to get into the boardrooms. We're not going to get into the tables to say, this is what we want. The clinicians do. And when it's both clinicians and patients are saying it, it's very powerful because you will bring into it the actual medical scientific information. And what we need from you is to really to be able to back up the fact that, as somebody else was saying, the most cost-effective strategy is a strategy that actually does address, the needs of the patients and does it in the most timely fashion. And if you believe that, that's what we need to make sure is the message going around. So the provinces kind of get it. And I can tell you an easy example is Quebec. I mean, Quebec's rare disease strategy is exactly what we're talking about. Not exactly, but it's pretty much what we're talking about, right? And they're buying into what we're talking about. And we're getting every other province. I mean, Alberta. Alberta's biggest concern was how do we get patients off a drug that doesn't work? But, that's easy, as I say. We need to negotiate it, right? But I think the provinces are quite willing. They're not quite as willing to just say, okay, just throw me a bunch of monies and I'll suck it into my drug plan and then off we go. I don't think they're there. So But we need you guys to actually be the ones to say, this makes sense. This is what we buy into.
Rob?
Oh, hi. Just building on what Don was saying, I think one of the things that drives me as a clinician crazy every single day is that the system in Ontario, which I'm sure is the same for all the other parts, is entirely set up for family doctors dealing with common disorders. You know, rare diseases is not on anybody's radar, so we have all these silly things that, you know, all of my hemophilia patients, I have to say they have osteoarthritis so they can get Celebrex. My wife is a nephrologist, and every single one of her patients has Zollinger-Ellison syndrome, so she can give them, you know, H2 blockers. So the whole system is entirely geared towards family doctors with common disorders. And so I think when you're talking about infrastructure, I think if we could sort of deal, while we're working on infrastructure, deal with this archaic system that was built with rare diseases not on anybody's radar.
That's a hugely important issue. I mean, we didn't actually go through all the things that a Center of Excellence is supposed to do, right? I mean, I tell you where the Center of Excellence is really coming through from. The WHO has endorsed a global collective network of rare disease centers. And so we're hoping to be one of those collective networks. And part of what's in there is comprehensive care. The most important thing, it's not just, you know, providing for clinical and medical. It's actually looking at the constellation of care. I mean, what we also know is that you know, you're talking about earlier, mental health, social issues, occupational issues, educational issues, you know, disabilities. Many of our patients, I mean, you know, some of the disability files are set up in such a way, as you say, you have to fake some other kind of disability to even get the assets for your patients. I mean, this is wrong. So we need to bring all that together into a rare disease strategy. And that is exactly where the centers can actually be in charge. Somewhere in the pediatrics is a little bit better, but that's where I want the money to go. Where does the money go? It goes into these centers so they can do these kinds of things in a reasonable, responsible kind of way. But part of it also is having, as you say, the data platforms, collect that information. If we can demonstrate that by able to provide X, Y, and Z in terms of other kinds of either medicines or in other times of care, that we actually end up with better patient outcomes, who would not want to do it? But we don't collect that information either because we don't have the systems in place to do it. And we need to put those systems in place.
Just in the interest of time, I want to thank you so much. I want to make a few comments. One, this speaks to our peer review process. I think we really need to get it going because I think we have self-identified as centers of excellence around Canada, but part of the whole peer review system is identifying centers of excellence and labeling centers of excellence with some sort of data to back that up. So when we get rolling with this sort of funding stream, that we will be able to actually have that data that centers of excellence and centers of what was the other part?
Distinction.
Distinction. So then we can also help identify our centers of distinction and help make criteria for those centers as well for the hubs, right? So I think as CanHaem, as an organization, that we need to get rolling on again.
Well, let me make you an offer.
I love offers.
Let me make you an offer. So one of the things we have been able to somewhat negotiate with Health Canada on this, they recognize that illicit drugs is not going to sell. And I basically said to them, I'd rather you fund nothing, spend no dollars than to do what you're doing, because we'll be down a road we don't want to go through. So we're proposing demonstration projects. They said, bring us some demonstration projects. CanHaem can be an interesting demonstration. It would be a very interesting demonstration project because most of what we're looking at centers right now are built on the pediatric centers. And what we do know is that obviously just pediatrics is not enough, right? And in the US, in order to get a designation as a center of excellence, you actually have to show your linkages to an adult site. We're not there yet. But it would be amazing to have something like CanHaem that come forth and says, we're not only pediatric, we're also the adults. That would be amazing. Talk to us. We would love to propose it as a project.
Yeah.
You know, I mean, we're trying to push some projects in front of Health Canada to say, here's where we want the monies to go. You know, we realized we were a little bit naive to think that if we just gave them the ideas that they would be able to come forth with something. So despite what you say, Kevin, the iron grip of Health Canada or the federal government is really not working. So, oh yeah, we need to do that, but we would love to talk with us.
I really think we're a great organization for that because we've always believed in pediatric and adult centers, and our patients, I'm a pediatrician, so my patients do grow up, and I pass them over to Lisa and Lauren, Lauren's virtual, but Lisa is here. And then they take good care of them in adulthood, and we have those linkages, right? And so I think it's one of the interesting places in rare blood diseases in Canada that we actually are together. The other thing I wanted to do is give a real shout out to our social workers. So I think Catherine might be the only social worker here right now today, but on the flip side, honestly, these are the people who go to bat to get the drugs for the patients right now, who cannot get access to them in every other way. Days and days and days of hard labor I see on a regular basis, because hydroxy is not covered in Alberta for our patients, for example. So those are the people who are doing all the hard labor in our clinics, and I really do have to give a shout out, because without that comprehensive model and those team members, we wouldn't get access to these drugs, right? I know, it's covered in Ghana, she just said. So hydroxy is covered in Ghana, but not in Canada. Not equitably in Canada, I should say, which is I don't know, a bit criminal. So
It's covered in Manitoba because it's a cancer drug.
Oh, yeah, see, inequities. Again, back to that inequities, right? It's not okay when the barrier is money, right? For a drug we know works well. I think that concludes the session, unless people have something they're burning to say. I don't want to cut anybody off too prematurely, but I am trying to move along. What do you guys think? Anybody have anything to say? All right, that concludes the conference for today, you guys. I have a number of slides just in thank you, if you don't mind giving me 2 minutes. And then we'll have a nature break, and then back for the AGM, which is a members only. And we have a number of issues to cover for the AGM. So if you could bring up my slides. You'll probably have to roll through a whole bunch of them. It's coming? Okay, you got it. Yeah, keep going. Keep going. Yeah. Keep going. Keep going. Keep going. Keep going. I wanted to give a shout out to our corporate sponsors who are here today. Cassie, as you heard from, was one of our platinum tier sponsors, so thank you very much. Oh, I have a pointer somewhere. Sorry, it's hiding. Bristol Myers Squibb as a gold tier sponsor. We had Vertex as a silver tier sponsor. Alexion as a copper tier. And Pfizer was a bronze tier. So thank you guys very much for helping bring us all together. I wanted to thank the Solera Resort and William, the very busy man in the apron with the red hair running around. He has been, I'm probably very sick of me by now. The Grand Catering, so all the catering was done by a restaurant called The Grand in town. And Core Global is our AV team. Stephen is our producer. And of course, Gallagher & Co., the Robs, a very big shout out to them. And really to all of you guys, okay? And to our partners who came and showed up in force, Canadian Blood Services, CORD, or Derhan's organization, SCADC, and the Thalassemia Foundation of Canada. So thank you, everyone. I know everybody's name. So, Jill. Somehow I knew I'd get a reaction. I love it. So we are going to start, and hopefully we can, well, we're not going to be fast, but we will try to be relatively fast. We have a lot of important stuff to get through. We're going to bring on Dr. Pastor. Yves is online. He's going to introduce the AGM proceedings, right? Mm-hmm. Oh, hello.
That is not Yves.
Hello. That is Frank. Hey, there's Yves. Okay. Get them both at the same time. I was like, wait a second, what happened to Yves?
Okay. Hello. So, we've lost our agenda on the screen with now that Yves is on. So, Yves, if you wanted to greet the audience, and then I think Aisha is doing her chair's report.
Right, absolutely. Yeah, I mean, first of all, I'm really sorry for not being with you today. And I definitely couldn't make it for various reasons. I'm not going to go through all of those. So, but I'm really happy to spend some time with you. I hope you had a really great time in Canmore. And I have no doubts that the organizing committee has done an outstanding job in this conference. So we do have that's the fun part for the AGM. That's where we need to discuss all that happened in the past year, and we'll go through the various reports. And first, we'll start with Aisha. So this is something we need to go through according to our bylaws, and then we'll have to agree with the election of new members and go through the constitution of the board without going and hopefully new members joining in. So Aisha, if you want to get on with your report.
Hi, everyone. I think most people probably know what we've done over the last year, but we will do a quick recap. One of the major things that we did was a strategic planning event. We went somewhere outside of Ottawa to a lovely facility with the board. Wakefield, thank you. I don't know, it was just a long trip. And we put a lot of time and energy with an organizer who will give a report on that, so I'm not going to go over it here in terms of where we should go as an organization, because over COVID, it's good to redirect, I think, at that time. We have also struck a new registry subcommittee. EB has handed over the reins to our two new leads, and you've already heard from them, so they're not going to give a further report really today. And they're going to give a very short report. The research subcommittee has kind of come back in, and he will give a little talk today, and that's Kevin. And I do have a little update from the peer review following up from our previous conversation. So really that's kind of where we're at this last year. We've really been focusing on just trying to regather and reorient, and really what are our important projects that we need to then move forward on over the next year. So I'm going to hand it back over to Frank.
Yep, over to Frank.
Okay, so Frank. Frank was our lead for our organizing for our strategic planning event, and he took us through multiple steps, and I think did a really good job on refocusing us whenever we got off track. So he's going to give the report from that.
And first I'm going to say, can you hear me? And just wave your hand there.
Yes, we can hear me.
We can hear you. Okay, awesome. So that's good. I'm really glad to work with you guys again. I wish I was with you in Canmore, because that's such a beautiful place. I'm outside of Perth here, presenting this to you. And so Rob's going to help me with this presentation as well. So he's going to, when I ask him to put the document up there, because basically to refresh you. So as you said, this was done last spring. And this is the report. So I'm not sure exactly how much detail you want me to go into, except that I heard you say that you're winding down and this is the end of your very busy day. So I'm going to try and be brief, and I might cut down some of the things I was going to say for that reason. I'll just introduce myself briefly as well. So my name's Frank Van Gool. I'm a professional facilitator. Been doing this for over 30 years now, and strategic planning is one of those very important processes that I facilitate with boards of directors and a wide range of industries and sectors, government, nonprofit. It's certainly on the medical side as well. A lot of clients over the years. Currently working with the Medical Council of Canada, who you guys are, I'm sure, familiar with, as you're probably members, many of you are members of or have been certified by. And so I'm just going to give you a real brief and try and get you back. I'm going to ask you this question, though, because you just spent a day listening to the work that's been done on behalf of CanHaem and what the strategy said back in the spring. One would expect you've probably been doing some work on it already. So it's suggesting that that these are big long-term goals, but you've been moving the yardsticks. If you've been doing anything in the area of advocacy, recognizing you've got to be influencing others in your network more than you have in the past, that's where the strategy is going. The strategy is also going around increasing education and outreach, letting people know more about bloodborne disease and the conditions upon which you guys work, recognizing there's not enough awareness. People don't know enough about it. We got to do more in that regard. So anything in that regard. Any research efforts being investing in more knowledge generation is also a key area of work for this strategy. And then two more areas: advancement of quality care, knowing that the standards of delivering care across the country could be even better than what they are now, and it's a long-term and probably never-ending strategy for you. And the fifth area, which I think is of interest here for you, is this idea of organizational stability. And Rob, I'm going to ask you to bring the document up and go to Appendix 1. I can't see the screen on my little phone here is not good enough to see it, but I'll bring it up on mine and follow you through it. Go to Appendix 1 where it says environmental scan. And just to give you the very simple description of the process and to bring everybody back to April when we did this, 3 steps. Step 1 is what, then so what, and then now what. That's kind of a nice way to describe it. What is going on? What do we expect in the next 3 to 5 years in the world around us? So what does that mean for CanHaem? What does that mean that it's going to affect us? Is that a big deal, a small deal, is important? What's a priority? And the third thing, what's here and to get done 5 years from now. So all of that is what we discussed in those 3 days. This is the what part. It's what do we think is happening, and you see the trends around the world of CanHaem and dealing with bloodborne issues. Continuing population growth, increased diversity may result in some disorders having greater increases than others. People living longer. What you're seeing there, though, is very demographic type trends, which suggests that the growth of the work that you have to get done is being driven by population growth generally. So it's not a massive amount of change. It's kind of what you're anticipating as you looked into the next 3 to 5 years was the prediction there. More information related to the prevalence and treatment. So there is more data being generated. Pharma is restricting what they're funding. So you're recognizing as an organization, you're likely going to be experiencing some challenges in terms of finding ways to continue funding. I'm not going to read all of this, obviously. So all that to say is there's not huge amounts of change coming down the pipe, but you're struggling in terms of getting voice because you're not growing and you're not, as a disease group, it's not growing dramatically, or it's not a crisis. Like the blood, we know that blood's experienced crisis in the past, and you can see what rallies around that in terms of efforts and work and research and attention and promotion and all of that. But when you're in a scenario right now where you're having to find ways to be better at advocating and better at awareness generation because the forces aren't driving it. What's interesting, what you have as a strength of an organization, you're kind of a part-time, you're all doing it on the corners of your desk kind of work. So to make this work, the strength that you have is the commitment that you each have. Those who dedicate their time to CanHaem and those who make efforts at all the organization, and anyone who's been on this board knows the work that it takes to be able to do all of this. And as an organization, that's your strength, your ability to bring this group of collaborators together, that people who are interested in working and furthering the field. So that's a strength, but you'll see that's also a weakness. As I'm rolling up to weaknesses here, you have to rely on volunteers, getting everything done within regular jobs. So that's a challenge you have as an organization. Advocacy is not central to what you do, but you recognize that for this organization to sustain itself, it needs continued effort and continued succession and continued work by those who are already probably work pretty hard already in their regular jobs. I'm rolling up to opportunities and threats, and they tend to be more forward-looking. It's as you look into the next 3 to 5 years, what are the kinds of things that we should be mindful of? It's an opportunity to do something or a threat that we might want to mitigate so that we're not unnecessarily harmed by something. And this is more the so what. So what are some of the things that we might want to consider? Taking on more advocacy, taking advantage of the fact that COVID it's not over, it's continuing, we all know that, but certainly the crisis component of it has moved on. So is there something that we can do in this in that world? EDI is, and I'm running into that with all of my clients. I'd say that they're all looking for ways to leverage EDI in their organization to give it greater focus. And for you, that is something clearly as you identified back then as something that you could leverage as well, because that obviously has relationships to the disease groups and patients within which you work. Looking at other ways to enhance mentorship, rejuvenate the organization, because as we move to threats, it's the burnout threat that you have to worry about, the momentum. I seem to recall that you would have a president come in to be your president, but then they'd leave the organization and they wouldn't be part of it anymore, which is odd. How can that happen? Because in most places, members become officers, but they don't leave. And so you're definitely having that challenge, is what I'm recognizing. It's the looking forward of the in the organization in terms of opportunities and threats. So then we develop the now what. And so this is the guts of the plan. And I'm going to ask Rob to scroll back to where it talks about, I'm looking for it here. It was called, right at the very beginning, our 5-year strategy. And this speaks to what the group said. Given all that conversation we had on day one, what are we going to do about it? What should we set out as our plan? This is the guts of what you said you would do. The first area is education and outreach. And these are the strategies that were identified. You'll see that none of these strategies are highlighted, and some of them are further down as we scroll down. But when we get the fact that if it's highlighted, it means the group identified that strategy is something that should be done in year one. Higher priority, we need to start moving on it. And you have a resource constraint, so you can't do it all in year one. So we were discussing what should we do in year one? What should be the things that have the most priority? So the strategies under education and outreach, it's not that they shouldn't be done. It's just that given all the good things to do, these ones are less important than the ones you're going to see as we roll down. So just promoting the role and expertise of the organization to other partners, investigating other offerings, educational offerings, updating the dissemination strategy. So the website clearly being a significant component of what is seen as education and outreach. I'm going to move along here to advocacy. Again, nothing in year one. But back in the spring, you talked about setting up your agenda to what you want to advocate about. The principles around what your efforts and how they should look, given the roles that you play within your own respective communities, and what's the process for establishing appropriate partners, because you know that this is not something that you would be advocating alone, but you would do it with others. I have another client who I've also done something similar with, but I did their strategy 3 years ago, and advocacy was a big part of what they said that they wanted to do. And I met with them this year to do their next strategy. And they are over the moon with respect to what happened in their advocacy efforts, because all of a sudden government is calling them much more often to be at the table. They're in the world of real estate, and so they're the appraisers in the world of real estate. And so they were never called or never part of all the questions government has in terms of developing new regulations, new policies around how regulations should get developed within the organization. And they're being pulled in regularly now. So they see themselves as much more influential. So an interesting strategy for you as well. And I think you will also yield very similar kinds of benefits of having more influence at the end of the day, which is what you're aiming for. The third area of priority is the area of research. And here you did identify a strategy you wanted to work on in year one. And that is to establish and promote the CanHaem role and network capacity to connect research sponsors with research investigators across the centers. So that's an acknowledgement that if you can further the research in this area, you will be moving the arch dramatically, and that this is something that would be that there is potential for, and that you would reap benefits from. So that's why that's shaded, because that was identified, and hopefully you've started to see some of that happen already in the meeting that you've had today. Exploring opportunities for collaborative research efforts across centers was seen as an opportunity, and then highlighting the accomplishments of hemoglobinopathy researchers and other contributors. So celebrating the successes is something that you see. Advancement of quality care, I'm going to come back to this one in a second as well, but just to say here, 3 things were identified as, but this is the raison d'etre at the end, is you're recognizing if we can find ways to take the quality of care to higher levels, then we'll really have accomplished our mission and vision. And I'm going to come back to those 2 things here shortly. And I have no idea, Rob, whether you're tracking with me or not. I'm rolling up here on my own personal copy and hoping you're managing to do the same. So establishing a national consensus of care for each hemoglobinopathy disorder through the use of expert subcommittees and stakeholder input. So that sounds very interesting, but it's bringing real focus to each disorder, and then each subcommittee being part of the advocacy effort, being part of the research effort. Build a sustainable patient registry and required processes for data entry, management, and extraction. So this is taking the blood disorders and taking them to another level of discipline and effort that would be similar to what other probably higher profile disorders may have, and support the peer review process to foster improved quality of care initiatives. So clearly there would be some benefit. I'm now going to organizational stability. And if you recall, when I started this, I made points to say that this organization, its strength is its collaboration and the motivation and dedication of the people within it. It's also its weakness, because it takes individuals to do that, and you need to sustain that over time. When people leave, are the next people going to be able, like, that's a lot of work and effort to maintain that succession over time so that you have a sustainable organization. So you recognize the need for a more formal governance structure in terms of reference for the board and for subcommittees. That gives it more sustainable sustainability as more people play roles on these committees. And these things are all connected in terms of coming up with good governance decisions for the organization. A structured approach to onboarding, mentoring, and succession of members. So it's putting a lot more effort into bringing people along so that you've got some kind of, that when one board leaves, that it's not starting all brand new again, that there's some ongoing development of people and some planning around that. And then finally, sorry, I hit the wrong part of my scroller here. And then prepare the annual funding strategy and plan to secure support for operations and initiatives. And I haven't stressed that one too much, but clearly that came out in the spring, that funding of the organization is still always going to be a challenge, and that your sponsors are key contributors to that, and you've got to figure out how to continue to do that, because the world of funding, particularly by pharma, is shifting and changing and probably will continue to. So you need to find ways to have secure funding from year to year, especially if you start to establish a more formal organization that has more sustainability over time. And then, Rod, maybe just roll back to where you have vision and mission at the beginning of the document. And just not going to spend a lot of time on that, but just to recognize that the group did articulate this. And so the vision is something that we say is time bound. It is between now and 2020, I should look here, 2027. This is not something you are today, but it's something you want to be seen as by 2027. The recognized network of Canadian experts in hemoglobinopathy. You aim to advance the quality of care provided to patients across the country through education, research, advocacy, in collaboration with key partners. So you'll see it's a combination of all those key result areas that we talked about. The mission, a little bit more enduring, because a mission is really, this is the business that you're in. This is what you do. I won't read that whole front part, but the organization is a not-for-profit organization dedicated to the care of individuals across Canada with hemoglobinopathies. CanHaem is dedicated to providing multidisciplinary expertise, encouraging collaboration, as well as promoting quality of care, education, and research. So that's what you do and how you contribute as an organization in making and furthering the good that you do. So there you go. That's the presentation of the strategic plan. I'd be happy to take any questions, but what I really hope at the end of the day is that this plan is just me reading what you guys own, that it is what you believe you need to do, what you're committed to delivering, the strategies that you think are the most important to be delivering. And for me, it's just a case of supporting you however I can by sharing it with you at this juncture.
Thanks very much. Since I'm up here, I guess I see a hand from Kevin, and Evan, you can come up since you're next up. So you've got a microphone, Kevin?
Yes, indeed. So these are good marching orders, and I would like to ask that the board provide us with a copy so we know where to go.
I was going to suggest the same. Yeah. Just repeat that for folks online who didn't hear. We're just talking about posting it onto the CanHaem website through the member-only login. Yeah.
Were there any other questions before we move on? Okay. All right. Well, thank you very much, Frank. And so then I was wondering if we could put up the slides for the treasure report. Bye. Thank you.
Enjoy the rest of your meeting.
Okay, so this is going to be very brief. And so this is the report for our expenses and overall balance sheet for 2021. So this here is just a quick snapshot of our revenue and expenses. So with respect to revenue, we only had about 13,000. Is this a pointer as well? Oh, okay, yeah, okay. So with respect to revenue, we had some unrestricted contributions through pharma, and then a small amount related to the conference. And then with respect to our expenses, the majority of our expenses went to administrative support and management, and about 4,300 went towards the conference, and then other operational costs. So at the end of the day, we spent about 12,500, so very similar to last year. And likely a smaller amount, given that we are still in the COVID pandemic and not having many in-person events. And so this is just the balance sheet. So I'll just draw your attention down here, where we have our fund balances. And so you remember we have this restricted amount that has been tagged for the peer review at about 65,000. So that's money that we cannot spend. And so really we have about $182,000 that remain. So with respect to this year and expected expenses, so you heard a bit about the strategic planning meeting. So there's some expenses that would have gone towards that, and also towards our usual management costs, and then the conference. But it sounds that Aisha did some amazing fundraising, so we're probably going to be net positive after the conference. We should be close.
Yeah, I think I can tell you what remains in the conference. You'll see it next year. It was $100,000 that we were able to fundraise. And the conference itself is...
Yeah, she should. Oh, yes, you should be on the mic.
Oh, yep. Sorry.
Thank you.
We were able this year to fundraise $100,000 in pharmaceutical support. And there's obviously some interest now in this area, as you can see by them coming out in force to join the conference today. So I think we do have to capitalize on that over the next year. the idea being that these are unrestricted funds for the most part, and there are lots of things I'm not allowed to spend the money on, but it goes back into the bank account, as frugal as we can be with the conference, which is not that frugal, unfortunately, but still we will be net positive at least this coming year, where we haven't been for the last 3 or 4 years because the pharma companies just were not giving any money. So ongoing, I think these are the years to ask, because it's obviously the years that things are coming closer in their pipeline and they're willing to give. So we can talk about that a bit later.
Right, yeah, so that's great to hear. And so as you'll see, as you go in detail with the strat plan, we do talk about, fundraising and sustainability and how we can continue to maintain our funds for our activities. And it will be important that we think of a budget as we think about those future activities and in planning for the future. So that's everything. I don't know if there are any questions. Okay, thank you for your time.
Thank you for organizing.
Okay, yeah. Oh, actually,
so we're going to bring on Yves Pasteur back on for the Governance and Nominating Committee.
Right, actually, so I'm sorry, there was one important point that I didn't mention. Sorry, that wasn't in the slides. So if you remember last year, we had discussed how there were some arrears that we were looking into related to CRA. And so we have to submit a voluntary disclosure that's almost finished. We had to submit our 2021 report or expenses first to the CRA. Our accountants are optimistic that there won't be significant penalties, but that of course is going to affect our bottom line, so that will be added to that as well. Okay, all right, thank you.
So yeah, so I'm just trying to show you some of the slides prepared for that. I hope you can see this. It appears that it is the case. So we'll first start with with the new member. You know that new member's application needs to be agreed on the AGM, and that's what we're doing now. So these are part of the new members that we received this year, and at least all of them that were checked diligently. And so unless you have any disagreement, I would suggest that we agree that all of those individuals become new full members this year. So maybe if you could do by a show of hands, if you all approve.
Sorry, Yves, there's a question from the floor.
Go ahead.
If we can put the list back up. So Nasro Moalen, Nasra, she goes by Nasra. She was just our temporary nurse in London and is leaving the role in a couple of weeks. So I don't know if that's something she would be interested in, but I think it's fine if we accept. It's just I don't think there's going to be an interest from that member to stay.
Okay. Well,
I think we should accept them, but keep in mind they may not stay.
Fair enough. I think we have to have a way of also, yeah, and having, because we have a lot of inactive members, and I think that there needs to be like a click button on the CanHaem website. I decided to have you not join or unsubscribe. Yeah.
So that's definitely, I think it's a good remark on several aspects. And first, I think that if we have healthcare professionals that would like to become members, I would really agree that as you mentioned that we should let them come with CanHaem, and if they change position, hopefully they will keep their interest. But as Aisha mentioned, there should also be a possibility for all of the members just to remember that if they no longer have any interest, that they could move out. So it's not something that we do have yet in place. So would you have any further
remarks?
Sorry, I just had one other question. I think it would be really helpful if maybe a list of members from each center was circulated, just so we could make sure all the people, like for example, on my site, I don't know who's a member and who isn't, and there's probably people who should be members who aren't on the list, or people who've left who shouldn't be on the list anymore.
Right.
I'm not sure it's just more about bandwidth and how much work it is for everybody, because honestly, this is Eve doing it on the side, right? And so it is, unless somebody else wants to take the membership list and then go through it and then scroll through it, if there's volunteers from the floor. But remember, you're asking the volunteer group. So
maybe one of the things we could do, and this is something that I have in mind. For example, at ASPO meeting, at ASPO meeting in the past, ASPO were circulators a list of active members, and those who would agree to have their informations, affiliations, email, and sometimes telephone, office phone, just to be shared with any other members. And this is something we could think on, because if we would have such a list available, it's another way just to enhance our capacity to exchange ideas and thoughts between all of us. We don't have such list available, so it might be something we might want to think about in the future. And I don't know how easy we can set that up, but just something just to maybe to consider, right?
Eve, I think I think this is it's a really good idea. I think the governance and nominating committee need probably more than 2 members. And then I would love to invite you to maybe the next board meeting, so that then we could kind of come up with some strategies to up how we revise membership lists, how we revise the consents for sharing information, because people have not given us their consent to share with other members, right? So we can't suddenly just email everybody and say, here, there's a membership list. So I think if you come to the next board meeting, maybe we can discuss that. We're running short on time.
Absolutely. I'd be happy to do this. All right. So just to continue, there are also 4 associate members. Just to remind you, according to the bylaws, to become a regular member, you have to be a healthcare professionals in Canada. If you're healthcare professionals not working in Canada, you can be considered for an associate members. Same thing for representative from the pharma and non-allied healthcare workers. So those persons falls into this category. Any opposed?
No, and I guess for new members, everybody from the floor, because Eve, you probably can't see us all. Everybody in favor of voting in the new members? Everybody's in favor. And for the associate members? Okay.
So maybe just 2 minutes, one thing I'd like to suggest that we also revise the process for new members. This is our current contact information, and all that we do receive is first name, last name, sometimes an affiliation, and an email. That is sometimes an email from that is a health professional email, but it's not that where to get a Yahoo account or similar things. So it's sometimes quite difficult just to know exactly who this person is and how to accept them as an official member. And this is something I'd like to suggest to you, that we revise our membership application just to make it a little bit more professional, just to know their professional qualifications, where they are currently working, what is their role, how did they hear about CanHaem, if they have been recommended by CanHaem members, and just to with a small paragraph about what is our subcommittees, because I think new members have to know that there are committees, and there are active committees, and if they would have any interest, we should know about this. And with a simple role of what defines an active member or an associate member, people has to choose if they want to become an active and associate members. And that's, and if they want to make a couple of remarks, just to get an open box. So this is something I'd like to suggest. I don't know, Aisha, if you want to, have that agreed on, if you want to have further discussion on the board. But, this is something I would suggest that we'll try to do.
Hi, Eve, this is Heather. I just had a thought that maybe moving forward on this application form should be where we get consent for sharing information across the membership.
That would be great, and we can certainly add this to the list. And for current active members, we can certainly send them an email just to ensure that they agree to have their information shared with all the other members. Shouldn't be too hard to do. Great suggestion, Heather. Thank you.
Eve, it's Mike. I wonder if on the box where you say, tell us more about yourself, we could maybe say, add to that, and why do you want to be a member of CanHaem? Because I think, in a way, that's really what we want to know. And most of the time, we know why people would want to be a member of CanHaem if we know who the person is. But for some of the people who we're perhaps less familiar with, I think it's a helpful statement. It's not that we're going to judge it, I think, but just it's helpful to know.
Well, yeah, and I agree with you. Just finding better ways to know who that person is and what their interests are, and hopefully to get them involved more actively right from the beginning.
Yeah, so Eve, if I might add, I think this form, we're seeing lots of, interest in this moving toward, this is Madeline, by the way, to increasing the amount of information. I think, again, kind of back to, in the interest of time, I think I'm taking notes, and what we can do is use this as an amazing first draft, and then get the input of the other board members to add in what's being suggested here. I see Kevin's got the microphone too, so I don't want to squelch the conversation prematurely. So here's Kevin.
Let's put that on the agenda on one of your next board meeting, and I'll be happy just to discuss all of this with you.
I'm just going to, of course, as Madeline succinctly wrap that up, I just wanted to say we may even want to do a call out for all members, please. Do you want to continue being membership, like having your membership continue to be active? Maybe we should do an e-bomb, just because I think we have 100 and something odd members, but I think we have probably 60 to 80 active members. No.
All right. So should we move on to the board of directors?
Go ahead, Eve.
Okay, all right. So this is the current list of board of directors. I put in red the two persons that I know of that would like to step down. First is really an occasion to really thank both Kathy and Gloria for their participation in the board. And I know that, Aisha, you could tell a lot more, but I really want to thank both of them for their work and dedication to CanHaem. I think it's crucial that, as for all members, but particularly for the board of directors, it represents really time and dedication. And I think that we really have to thank all of you that put a lot of efforts and time in this. So in replacement of Kathy and Gloria, there are two persons who would like to propose. One is Virginie Lamy. Virginie is a nurse and a practitioner in Quebec that started to work with us at Saint Justine this year, and she's really interested to join the board of directors. Suggested her because we need more nurse in the board of directors, and I hope that you would agree to have her on. Unless you have any other suggestion, it's clear that any proposal from the floor are always welcome. We also would like to propose Sarah Tersine from Saskatchewan to join the board. And it's clear that if you have any other proposal from the floor, please be welcome. I'd like just to also mention that we're missing people from BC and also not SK, but from Nova Scotia. from Terre-Neuve, right? So, you know, if people from those areas would be interested, would be really fantastic. So, any suggestions?
Yeah, hi, Eve. I don't know what the criteria of because you were replacing two nurses, I guess. Did you want to have two nurses? Is there? I can't remember what the limitations or expectations were around that.
We'd love to get, you know, and first, you know, if we go back on the board, you know, the thing that is important, just we don't want to get more than 3 representatives from provinces. So if Virginia will come up, it will be 3 from Quebec. We cannot have any other representative from Quebec. Every concern would like to get at least 2 nurses.
Because Eve, I do know from BC, Dr. Ali Hamid was very interested. So.
I think, and I think historically, if people aren't at the board meeting, we really should have a long conversation with before they step up.
No, I'm not saying for the. I'm not saying for. I'm talking about for next year.
And I did approach him earlier in the year. So not necessarily. We do need nurse members. We need them not to be from Ontario and not to be from Alberta at this moment in time. Chantal, you're willing to step up? I know, and Gloria those are big shoes. Those were big shoes. So we would, yes. So Chantal DeYoung from Halifax, pediatrics, works at IWK with Vicki Price, is her nurse there, or works with her as her nurse there, and is proposed from the floor.
Okay, so we'll add Chantal.
Okay, so now we have to vote, right? And we have 2 spots and 3 positions.
The one thing I will say is, I know Chantal's very tired. She may regret
Okay. Sarah is withdrawing her application. Plus, honestly, very selfishly, I really want Sarah to run with the registry subcommittee right now and put all her eggs in that basket. Thank you. Yep, Dawn Houston is at Winnipeg, and Kathy Bourne was, and she just stepped down from Winnipeg. And we definitely want, it's more a matter of how many positions versus how many board members we have.
There will be spots
coming up.
Next
Yeah,
year's
yeah,
board meeting.
yeah. There's definitely more positions coming, but we really, really need nursing representation. I think that's always been, whether it's not in our bylaws or not, it's always been a mandate of our board and our membership. And like, again, selfishly, I really want Sarah and Ziad to run with the registry subcommittee. So I think we just need to vote on those 2 members. Everybody, oh, sorry, go ahead, Eve.
No, go ahead.
Is everybody comfortable doing a show of hands, or do you want to do it by ballot? No, we always vote, don't we, Rob? Yeah.
We need to vote.
Yeah, we need to vote. Do you guys, everybody comfortable doing a show of hands, or, okay. Huh? No, based on, okay, so the board bylaws are essentially only 3 members per province. Ideally, definitely not from the same center. So right now, Ontario's full, Alberta's full, Quebec would be full. Virginie is voted on, and Halifax would have 2 representing the eastern provinces. So really, it's really based on location. The bylaws weren't so strict to say we have to have representation for every province. I believe, please correct me if I'm wrong. It's by region, right? And so we would have representation from the regions. And there is a lot of turnover coming up, and that's something I want everybody to be aware of. There are positions. I think there are a lot of board members have been on the board for a while, and I think are looking to hand over their positions at some point in time. So we would love more, but like I said, we really want to hear our allied health professionals and their voices. I think it's been a very important part. But so really, that's it, Ziad, for the bylaws and the reasons. So I don't really think there's much else to say there. So if everybody's happy, and if you're not happy, just kind of say, and we can pull out ballots and do the ballot things. Anybody have any issues? Okay, everybody happy voting? All right, all right. All right, so from the floor, everybody in favor? I don't know from the online membership. We're just going to check the online membership.
You've said it verbally, so if everybody's listening, they should have heard you. I've just typed it in.
Okay, perfect. Eve, do you have another agenda item?
And I think that, you know, that will be all for me.
Okay.
The composition of the executive is usually decided by the board. I think one thing that is important just to mention is that in order to ensure that there will be a good continuity in the executive, I think it's important just to mention that Aisha, that you have agreed to continue as a chair until 2024, and I think I personally really, I'm delighted to hear about this because I think you've been doing an absolutely outstanding job in continuing the tradition of CanHaem.
Thank you, Eve. I am. Thank you.
And I know that your colleague Catherine has also agreed just to step up and become a vice chair. And I don't know if you want to comment on the other composition of the exec.
I would love to.
We're going to discuss this on the board of director shortly, but I think for all the members might be a good thing just to hear from this.
Yeah, of course. To recap, so our executive is I'm obviously the chair, and then we have Catherine Coverbrook, who works in Edmonton in pediatrics with me and does thalassemia care. She is currently on mat leave, but she's currently our vice chair, and welcomed a new member into the world just the other day. So she is taking a leave right now. And then we have Madeline, who is our secretary, and Evie, who's our treasurer. And that is our composition right now of the executive, and then the board members support us in our activities. The executive, we have been having a lot on our plate, but I think we're getting things active again over this the next couple of years is our plan.
All right, thank you, fantastic. So yeah, I'll let you move on with the AGM, and I think that now you were going to have the reports from the various subcommittees.
Thank you very much, Eve. Yes. So we'll bring up first Heather McCartney to provide an update from the nursing subcommittee. Or maybe she's going to do it from her chair.
I'd love to do an armchair report if that's okay. The nursing let me start again. The nursing committee has continued to support each of its members across the country. We did manage to have 2 virtual meetings. I strived for 3, but couldn't get the 3rd one going. So we had one last October that was actually a presentation on iron chelation from Dr. Fernando Trichta. And then in April, we had a meeting, just us members, and talking about successes and challenges across the country that we've had in our clinics in the past year. And we had our annual in-person meeting yesterday and had 10 nurses and 1 social worker attend. We had a great talk from Catherine, the social worker, on managing challenging relationships. And we're lucky enough that 5 of the members that attended were funded by CanHaem. So thank you very much to the board for agreeing to support our nurses in coming to the in-person meeting. I think it's very important. We've been actively asking questions, sharing resources through our email group. Unlike the regular membership, basically, if you're on the nursing list, your information is getting shared. If you don't want it, you just let me know. But everyone gets all the emails if they agree to it. And we've increased. We've got 46 nurses that are on the list across the country. And they're all pretty good at responding, and it's been a good group this year. We have a lot of new nurses, a lot retired over the last couple of years, but we have some new faces, and I look forward to what's going to happen in the year ahead. Yes.
Any chance of you getting a co-chair?
So I did yesterday say that I would like either someone to take over or some help. And there has been some interest, so I'm going to put out a formal call, I think, for either a full chair to take over, or I don't know if I don't know if I could get an opinion, because I have been in this role since CanHaem started, and I first had Colleen Johnson, and then I had Gloria Gallant, and so this is my first year on my own. I wonder if I should do a year of onboarding and then hand over the reins, and I'm getting some nods. So I think that's what I'm going to call for, a co-chair, and then the following year I'll step down and have any other interested parties can come up and join the current co-chair. So that's my plan there. All right. Thank you.
Can I just, getting back to one of the issues that came up earlier, if you know the nurses who've retired and left, and the ones who are onboarding, maybe that could be passed on to the governance and nominating so we could clean up the list?
Yeah, no problem. Actually, I wanted to confirm with, because I didn't actually know Nazra was leaving, and I literally just signed them up. So I feel like there is a bit of discrepancy between the list I have and the membership, and I'm not sure who is members and who actually followed through on my, because whenever I get a name, often physicians will email me a name or a contact and say, hey, this is our new nurse, can you add them to the nursing group? And my response to that nurse is always, you need to sign up for CanHaem, basically to be part of our group. But I have a feeling that there are some nurses that we might have on the list that are not CanHaem members, which I think if it's a CanHaem nursing committee, they should be CanHaem members. So I'd like to kind of cross-check. And I do have some nurses that have retired or moved, Angela from Alberta, Rizuki, and Colleen Johnson, Gloria Gallant, Christine Chrétien, yeah. So a few that were with us for many, many years and have now gone. So yeah, glad to.
I really think that if we do like an email bomb, just saying everybody email us back, or you have to go on and re-register or whatever. Yeah. Then people either will or they'll be dropped off the membership.
Yeah, oh God, all of a sudden it's working. I did say that I did one recently with the nurses, and I basically said you have like 15 days, and if I don't hear back from you, you're off the list. Because there are many, I had like 60 nurses on the list, and some of them I didn't even have phone numbers. I had like a personal email. It wasn't, if you're not actually interacting with me that you want to be part of this group, then you can find me later. Great, okay. Thank you so much for that update. And next we have the Education Subcommittee, and we have Dr. Surabi Rawal, who I believe is joining us by Zoom. Hello.
How are you doing? Sorry I couldn't be there. So a quick update on the Education Committee. So as you guys know, our purpose is to to work on education materials, as well as working on continuing medical education for hemoglobinopathy providers. Our current membership, and I say this because we're always looking for new members, but our current membership has both adult and pediatric practitioners, with only representation right now from physicians and nursing. So if there are any trainees who are interested, if there are any allied health members who are interested, either practicing in adults or pediatrics, we'd love to have you. An update on our active projects so far. So we have uploaded already to the CanHaem website some patient education materials. So there's pamphlets on use of hydroxyurea in general, as well as specifically use. We're working on the one for thal. There's one on sickle cell and pregnancy, and we're working on one on fertility and sickle cell. A big project, which Ziad is also the co-editor of with myself, is the consensus statement, which we, so maybe it wasn't the best time for me to take it on. I just came back from maternity leave, but we've collected all the, I think most of the chapters. I've looked through a few, Ziad as well has looked through a few. So far what we've received is actually very, very well done. So I'm hoping that if this is representative of what we are going to receive, there's not going to be too much editing to be done. So our time frame for completing that looks, I think, hopefully still good for early 2023, spring of 2023. And for our webinar series, so again, because of the mat leave, we've been a bit, we haven't had as many this year as we usually aim for. We usually aim for 4 to 6 a year. So there won't be that many this year, but hopefully there'll be one more before the end of the calendar year. So I've reached out to a few people, and as soon as somebody confirms, I will send an email out to the membership. On the topic of webinars, so they have been, I think, a good variety of representation of Canadian practitioners, as well as topic experts that are international. We've gotten speakers from the United States, as well as we had a thalassemia expert from Greece not that long ago. But we'll be sending out a survey to get a sense of what kind of topics the membership would like to hear about, as well as if you have speakers in mind for those topics, that'd be great. And then I think the last thing on the topic of webinars is that we had talked in the past about submitting the application to get these accredited through the Royal College for CME credits, and I very much would like to do that. You do have to have a minimum number per year in order for them to be accredited. So this year it won't be able to on the basis of this year. But I think if we plan to have 4 to 6 next year, and I think that should be our aim, we'll be submitting the paperwork for that. There is a small fee that comes with that, so I can submit a request for that to the board when I find out what exactly that number is going to be. Just to mention some upcoming projects. So we had talked as a subcommittee about trying to make sure that there's more sort of I guess access. I think lots of practitioners, I mean, certainly I can only speak for my center, but I'm always referring trainees to the consensus statements both for thalassemia and sickle cell. But we wanted to sort of spend a bit more time working on projects that are sort of trainee focused. So we're working on a OSCE case for there's like a pediatric pool of practice OSCE cases that all centers go through nationally. So we've tried to contribute a sickle cell based case for that pool of practice OSCEs. There's a CPS practice guideline which links right now to the current consensus statement, and we'll update that link, or we'll ask them to update that link when the new consensus statement is out. And we're always looking for other strategies to provide more education to our trainees as well. And that's the update.
Okay, thanks very much, Sarabi. Aisha's whispered in my ear that she has something she wants to add, and then after that, just put up your hands if there's any other questions.
I honestly, this is more about just other things that I wanted to mention so I don't forget, just it's been a long day. One is next year's AGM will be, I hope, very important. There's been a lot of talk about redoing the bylaws. If we redo the bylaws, we should bring all the issues to the table because it's an expensive and long process. So we should, all membership issues, board issues, how the executive roles, the subcommittees, whatever it might be in the bylaws that you wish to redo or think that would be a good idea for us to look at. Plus, we need a quorum at the AGM. So either virtually and or in person, it would be, well, not and or in person, please consider joining. And it will be really important to updo our membership before that so we have a proper quorum. The other thing is, before I forget, so that somebody else is hosting the conference next year, and I'm looking at Dawn, hopefully. No pressure, Dawn. I would like to leave the AGM with at least a host for next year's conference, and I would like to go anywhere in the country as the last 2 years host.
Okay. So that will give everybody a few minutes to think about whether they're up for, everybody / Dawn, a few minutes to think about whether they're up for hosting. Awesome. Okay. It's decided. Woo! Okay, excellent. Did anybody have any responses to what Aisha just said, or back to Sarabi? Yeah. Okay. Kevin's got his hand up. Microphone on its way.
Is for Sarabi. Hi, Sarabi. That's wonderful initiative regarding the OSCEs. To avoid duplication, I know that like McMaster has done a number of case. You guys have like a case.
The online learning
online learning module.
Yep.
I think different people have developed different things over the years, and it would be nice to gather all the resources from all the members, and you can collate them and optimize them.
Yeah, no, that's a very good point. And actually, I think that was on my list of things to mention and I forgot to completely. But I think Catherine, before Catherine went on mat leave, I think Catherine had spoken with you, Madeline, about incorporating those, I think you had, I forget the name of your trainee with whom you had come up with those modules, but I think that had been definitely one of our agenda topics earlier. So I'll email you separately after the meeting.
Okay, excellent. Thank you.
Thanks for that.
Thank you. Okay, excellent. Excellent work. And next up, we have the registry subcommittee. So if you wanted to report from your seat or from the podium, you get to choose. All the microphones. Make sure you're turned on.
So we are starting out. We have some excellent consultants who will be guiding us through this process a little bit. I think our next couple of big steps will be looking for a platform, potentially a funding source, and some project manager kind of a person. So we will be working on that and kind of go from there.
Yeah, I think the main things that we identified today is that there's no way we'll have clinic staff helping at all, which is an idea we needed to squash from the very beginning. I'm glad we did, and so that means we need to hire people with research experience that will either be hired per center or travel somehow. I'm not sure what the models will be, but if anyone here has ideas for funding, should we completely rely on pharma, or do we we're going to learn from Durhan and others, how other registries were funded. She even had ideas on, free software that's available for these things, and then even basic things like I think we're thinking of like changing the name of the subcommittee from registry to, patient management. I think that's much better, less scary. It's less scary for people to hear, patient management monitoring information system. And that will help get the patients on board, and maybe, you know, approach the patient organizations if they're still interested. So I think we've got a place to start from, and, you know, me managing the, you know, the consensus statement with Surabi and taking this on will be a challenge, but I think we'll have to manage our time and split the responsibilities. We'll be okay.
One, I think we have to approach pharma soon. I think, like I said, it comes in waves, and at least we're riding the wave right now. In a year, we might not be. We might be, and then we won't get any. And not that it should be our only source, but I think people have looked very hard into trying to get CBS and government to pay for this. It has gone zero, and I mean, Evie can speak to that, because she was trying very hard to get grant funding and everything else to do it, and it didn't fly, right? So I think if we really want to get the groundwork done, we need to start at least getting some fund earmarked and into a fund like peer review. It sits in our bank account. Nobody's allowed to touch it unless it's for peer review, right? So if it just sits there and you haven't got enough yet to roll, that's okay. At least we have some earmarked, right? The final thing I would say about that is your platform is really important, because you need a budget to write the grants, right? Like, you can't do it without, and there may be a way, you can talk to Molly and the crew from the hemophilia areas, maybe their CRAs can help enter data at site if we pay their CRAs at the sites, because they're in all the blood centers. Like, because we can't pay for a CRA to go to different sites, plus it's ethics and all those sites and all that sort of stuff, so.
I just met Durhan when I was trying to get coffee, and she was also talking about setting us up and meeting with a couple of patient-centered data entry platforms who will be very interested in trying to, like, help us with this kind of activity. So we're going to meet them, and I had some really helpful insight from Molly as well. So I think we are going to put all of that together and email people a lot, including Evie, and figure it out. Yeah. And I think the other thing that you said about CRAs is absolutely correct. We will have to have them seated somewhere, right? Like, maybe, and if we are making them like the stewards of the data in the sense of data cleaning and data management and all of that, they will probably have to be a few. And I don't really know what that few is. It's 3, it's 5. I really don't know, but that's something we have to consider.
So most of the pharma companies have grant portals to apply for unrestricted grants. Obviously, the grants will state that this is for a registry. So would the group advise to go the unrestricted grant route, or okay? And, you know, budget-wise, we need to also have an idea.
If you start slowly bankrolling it, we start getting the groundwork going, right? Because it's a huge investment over time. And so I think if we started approaching Chessie this year, and we were at an unrestricted grant for Chessie this year, it goes into the bank account, sits there until you guys are ready to move with it. Or you take it and do focus groups, whatever you guys need to do, right? But I think we have to start writing them soon. But of course, the budget comes first, which means your variables come first. Right?
That's where platform comes from.
Yeah.
So we have to decide on a platform, and we have to decide on how many people we need to just have it start.
Yeah.
Have it started. That's it. Like, at least, and then we can give that proposal to the pharma company.
Yeah, can I just say from the hemophilia perspective, the government only stepped in to pay for it once it was shown to be running and doing really good. So I think it's a good idea to use the farmer to get things up, and then show that you put the legwork and the effort in, and we're gonna, because I think that's my impression was the provinces and territories were only going to willing to kind of pony up once they saw, okay, this thing's actually working. And I mean, obviously it's a different situation with hemophilia because their drugs are so much more expensive. So I think that's another piece of the puzzle. You have to somehow, I think the good news is that there's more expensive drugs coming in for sickle cell and thalassemia, so then there's a better incentive for the provinces and territories to pay for it.
So, and I think, there's a lot of great ideas we're hearing here. So we would like to invite people to join the subcommittee if they have feedback they'd like to add and offer. I know we're co-chairs, but we're flying solo right now, so it'd be great to have input from others, and we won't throw too many tasks on you, but mainly idea gathering.
And I'll just add my 2 cents. I think you already know of who some of your key contacts are within CanHaem. You're hearing some other people who maybe might not have the time to be on the subcommittee, but who could be really useful ad hoc advisors, et cetera. So, I think that would be the other thing. And then they'll know who's been working on other aspects of this. So some of it might be like asynchronous rather than, hey, everybody, let's have a committee meeting. That's what I'm thinking.
And I just want to give a nod out to Kevin too, because Kevin.
Good segue. No, Kevin, you can come up because you're next.
Not only that, but he also knows all. The companies, my friend, and you have a rep with the companies. And that helped me generate a lot of money for this conference. Like without those kind of connections and introductions, the grants don't go very far, right? If I'm just emailing out to some global grant company, they're like, we're done, right? But yeah. Kevin lets me know, and then they tag that grant that I put in for the conference, and then they flag it because Kevin was nice enough to introduce me to his rep and say, this is a really important organization. You need to know these guys. So when the time comes.
We're not reps. I think we're actually medical. Yeah.
Okay, whoever I was emailing or made like lots of teleconferences with lots of different drug people.
Yeah, no, definitely. I think.
They were the one who controls it first place. You don't go to reps. That's problem number 1. Never ever go to reps.
Okay,
Yeah.
So Kevin,
Definitely.
go to Kevin.
I'll go to Kevin, and I think we all noticed that the panel. The response from the pharma rep on the panel was underwhelming in terms of what do you want from a registry. There was really a non-response. So we need actual companies that are invested in in these patients that know what they're talking about.
Well, I have to say that said, Chessie was like a platinum sponsor. Yeah. So they were really invested in our patient population because they paid for half this conference or more, right? So really, truly, in some ways, they are very invested. Whether or not they are allowed by their company to give us a very forward-looking answer, because there's a lot of restrictions in their organizations where they have to give these diffuse answers. They're not allowed to say what the need are. So there's other companies sitting in the room, right?
So Chiesi is great, but when they bought the Fairprone, they pulled a whole bunch of funding from our site for a huge educational project we have. So, my faith in them was like gone. But this is different, so I'm hoping we'll start fresh with a new proposal.
It's more though like it's riding the wave, right? They're private corporations who invest in what they want to invest in to make money. Period, right? Their bottom line is dollars, and you have to go with it that sense. And if you've ever worked in private industry, that's just the way it goes. And they're partners. But I hear you. Unless you get the check, don't believe the promise, right? Like until the check comes into Rob, I don't believe that they're giving me the money. And some of them sent us the wrong check, and then we had to say, hey, by the way, wrong check. You're 10,000 shy.
Does it tend to be like a one-time lump sum payment where we are accounting for year 1, year 2, year 3, or does it tend to be an ongoing thing? Because with ministry funding, obviously it's an ongoing thing. So, and I have some experience of that, but I definitely have not had experience.
I can help you when you go through the application process.
Okay.
Each company is different. Most of them are a one-time funding, but you can lay it out in a year's over, a 5-year funding process, right? But they're only going to fund you once, usually, because they budget every year ahead of time. So.
So I've mentioned a couple of times, Kevin, you can come on up. So Kevin's going to give us a 5-minute high-level summary of the inherent study. Yeah. Oh, sorry. Okay, and after Kevin is going to be Aisha coming to wrap it up.
So thank you. So as your subcommittee research subcommittee chair, I'm pretty much a loner. Anyone who wants to be a co-chair, first of all, please. Okay, all right. Anyways, to answer your woes about the registry and funding and all those things, I have a great opportunity that I want to present to all of you that I think we should be part of. Okay, so let me tell you what it is. First of all, Inherent is an international initiative to study the role of genetic modifiers in hemoglobinopathies. I don't want to go through introduction because we all know what the problem is, right? We know that patients with hemoglobinopathies present with diverse phenotypes, even though they have very similar to or exact genotypes. We have done GWAS studies in the past, but the GWAS study only explain a proportion of the variations that we see. And if we look at that, we know that 70% are genetic, 30% are environmental. Within that genetic, maybe only half of it is explained by some of the markers. And even those markers are not replicable. And part of the problem is that the outcome definitions are all over the place. I mean, let's just throw it out to the audience, right? How do you define pain crises? Well, you can come with 10 different ways of defining a pain crisis right off the bat, for example. So, of course, this is a problem for us because, A, even though we have discovered some drug targets, the drug targets are not that good. We know that, right? Look at luspatercept, for example. It only works in 21% of the patients, right, who gets a 1/3 or greater reduction in transfusion requirements. So that means there must be other targets out there that are not discovered. And B, we can't predict who's going to get better or who's going to get worse over time, right? We need to know that if we want to somehow optimize our patients' treatment. We need to know who should actually get transfusions, right? What we should do. So to do that, there is now an international initiative called Inherent, and the objectives is to discover new genetic modifiers, to validate previously studied ones, to pull and analyze existing genomic data, as well as to standardize the phenotypic description of the outcomes in the covariates. And the planned enrollment is 30,000 patients, more than 30,000. This is going to be the largest GWAS ever conducted, okay, especially for rare diseases, right? You can see that, you know, we can detect, even with a sample size of 10,000, we can detect as low of an MAF of 5%, odds ratio of 1.5, a case control ratio of 0.3, and a p-value of, 5 times 10 to the power -8. Similarly, for the survival endpoints, we only need around 5,000 to 10,000, but we're gonna completely overpower with 30,000. How are we gonna do that? Well, the entire world is gonna participate. You can see any of these colors ones, at least places that have hemoglobinopathies. You're gonna ask yourself, how does Sub-Saharan Africa participate? Well, they have a lot of initiatives already that we don't, actually. They have REDEEP, they have SEDAC, they have like RISO, like they have even the French-speaking countries, they have 2 of them. They're all these consortiums that we don't have, they're well-funded. So, comes to then, how is this going to be organized? It's now organized into 5 working groups. There's a clinical working group, there's a genotyping working group, data management analysis, ethics, and knowledge translation. Each of these groups are responsible in their domain in terms of creating the protocol. So the clinical group will be there to define the outcomes and the covariates. The genotyping will be determining what sort of panels and what sort of genes we should include in this GWAS, SNPs we should include in this GWAS. Data management analysis is creating the CRF, creating the infrastructure for this. Ethics, knowledge translation, etc. Ethics is, to help with, local or national or supranational research ethics questions. For example, in EU, they actually have the EU they have a governing board that governs ethics within the entire EU. So, so if you pass one, then it's going to be applicable to all the member countries. For example, it's steered by the Cyprus Institute of Neurology and Genetics, and they're also tasked with communication, review of manuscripts, etc. So where does it come into play? I think that this is an opportunity for us not just to be part of one of the largest GWAS in the world, but also to evaluate and build a research capacity as a consortium, as a Canadian consortium. It will allow us to collect accurate figures on hemoglobinopathy patients in Canada with genotypic and phenotypic distributions, We can obtain grants as a consortium. We can apply for CIHL project grants. We can, as a consortium, we can apply to the SPORE grants, right? That's a SPORE network grants, for example. And of course, we can create spin-off projects from this because ultimately we will be the ones owning the data, okay? Whatever data we generate, we will be the primary owners of them. What's the strength here? As I see here, this is the strength. We have CanHaem already. We have, Guillaume Letry is already committed, actually, to be part of the genotyping center for the entire inherent project, one of the 7 genotyping centers. So we already have a homegrown genotyping centers ready to go. And we know that Guillaume has a proven track record in doing this, right? I mean, the guy discovered half of the SNPs that are responsible for sickle cell and thalassemia variations. So, and we know that already some centers in here already have the capacity to do observational studies. It's just a matter of finding the money. So I think what our action items, and I propose this to the entire group here, is I think we should start recruiting centers and investigators into the study within Canada, right? We should identify the level of commitment of each individual. All levels of commitment, welcome, starting from just contributing patients or not even, or just to serve as part of the committee to, say, create the grant, to write the grant, or to review the grant, to things actually, taking leadership within the working group for these grants and projects. Or if you have a spin-off project, please, that would be welcome as well. I think the first meeting, we need to start when we have representation from at least 4 provinces, okay? We need to establish objectives and action items, identify grants to fund the Canadian proportion of the studies, and also generate new ideas based on this big GWAS. Because if we can be part of this consortium, then we have leverage with Inherent to actually use their data for research purposes to generate our own questions. And with that, I draw to a close. Thank you.
Kevin, so this consortium, so it's based in Cyprus as sort of the lead site, is that how it works?
No, they're not the lead site, they're just a coordinating center. Yeah.
Well, coordinating center.
It's for like grants and tax purposes. You know how Cyprus is a tax haven.
Okay.
It's true.
So I was just trying to figure out how this thing was born and what the idea was, how it was going to be funded.
Yeah, so the funding is going to be a mix of industry and governmental. So it's been supported by EuroBloodNet. So part of this, so we've had a number of meetings already, and the meetings have been supported by EuroBloodNet. But essentially each of these, because it's a super consortium, right? And within there's already 9 consortium. There's like the Human Variant Project, et cetera. They all be contributing either in kind with data, or they actually have funding or have the ability to collect the data. We are also looking at, or Inherent is also looking at industry funding as well. So it's going to be a mix of different fundings. Yeah, so I think it's important that we are able to get our own funding, because if we don't get our own funding, A, we can't expect other people to get the Canadian portion of the study done, and B, we're not going to have ownership of the data. And we're not going to have leverage within the big group that we can start generating research questions on our own and be able to use that data.
Quick question. How do people feel about having 4 centers and being a CanHaem project? Like because we're talking about 4 centers jumping in and joining, at least 4 centers. He would love more. I think it would be open to all. But how does, like, if you are part of CanHaem, you're a CanHaem center, and you're not a center for whatever reason, how does the membership feel about that sort of idea? Is that should we proceed like that? Is that good with everybody? Good. Okay.
That's good. Not for this. I just said to Kevin, to Kevin, not for this project necessarily, because he wants 4 or more, but I would say, like, if there's 3 or more centers involved in a project, saying that it's a CanHaem.
3 or more from across the country, though? Because if it's isolated to a province, then it looks a little...
Yep.
like
Did I say 4 or more province or 4 or more
You said
centers?
4 or more
three or more,
provinces.
3 or more centers, I think you said.
You said 4 or more provinces.
Provinces. I
Oh,
said
did
4
you?
or more
Oh, sorry.
provinces. Provinces.
Okay, I think that, okay. And what do you need from us? What do you need from us?
Any form of participation. Let's say if you just say, I want to contribute, patients, and I have this number of patients I think I can recruit. Even that alone is sufficient to be part of this. And then I need people who are willing to, say, build the grant with me, right, to write the grant, to apply for grants at CIHR. Obviously, those who will contribute to most of the work will be, principal investigators and then co-investigators, collaborators, et cetera, depending on, what your level of contribution is. I would love to have people who can come up with new ideas in terms of, because you see, we can't just pitch inherent to, say, CIHR, right? We need a hypothesis-driven study within the Canadian context. We need to create that. So what is that Canadian context that we want to do? And how do we capitalize on, the current EDIs and racial disparities?
And so, Kevin, are you thinking, RCT level studies that will be?
No, this is observational, right?
Yeah, right. So you're thinking more feasible ones that are like observational
no,
studies.
This is it. Like this is the observation. Now we're going to piggyback on this study and then present it into. So here's my idea. My idea is to take inherent, right, which is a genotype-phenotype relationship study, but have a Canadian pitch to it.
Yeah, I do think that's great, because one of the problems is if you ask people if they want to contribute, it's great, we'll support it, wonderful, but then if there's no money, and I don't have a nurse or I don't have a, people can say whatever they want, but it's because the reality is it's very hard to do a study if you don't have funds.
The first thing we're going to do that I propose is that we start applying for grants, right? And it's not, I don't mean just me applying for grants, I mean us as a group with contribution for everybody, right? In terms of writing this grant. Because then we can get hard dollars, right? I want, and then for those participating centers who are willing to contribute patients, I want like a figure. How much do you think you need to fund a coordinator, right? To collect X amount of data. I need to know, in addition to that, what are the fundings you need to get this done? Guillaume already has the genotyping pricing already, so that's out of the way.
I have to say for multi-center studies, I'm a carrot stick person. What's the carrot for the investigators who might sign up from their center as a collaborator, author? Is it a recognition from the center? Stick is you don't do your job, which you said you were going to do. We drop you from the study as a writer, whatever, or like an author, whatever it might be. But I think if people kind of knew what they were signing up for, people would probably be happy to email you with my center's there. We'll do it. But if they don't think that there's any, they're doing this because it's a lot of work to be, say I enter my center, say I want to write the grant with you. If that's for the good of CanHaem, wonderful, but that's a lot of work to do without, say, the offer.
Well, think about it, right? So for that point, I think, the carrot, I think, A, well, obviously is getting manuscripts, right? That's the sort of the basic thing. And then B is whatever spin-off projects you want to do, you can piggyback off it, so you can create a lot of spin-off projects, right, if you have ideas. Third of all is whatever grant money you're going to put in for the CIHR, right, or whatever we're going to apply for, right, I'm expecting you to slightly over budget so that you can have extra money to use for other projects as well. Because then you have a coordinator that you can use. I mean, ideally we want you, I want all of you guys to be able to at least fund, 1.5 at least, FTE coordinator to be collecting the data, but in addition can help you with other projects as well.
So Kevin, if I might suggest just to follow from like a practical next step, I know you had already, probably about a year ago, emailed out all the physician leads from the clinics. I wonder if, or something,
no,
maybe
I don't
not
think
all
so,
the physician leads.
Just some,
There was an email that went around.
To the board.
I'm thinking something.
It was an email just if we're interested in pharma contacting us, I think, right?
No.
That's a different.
That's a different one. That's a different
Okay,
one.
yeah.
That's
I
a
don't remember an
Kevin
email either.
emails about research from time to time.
Yeah.
What I'm going to suggest is if you put together a very structured email along the lines of what Aisha has
But I
suggested.
did already.
I would say right now, while the topic is hot, if you did it, we could circulate it again to CanHaem.
Okay.
Because you could send the same email. And
Okay.
say, what is your level of wish to be participant?
Yep.
Or potential interest? And then people email you back.
I'll send it to you. You distribute to all the members, and then info and CanHaem. Yeah. Okay. Got it.
And I think, Kevin, if you want to have some kind of separate meeting to discuss hypotheses, like, and study ideas, because I think right now it's a bit raw. So I think we all need more concrete kind of, what kind of study would your site be interested in?
No, I'm looking for you to propose to me.
No, but that's what I mean.
Yeah.
I mean, we need to sit down and talk about.
You need to.
But we need to sit down and have a conversation about feasible studies and non-feasible studies.
Well,
a lot of
this is
ideas
why
are.
at the end, I say, that's exactly right. Completely agree with you. Yep. Yeah, we need a meeting, but we need the quorum first to get that meeting. Chicken and an egg. Okay.
You got to start somewhere.
We can definitely redistribute the email, and people can send it if they're interested for sure.
Mhm.
That would be, and it's really, I know people have heard about it. I know, hopefully, they like listening.
Thank you.
Thanks so much. I know it's been a long day. Aisha's going to go last, but before she comes up, I think we all owe her an enormous debt of gratitude for picking this beautiful location, this city, this hotel, and doing the lion's share. She did like 99% of the organizing, as assisted by Rob. And I think things have gone extremely smoothly, and we've all been so delighted to get to see one another in person finally. So big round of applause for Aisha and also for Rob and his team.
I'm getting to the point of the day when I'm starting to clap for myself. I'm like, okay, yay, we're almost done. You guys, I thank you everybody for your energy and your participation and coming out. I know it's a long trip and I really appreciate it. Really, that's it. I think we have a lot of good agenda items moving forward and a lot of momentum. And thank you again. I unfortunately can't dismiss the board members. You have to stay. All the new board members, all the old board members are excused. But everybody else has to stay for, Madeline will keep us on task, 5 minutes.
It'll be brief.
It's really a meet and greet and pick our next meeting date. Because if we don't pick our next meeting date, we don't meet.